Bowel obstruction is when the normal flow of contents moving through the intestines is interrupted. Bowel obstruction can be defined as partial or complete. Partial obstruction is when gas or liquid stool can pass through the point of narrowing, while complete obstruction is when no substance can pass, and this is defined as obstipation. The causes of bowel obstruction can be either functional or mechanical causes. Functional or adynamic causes disrupt peristalsis, which are the waves that move through the smooth muscle of the bowel walls. Mechanical causes are actual blockages in the large or small intestine of the bowel, and these mechanical causes are the ones that are usually treated surgically. Among mechanical causes, one cause of small bowel obstruction in individuals who have previously undergone surgery are postoperative adhesions. Adhesions are fibrous bands of scar tissue that cause organs to attach to the surgical site or to other organs, causing the lumen of the bowel to get kinked or pinched tight in certain spots. Another cause of small intestinal obstructions is hernia, which is when a portion of the bowel protrudes out of the abdominal cavity and can get trapped or tightly pinched at the point where it pokes out. Large bowel obstructions, on the other hand, are most often due to a volvulus, which is when a loop of the intestine twists upon itself, kinking off the lumen. Sometimes, the volvulus can occur around a mass, like in colorectal cancer. Other mechanical causes of both small and large bowel obstruction include inflammatory bowel disease, which can cause strictures and adhesions, ingestion of a foreign body, which can get lodged along the gastrointestinal tract, and intussusception, which is where a part of the intestine folds into the lumen of an adjacent section of bowel. One unique situation is called a closed-loop obstruction, and it's where the intestine is obstructed at two locations, creating a segment where nothing goes in and nothing comes out. Soon after a bowel obstruction, the air and bowel contents distal to the obstruction get passed, but after that happens, proximal to the obstruction, air and stool can start to accumulate, causing the bowel to dilate, causing cramping abdominal pain. Over time, the bowel walls become edematous, so they stop absorbing any more nutrients and water. Individuals can develop nausea and vomiting, which can cause electrolyte abnormalities and dehydration. Finally, some individuals develop respiratory distress from upward pressure on the diaphragm from their distended abdomen. Now, generally speaking, in small bowel obstruction, vomiting is more common and the pain tends to be periumbilical, cramping, and intermittent, with bouts that last for a few minutes at a time. In large bowel obstruction, vomiting is less common and the pain is lower in the abdomen and bouts of pain are less frequent but last a bit longer. If bowel dilation becomes excessive, or if there's bowel strangulation, the bowel wall can face extreme pressure, causing the blood vessels within the walls to collapse. When that happens, perfusion to the intestine can be compromised, and it can lead to ischemia and eventually necrosis and perforation. When there's progression from cramping to more focal and constant pain, it can indicate localized peritoneal irritation due to a microperforation of the intestine. Alternatively, a large intestinal perforation may cause a sudden relief of pain due to the nerves in the bowel wall no longer being stretched. But then it's usually followed by progressive worsening of pain as generalized peritonitis sets in. Finally, hematochezia can be a sign of colorectal cancer, which can be a cause of bowel obstruction or bowel ischemia. Next up, lab studies include a CBC with differential, as well as a basal metabolic panel including electrolytes, BUN, and creatinine. Leukocytosis with a neutrophil predominance is a specific sign of an underlying inflammatory response, such as inflammatory bowel disease or diverticulitis, while anemia may point to inflammatory bowel disease or colorectal cancer. Individuals with more severe symptoms like fever, tachycardia, hypotension, and altered mental status should have an ABG and a serum lactate, because metabolic acidosis and an elevated lactate level suggest bowel ischemia. Finally, blood cultures should be sent if there are clinical signs of peritonitis or sepsis. Diagnosis of bowel obstruction requires imaging studies, starting with an abdominal X-ray. In bowel obstruction, there are dilated loops of bowel with air fluid levels, which show that both fluid and gas are collecting in the intestines. Usually, the proximal bowel is dilated, and the distal bowel is not. Specific X-ray signs can suggest the cause of bowel obstruction. For example, an apple core sign suggests constriction of the colonic lumen, and it's often due to a ring-shaped colon cancer. Now, if there's bowel perforation, there's free intraperitoneal air, called a pneumoperitoneum, and it requires immediate surgical intervention. In hemodynamically stable individuals who don't need emergency surgery, an abdominal CT scan with contrast, given either orally or through enema, is done next to identify the potential cause of the obstruction. Typical abdominal CT findings include bowel wall thickening, submucosal edema or hemorrhage, and mesenteric edema. Some specific findings that suggest underlying causes include a target sign, showing alternating hypo and hyperdense layers of bowel indicative of intussusception, and the whirl sign, showing rotation of the bowel mesentery, suggesting a volvulus. Abdominal ultrasonography may be useful for individuals with contraindications to CT scanning, like those with contrast allergies, pregnant women, and critically ill individuals who need imaging done at the bedside. Ultrasound can identify fluid-filled distended bowel loops, which generally have a diameter of over 2.5 centimeters. There may be the to and fro sign as the contents move back and forth within a bowel loop because they can't pass through the obstruction, as well as the keyboard sign, showing finger-like projections, which are when the inner mucosal folds of the intestine, called the plica circularis, become thick and prominent. Conservative management consists of supportive care that includes IV fluids, correction of electrolyte abnormalities, and gastrointestinal decompression for individuals with persistent distension, nausea, or vomiting. Gastrointestinal decompression is done with a small flexible nasogastric tube that's inserted through the nose and into the stomach to help empty the dilated bowel. Partial obstruction is initially managed with supportive care, as the obstruction slowly resolves on its own within 5 days. Symptoms are monitored closely, and repeat abdominal x-rays are done to ensure that they are slowly improving. Sometimes, an oral hypertonic water-soluble contrast agent like gastrografin is given to help resolve the partial obstruction more quickly. The way it works is that the hypertonic gastrografin contrast draws fluid into the lumen, decreasing intestinal wall edema and thereby stimulating peristalsis. Usually, 7.5 milliliters is given over 30 minutes, and up to 22.5 milliliters can be given within 2 hours, up to a total dose of 100 milliliters. When bowel obstruction starts to resolve, there's usually a decrease in abdominal distension, passage of gas and stool per rectum, and less nasogastric tube output. If no improvement is seen after 5 days, the individual should have surgical exploration. Individuals with a complicated bowel obstruction, including complete obstruction, closed loop obstruction, or evidence of bowel ischemia, necrosis, or perforation, should have surgical exploration right away. Prophylaxis with broad-spectrum antibiotics covering enteric streptococci coliforms and anaerobes should be administered to those who will undergo surgical exploration. When the obstruction is caused by colon cancer, surgery is typically needed, and the type of surgical approach depends on the stage of the cancer. Early cancers that are confined to the wall of the colon can be surgically resected, whereas those that have spread to nearby lymph nodes are often treated with chemotherapy instead of resection. Unfortunately, metastatic cancers are typically not candidates for curative surgical resection, but individuals may get palliative resection, stenting, or chemotherapy to manage the symptoms. Some individuals may be managed with a stent to open the lumen just enough to decompress the bowel. The two main uses for stenting are as a bridge to surgery in individuals with acute mechanical obstruction by providing preoperative decompression, or as palliation in those with advanced malignant disease who are not surgical candidates. A stent is a wire mesh in the shape of a ring that's placed within the lumen of the bowel at the site of the blockage to force the bowel open, allowing feces to pass through. The stent is typically placed endoscopically using X-ray guidance. This provides about a week of time prior to surgery, during which time fluid and electrolytes can be repleted and a person can be prepared for surgery. This allows surgery to be performed under elective rather than emergent circumstances. Finally, some individuals may need a stoma, which is an artificial opening in the abdomen that's created by cutting the bowel and allowing it to exit in the abdominal region. This allows feces to bypass the rest of the bowel and drain into a pouch. Sometimes, a temporary stoma is created in individuals at risk of anastomotic leak and dehiscence due to ischemia, obesity, prolonged operative time, and having emergency surgery, until a second surgery can be done to reconnect the two ends of the intestines. However, sometimes the ends of the intestines cannot be reconnected if a large chunk of the bowel was resected and a permanent stoma is needed. Alright, as a quick recap. Small bowel obstruction often causes vomiting and periumbilical pain, while large bowel obstruction causes lower abdominal pain. Bowel obstruction can lead to microperforations in the bowel, leading to local peritoneal signs, as well as a sudden relief of pain, followed by a progressive worsening of pain due to a large intestinal perforation. Laboratory studies include a CBC with differential, electrolytes, BUN, and creatinine. Plain abdominal x-rays typically show dilated proximal loops of bowel with air fluid levels, and free intraperitoneal air is usually visible with bowel perforation. CT scan with contrast can help locate the transition point between dilated and non-dilated bowel, and can identify hernias or a mass lesion as well as bowel ischemia. Supportive care includes IV fluids, electrolyte replacement, and gastrointestinal decompression for individuals with significant symptoms. Partial obstruction is managed with supportive care along with gastrographin to help with resolution of symptoms. After 5 days, if no improvement is seen, the individual should have surgical exploration. Individuals with complicated bowel obstruction, including complete obstruction, closed-loop obstruction, bowel ischemia, necrosis, or perforation, should have surgical exploration plus broad-spectrum antibiotic prophylaxis, covering enteric streptococci, coliforms, and anaerobes. Some individuals may need a temporary stoma if they're at risk of anastomotic leak and dehiscence, or a permanent stoma when the ends of the intestines cannot be reconnected.
Bowel obstruction is when the normal flow of contents moving through the intestines is interrupted. The causes of bowel obstruction can be either mechanical or functional, also called ileus. Mechanical obstruction is caused by actual blockages in the large or small intestine, and it can be defined as partial or complete. Partial obstruction is when gas or liquid stool can pass through the point of narrowing, while complete obstruction is when nothing can pass. Functional causes disrupt peristalsis, which are the waves of contraction that move through the small muscles of the bowel wall that pushes food through the intestines. The small and large intestines are tube-shaped structures, where chyme, or food that's been partially digested by the stomach, and stools pass until they're excreted. Now if we zoom into a cross-section of the intestinal wall, it's lined by 4 layers of tissue. First, there is the adventitia, or serosa, which is the outermost layer that faces the abdominal or peritoneal cavity. This is the space between the abdominal wall and the abdominal organs, and it's lined by a peritoneal membrane that contains a thin film of serous fluid. Moving on, there's the muscularis externa, which is smooth muscle that contracts to move food through the bowel. Deep beneath this layer is the submucosa, which has connective tissue as well as glands, blood, and lymph vessels that supply the intestinal wall. And finally, the innermost layer is the mucosa, and it's composed of a few of its own layers. The muscularis mucosae, which has smooth muscle, the lamina propria, which is rich with blood and lymph vessels, and the innermost layer, which is the epithelial lining that faces the lumen. Okay, so let's go over some mechanical causes for bowel obstruction. The most common cause in the small intestine is postoperative adhesions. After a surgery, the scar tissue that forms during the healing process can form fibrous bands that cause organs to attach to the surgical site or to other organs, causing the lumen of the bowel to get kinked or pinched tight in certain spots. Another cause of small intestinal obstruction is hernias, and they can occur when a portion of the bowel protrudes out of the abdominal cavity and can get trapped or tightly pinched at the point where it pokes out. Mechanical causes for large bowel obstructions, on the other hand, are most often due to a volvulus, which is when a loop of intestine twists around itself, kinking off the lumen. Sometimes the volvulus can occur around a mass, like in colorectal cancer. Some mechanical causes of both small and large bowel obstruction include inflammatory bowel disease, which can cause strictures and adhesions, ingestion of a foreign body, which can get lodged along the gastrointestinal tract, and intussusception, which is where a part of the intestine folds into the lumen of an adjacent section of the bowel, kind of like retracting a telescope. This is the most common cause of bowel obstruction in children under the age of 2. Now, regarding functional obstruction, Causes include anything that decreases the smooth muscle contractility. The most common cause is postoperative ileus, which is transient paralysis of the smooth muscle in the intestinal wall, and it's usually caused by trauma during surgery. Other causes include infection or inflammation, such as appendicitis or peritonitis, hypothyroidism, meaning the thyroid gland doesn't produce enough thyroid hormones, and electrolyte abnormalities like hypokalemia, meaning low potassium in the blood, or hypercalcemia, which is high calcium in the blood, or various medications like opioids. So when there's a bowel obstruction, whatever the cause, the bowel contents distal to the obstruction get passed. But after that happens, proximal to the obstruction, gas and stool start to accumulate, causing the bowel to dilate, and then causing the overall abdominal cavity to distend. Over time, all this gas and stool causes pressure inside the bowel lumen to increase, so the intestinal contents push toward the intestinal wall, compressing the mucosal blood and lymphatic vessels. Since the walls of veins and lymphatics are weaker and easier to compress compared to arteries, venous and lymphatic drainage are the first ones to get blocked. The pressure pushes the water in these vessels into the surrounding area, leading to mucosal edema. If pressure inside the lumen gets even higher, it also compresses mucosal arteries, leading to ischemia, or reduced blood flow to the intestinal wall. In turn, ischemia causes hypoxia, or low oxygen supply. At the cellular level, this is accompanied by the production of reactive oxygen species, which can damage DNA, RNA, and proteins of the cells in the epithelial layer and lamina propria of the mucosa, leading to cell death, or mucosal infarction. So, when the mucosa becomes damaged and capillary blood vessels in the lamina propria rupture, blood enters the bowel lumen. And all the stool and blood in the lumen becomes a nutritious feast for bacteria that normally reside in the intestines, and they start growing out of control. These bacteria can then get into the intestinal wall, where they get attacked by macrophages rushing into the mucosa. These macrophages then release inflammatory cytokines, like tumor necrosis factor alpha, which cause blood vessels to become more permeable to fluid and to more immune cells, further increasing mucosal edema, inflammation, and damage. The overall result is the compromised ability of the mucosa to absorb food and water, which may lead to dehydration and loss of electrolytes, like sodium, potassium, and chloride. Now, as all these lumen contents continue to build up, intraluminal pressure rises even higher, making the problem even worse if not corrected. And if this pressure becomes high enough, even larger arteries will get compressed, meaning that the arterial supply to more layers of the bowel wall is compromised. In other words, bowel ischemia and infarction extend from just the mucosa to all layers of the bowel wall, known as transmural infarction. This can result in perforation, so there's basically a hole in the bowel wall that connects the lumen to the peritoneal cavity. And all the bacteria that have been accumulating inside the lumen can now easily leak out, causing peritonitis. Now, since the layers of the peritoneum are very rich in blood vessels, large numbers of bacteria from the peritoneal cavity can sneak into the bloodstream, triggering a massive inflammation response called sepsis. In sepsis, blood vessels throughout the body can get leaky, letting the water in blood escape into the interstitial space. If too much fluid is lost, blood volume drops, and so does the blood pressure. This leads to a decrease in the amount of blood reaching vital organs to deliver oxygen, and we call this shock. Ultimately, this can cause organ failure and death. Now, generally speaking, symptoms of bowel obstruction include cramping, abdominal pain, constipation, vomiting, and abdominal distension. In individuals with partial obstruction, symptoms typically appear more gradually and are milder, including abdominal discomfort after meals and constipation. On the other hand, in complete obstruction, symptoms usually appear suddenly and include obstipation, which is a more serious version of constipation where there's a complete inability to pass stool or gas. Now, in small bowel obstruction, vomiting is more common, and the pain tends to be periumbilical, or around the belly button. The pain is often described as cramping, and it's intermittent, with bouts that last for a few minutes at a time. In large bowel obstruction, vomiting is less common. The pain is lower in the abdomen, and bouts of pain are less frequent but can last a bit longer. When there's progression from cramping and vague pains to more focal and constant pain, it can indicate peritoneal irritation due to a perforation of the intestine. Finally, bowel obstruction can cause abdominal distension, which pushes on the diaphragm, making it hard for the lungs to expand. This causes some individuals to develop respiratory distress, presenting with symptoms like shortness of breath, tachypnea, and cyanosis, which is a bluish color of the skin due to poor oxygenation of the blood. They can also develop shock if sepsis is present, with symptoms like fever, fatigue or weakness, tachycardia, and tachypnea. Diagnosis of bowel obstruction begins with auscultation or listening to the bowel sounds with a stethoscope. High-pitched, tinkling sounds typically indicate mechanical obstruction, while the absence of normal bowel sounds suggests functional obstruction. Imaging studies are also important, starting with an upright abdominal X-ray. Dilated loops of bowel with multiple air fluid levels on the X-ray suggest mechanical bowel obstruction. On the other side, generalized uniform distension of the large and small bowel suggests functional bowel obstruction. Free air under the diaphragm means there's perforation, so emergency surgery is needed. Otherwise, we can proceed to an abdominal CT scan with contrast in order to identify the potential cause of the obstruction. Abdominal ultrasonography can be useful for individuals with contraindications to CT scanning, like those with contrast allergies and pregnant females. Most bowel obstructions resolve on their own, so treatment typically focuses on relieving the symptoms. This might involve administering intravenous fluids or nasogastric suction, which is when a tube is inserted through the nose to the stomach to remove the fluid and gases that have built up. If symptoms don't improve or there's complications such as perforation, then surgery might be needed. Alright, as a quick recap, bowel obstruction is when the normal flow of contents moving through the intestines is interrupted. Causes can be mechanical, which can result in partial or complete bowel obstruction, or functional. Complications include dehydration, electrolyte abnormalities, bowel perforation, and peritonitis. Symptoms include cramping, abdominal pain, constipation, abdominal distension, and vomiting. Diagnosis of bowel obstruction requires imaging studies, like X-ray and CT scan with contrast or abdominal ultrasonography. Treatment depends on the cause and severity of the obstruction. There's conservative management, and then there's surgery.
The term volvulus actually comes from the Latin word volvere, which means to roll. So a volvulus is an obstruction caused by a loop of the intestine that rolls or twists around itself and its surrounding mesentery, which is the tissue that attaches the intestine to the back wall of the abdomen. The three most common types of volvulus are a sigmoid volvulus, which happens in the last part of the large intestine leading to the rectum, a cecal volvulus, which happens in the beginning of the large intestine, and a midgut volvulus, which happens in the small intestine. Now, a sigmoid volvulus is the most common type of volvulus, and it can happen in a variety of settings. One classic one being pregnancy, because the growing fetus can cause displacement and twisting of the colon. It can also develop, though, in middle-aged and elderly individuals. This can sometimes happen as a result of chronic constipation, where a big load of stool can act like a pivot point around which the rest of the colon can twist. Hirschsprung disease, which is a disease of the large intestine that causes severe constipation or intestinal obstruction, therefore raises the risk for developing sigmoid volvulus. In addition, there are also abdominal adhesions, where internal scar tissue creates a physical attachment between two parts of the abdomen, which again serves as a pivot point around which the colon can twist. A cecal volvulus is usually found in young adults, and usually happens in individuals who didn't develop their abdominal mesentery normally during fetal development. Since some mesentery contacts might be missing in these individuals, the colon can flop around freely, and any large object, like a baby in pregnancy or a load of stool in someone that's constipated, can act as a pivot point in the cecum and cause the colon to twist. Midgut volvulus is most commonly found in babies and small children, and is the result of abnormal intestinal development in fetuses. In normal fetal development, the digestive tract starts as a straight tube from the stomach to the rectum. For a little while, a part of the intestine protrudes from the abdomen into the umbilical cord. Once the fetus reaches around 10 weeks, though, the intestine pulls back out of the umbilical cord and returns to the abdominal cavity and makes two turns, so that it's no longer a straight tube. Malrotation happens when the cecum and the appendix, which are normally found in the lower right side of the abdomen, stay in the upper right side. Babies with malrotation can later develop twisting of the small intestine, which is a midgut volvulus. In any type of volvulus, a portion of the intestines becomes twisted and it pinches the lumen shut and results in bowel obstruction, which prevents the normal passage of digested food and water. Sometimes the mesentery can get so tightly twisted that blood flow to that part of the intestine is cut off, which leads to infarction or death of the intestinal wall. This can cause a variety of symptoms, ranging from mild bloating and constipation to severe pain and bloody stools. In fact, bowel infarction can also cause the intestinal wall to break down and allow the bacteria in the gut to move into the body, which causes sepsis and the potential for cardiovascular collapse. Abdominal x-rays are usually used to diagnose volvulus. These x-rays show the shape of the volvulus, which can look like a bent inner tube or a coffee bean. A barium enema can also be used to show a bird's beak shape, enlarged at one end and tapered at the other end, which is the point where the bowel's twisted. A sigmoid volvulus is usually treated with sigmoidoscopy, an examination of the sigmoid colon using a set of flexible tubes inserted through the anus. If the tissues look normal and pink, the tubes untwist and decompress the colon to relieve pressure. A similar procedure that goes a bit further in, called a colonoscopy, examines the entire colon and can occasionally be used to resolve a cecal volvulus. But a midgut volvulus can't be treated with a colonoscopy, since it's even further back in the small intestine. Normally, surgery is recommended within 2 days of receiving treatment, or in some cases, surgery should be performed immediately, like if the bowel is severely twisted or if the blood supply is cut off. The normal surgical procedure involves untwisting the intestine if it hasn't been corrected yet, and attaching the intestine up against the abdominal wall to prevent it from twisting in the future. In severe cases, like an infarction, pieces of the intestine have to be removed, a process called bowel resection, before the intestine can be reattached. Alright, as a quick recap. A volvulus is a twist in the intestine and surrounding mesentery, and it's most commonly found in the sigmoid of middle-aged and older adults, the cecum of young adults, and the midgut or small intestine of babies. Volvulus results in bowel obstruction and can sometimes cause infarction or death of the bowel tissues. Volvulus is diagnosed using x-rays and is usually treated with surgery to remove part of the bowel and attach the bowel up against the intestinal wall. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. A colorectal polyp is a small clump of epithelial cells that form a small bump or overgrowth of tissue along the lining of the colon or rectum. The cells lining the colon and rectum are constantly dividing, and typically when there's an overgrowth of tissue, it's benign. But some can become malignant, meaning that the dividing cells can start invading nearby tissues over time. Now, there are various types of colorectal polyps. The most common ones are adenomatous polyps, also called colonic adenomas. And these form when there's a mutation in the adenomatous polyposis coli gene, or APC gene, which is a tumor suppressor gene that regulates cell growth. When the APC gene is mutated, the epithelial cells start to quickly divide, which forms polyps. But even though they're dividing, these polyps only become malignant, meaning they only invade nearby tissues, if there are additional mutations in other tumor suppressor genes like P53 gene or in proto-oncogenes like KRAS. Some people with the genetic condition called familial adenomatous polyposis syndrome, or FAP, are born with a mutation in their APC gene, and they end up developing hundreds or even thousands of polyps in their colon. These people often need to have their entire colon surgically removed, because having so many polyps increases the chance that one cell among all of those polyps will develop another mutation and become malignant. Adenomatous polyps can also be classified histologically, based on their growth pattern as being tubular, where the growth has little holes in it when you're looking at a cross-section of the tissue, or a tube if you imagine it in 3 dimensions, as well as villous, where the growth looks like a little tree with branches. Some adenomatous polyps look like a mix of the two with tubes and tree-like structures and are called tubulovillous. This description is helpful because it turns out that a growth with a more villous growth pattern is more likely to become malignant, and therefore needs more frequent monitoring if it isn't surgically removed. Another classification is based on whether the adenomatous polyp is pedunculated, which means that it's attached to the colon wall by a stalk and therefore able to swing around freely, or sessile, which means that it's firmly attached to the colon wall by its base. It turns out in this case that the sessile adenomatous polyps are more likely to become malignant. Serrated polyps are a second type of polyp, and they get their name because the cells have a characteristic sawtooth appearance under a microscope. Within the DNA of the cells in these polyps, there are specific stretches of nucleotides that are called CpG islands. CpG islands are found in most promoter regions of genes, which are the DNA sequences responsible for the initiation of gene transcription. In the cells that make up serrated polyps, the nucleotides that make up the CpG islands have methyl groups added to them, and this silences the promoters, which in turn silences the genes that the promoters help to get transcribed. Unfortunately, this includes DNA repair genes, so by having them silenced, errors during DNA replication don't get fixed. This can lead to a variety of mutations, including ones that cause cells to rapidly divide, and potentially become malignant as well. It turns out that small serrated polyps are also known as hyperplastic polyps, and are rarely malignant, whereas larger serrated polyps, which are typically flat and sessile, have a greater tendency to become malignant. Another type of polyp are inflammatory polyps, which often follow a bout of ulcerative colitis or Crohn's disease and don't become malignant. A final group are hamartomatous polyps, which are normally made up of a mixture of tissues and have a distorted architecture. Hamartomatous polyps are often associated with genetic syndromes like juvenile polyposis and Peutz-Jeghers syndrome. Risk factors for developing polyps include anything that predisposes towards a genetic mutation, which is likely to happen if there are more cell divisions. So this includes genetic conditions as well as anything that injures the bowel wall, like cigarette smoke, inflammatory bowel disease, and old age itself. Most of the time, polyps don't cause symptoms and are spotted on colonoscopy, which is when a camera looks directly at the colon and rectum. In some cases, though, a polyp can ulcerate, which causes rectal bleeding. Sometimes that bleeding can be very subtle and go unnoticed, but can result in anemia over time. Rarely, if a polyp's really large, it can cause obstructive symptoms like abdominal pain and constipation. A diagnosis of the type of polyp is done by biopsy, and treatment usually involves using a wire loop to cut out the polyp, followed by cauterization to prevent bleeding, which is a procedure called polypectomy, and literally means polyp removal. Part of the bowel may also need to be surgically removed if the polyp is particularly large, or if there are a lot of polyps in that section of the bowel. Fortunately, there's evidence that a healthy diet with lots of green vegetables, legumes, and fruits can help prevent polyps from forming in the first place. Just another reason to eat what your mother serves you. Alright, as a quick recap. There are different types of polyps, and the ones that have the potential to become malignant are the adenomatous polyps and serrated polyps. Typically, polyps are found on colonoscopy and can be removed with a polypectomy.
Colorectal cancer, or CRC, is a malignancy that arises in the large intestines, which includes both the colon and the rectum. It's the most common cancer of the gastrointestinal tract, and a major cause of death and disease around the world. Most colorectal tumors develop due to sporadic mutations, but some are caused by inherited conditions like familial adenomatous polyposis and Lynch syndrome. Individuals at high risk for CRC include those with inflammatory bowel disease, especially ulcerative colitis, hereditary colorectal cancer syndromes, such as familial adenomatous polyposis, and those with a family history of colorectal cancer or adenomatous polyps. Individuals at medium risk for CRC include the elderly and those that smoke, drink alcohol, eat red meat, and are obese. Finally, well-established protective factors include a high-fiber diet full of fruits and vegetables. Sometimes, especially early on, colorectal cancer is asymptomatic, and it's discovered by screening using either stool-based tests or direct visualization. One stool-based test is the guaiac-based fecal occult blood test, or GFOBT, which detects blood in the stool. Another test is the fecal immunochemical test, or FIT. This time, instead of guaiac, there's an antibody that attaches to any hemoglobin that's present in the stool. Finally, there's the FIT DNA test, which combines FIT with a test that detects genes associated with colorectal cancer in the stool, such as mutations in the adenomatous polyposis coli gene, or APC gene. One direct visualization test is a colonoscopy, which is when a camera is inserted retrograde into the colon and rectum using a flexible tube and biopsies are taken. Another one is a flexible sigmoidoscopy, which uses a flexible tube to visualize the rectum and sigmoid colon. Finally, there's CT colonography, or a virtual colonoscopy, which is where CT scans are digitally assembled to produce three-dimensional views of the colon. If a suspicious lesion is seen on a direct visualization test, it should be further investigated using colonoscopy and biopsy. A common example of a suspicious lesion is a colorectal polyp, which is a small bump or overgrowth of tissue along the lining of the colon or rectum. The most common polyps are adenomatous polyps, also called colonic adenomas. Adenomatous polyps can either be pedunculated, meaning that they're attached to the colon wall by a stalk and therefore able to freely swing around, or sessile, which means that they're firmly attached to the colon wall. Sessile adenomatous polyps are more likely to become malignant, so they need to be closely observed. If a polyp is found during a colonoscopy or during a flexible sigmoidoscopy, then a biopsy should also be done to rule out or confirm cancer. On histology, polyps can be tubular, where the growth has little holes within it on a cross-section, or villous, where it looks like a little tree, or tubulovillous, where it's a mix between the two. Among these, villous polyps are the most likely to be malignant. Now, if an adenomatous polyp can't be entirely removed using the colonoscopy, then surgical resection may be needed, especially if it's a polyp that has a high risk for malignancy, like a sessile polyp. Another type of polyp is an inflammatory polyp, and these typically develop after a flare of ulcerative colitis or Crohn's disease, and they usually don't become malignant and don't require excision. A final group are hamartomatous polyps, which are normally made up of a mixture of tissues and have a distorted architecture. Hamartomatous polyps are often associated with genetic syndromes like juvenile polyposis and Peutz-Jeghers syndrome. How we screen for CRC depends on risk and which method is used. For medium risk individuals, one option is to do an annual screening starting at age 45 with GFOBT or FIT. If FIT DNA is used, screening can be done every 1 to 3 years. CT colonography or flexible sigmoidoscopy should be done every 5 years, while colonoscopy, which is the best screening test, should be done every 10 years. With high-risk individuals, screening starts earlier than usual. If an individual has a family history of sporadic CRC, then screening should start at age 40 with a colonoscopy, and it should be repeated every 5 years. Alternatively, a FIT test can be done annually. Individuals with inflammatory bowel disease should get a colonoscopy every year. Typically, screening stops between age 75 and 85, depending on the individual's overall health. Now, these guidelines are a bit different for hereditary colorectal syndromes. Lynch syndrome, which is also called hereditary non-polyposis colorectal cancer, or HNPCC, is the most common cause of inherited CRC. It should be suspected in individuals that develop CRC before age 50, or develop other cancers typically seen in Lynch syndrome like endometrial, ovarian, small bowel, stomach, and renal cancer. Lynch syndrome is caused by a mutation in a DNA mismatch repair gene, or the EpCAM gene. For a definitive diagnosis, the mutations need to be confirmed using genetic testing. Normally, screening for individuals with Lynch syndrome begins at age 20 or 25 every 1 or 2 years using colonoscopy. And females with Lynch syndrome should also get a pelvic examination annually to look for signs of endometrial or ovarian cancer. Familial adenomatous polyposis, or FAP, is an autosomal dominant genetic disease caused by mutations in the adenomatous polyposis coli gene, or APC gene. There's a classic form of FAP that is characterized by more than 100 colorectal polyps, and an attenuated form of FAP that has fewer than 100 colorectal polyps. FAP can also cause extracolonic symptoms, such as polyps in the stomach and duodenum, desmoid tumors, which are connective tissue tumors, and these are usually localized in the abdomen, and sometimes individuals can present a nodular thyroid that in some cases may develop into thyroid cancer. There are also some variants of FAP, like Gardner syndrome, which causes multiple colorectal polyps as well as osteomas, which are bony growths that develop in the mandible, and soft tissue tumors like epidermoid cysts, fibromas, and desmoid tumors. Another one is Turcot syndrome, which consists of multiple colorectal polyps and brain tumors like medulloblastomas and gliomas. Turcot syndrome can also be associated with Lynch syndrome. Now, the diagnosis of FAP should be suspected in any individual with more than 10 colorectal adenomas, a history of colorectal adenomas with extracolonic manifestations, or with a family history of FAP. In these situations, genetic testing is done to look for an APC gene mutation. Screening for individuals with classic FAP begins around age 10 with an annual flexible sigmoidoscopy or colonoscopy. With classic FAP, the risk for eventually developing CRC is about 100%. And since not every polyp can be removed endoscopically, a colectomy is typically recommended. For individuals with attenuated FAP, CRC typically develops later in life. So, screening begins at age 25 and is done every 1 to 2 years using colonoscopy. Now, in addition to identifying CRC through screening, it may also get diagnosed in individuals that develop symptoms like abdominal pain, unintentional weight loss, and a change in bowel habits, specifically diarrhea alternating with constipation. Left-sided CRC is associated with pencil-shaped stools, and rectosigmoid cancer is associated with hematochezia and tenesmus. CRC can also cause complications like peritonitis or intestinal obstruction. On the physical examination, sometimes an abdominal or rectal mass can be felt. A classic sign of metastasis is periumbilical adenitis, And in terms of organs, metastasis usually goes to the liver, followed by the lungs and the bones. The workup for CRC includes a CBC, which can show anemia due to iron deficiency from blood loss, an ALT and AST, which may be elevated if there is liver metastasis, and a BUN and creatinine to assess renal function because a large tumor can compress the ureters and cause renal impairment. The tumor marker carcinoembryonic antigen, or CEA, is often elevated in CRC. A barium enema can be useful as well. That's where a liquid is injected into the rectum through a small tube, and an X-ray is taken to look for abnormalities in the large intestines. Classically, colorectal cancer will show an apple core sign, which shows constriction of the lumen, most often in the descending colon. A colonoscopy with biopsy is the gold standard for diagnosing CRC. Most commonly, the mass is exophytic, or polypoid, meaning that the tumor grows into the lumen. But it can also be endophytic, or ulcerative, meaning that the tumor destroys healthy tissue and creates an erosion into the intestinal wall. Finally, some tumors are considered diffuse and infiltrative, which is where they grow within the intestinal wall, causing it to become thick and rigid. All of these tumor types can be friable and necrotic, and can bleed easily. On histology, most CRCs are adenocarcinomas, meaning that they arise from the cells lining the intestinal glands. Once the diagnosis of a CRC is confirmed, the next step is to obtain a CT scan of the chest, abdomen, and pelvis to see if there's lymph node involvement, or if there are any metastases. Sometimes, an MRI of the liver is specifically done to look for lesions. CRC is staged accordingly to the tumor node metastasis, or TNM system, into 5 stages. Stage 0 is carcinoma in situ, meaning that the tumor has not grown beyond the mucosa. Stage 1 is when the tumor has grown beyond the mucosa but has not spread to lymph nodes or distant organs, and this usually includes cancers that were part of a polyp. Stage 2 is when the tumor has invaded the whole colonic or rectal wall, and may have reached nearby organs or tissues, but still hasn't spread to lymph nodes or distant organs. Stage 3 is when the tumor has spread to lymph nodes, but still hasn't spread to distant organs. Finally, stage 4 is metastatic, meaning that the tumor has spread to distant organs. Treatment for colorectal carcinoma depends on the stage of the cancer. For stage 0 and 1, surgical resection of the tumor is usually curative. For stage 2, a partial colectomy may be needed, along with removing the nearby lymph nodes. Adjuvant chemotherapy, meaning chemotherapy after surgery, is recommended when the cancer has a high risk of recurrence. An example of this is when the CRC obstructs or causes a perforation in the colon, or CRC that develops near large blood vessels. For CRC stage 3, a partial colectomy and surgical removal of the nearby lymph nodes is recommended, along with adjuvant chemotherapy. Chemotherapy typically includes the FOLFOX regimen, which consists of folinic acid, or leucovorin, 5-fluorouracil, and oxaliplatin, or FOLFIRI regimen that consists of folinic acid, or leucovorin, 5-fluorouracil, and irinotecan. One additional regimen is called CAPOX, and it's formed by capecitabine and oxaliplatin. In individuals that are severely ill and cannot undergo surgery, radiation therapy with or without chemotherapy may be an option. For CRC stage 4, neoadjuvant chemotherapy may be done to shrink the tumors before surgically resecting the CRC, along with any metastasis in the liver or in the lung. If the CRC blocks the colon, then a diverting colostomy, which is when the colon is cut above the location of the CRC and attached to an opening in the skin to allow waste to go out, or even a colectomy, which is a total removal of the colon, may be needed. Now, if CRC has spread widely and surgical resection is no longer an option, then chemotherapy is the main treatment. Alright, as a quick recap. In colorectal cancer, for medium risk individuals, screening starts at age 45, and it can be done using GFOBT or FIT annually, FIT DNA every 1 to 3 years, flexible sigmoidoscopy or CT colonography every 5 years, or colonoscopy every 10 years. For high-risk individuals, if there's a family history of sporadic CRC, then screening should start at age 40 using colonoscopy every 5 years. If there's inflammatory bowel disease, then a colonoscopy with biopsy should be done every year. If Lynch syndrome is suspected, genetic testing for the MMR or EpCAM genes should be done. And screening here begins at age 20 and is done every 1 to 2 years using colonoscopy. If FAP is suspected, genetic testing for the APC gene should be done, and screening begins at age 10 and is performed annually using colonoscopy. In individuals with symptoms of CRC, the workup includes lab work and a barium enema, which may show the apple core sign. The gold standard for diagnosis is a colonoscopy with biopsy, and typically the CRC is an adenocarcinoma. After the diagnosis is confirmed, staging is done using a CT scan. Based on the TNM system, CRC has 5 stages. For CRC stage 0 and 1, a surgical resection of the tumor is usually curative. For CRC stage 2, a partial colectomy may be needed, along with adjuvant chemotherapy. For stage 3, surgical resection including the nearby lymph nodes and adjuvant chemotherapy is recommended. For stage 4, a surgical resection may be done to remove the tumor and metastasis in the liver or lung, but if surgery is not an option, then chemotherapy is the main treatment. If complications appear, then a colectomy or a diverting colostomy may be needed. Finally, chemotherapy regimens include FOLFOX, FOLFIRI, or CAPOX.
Colorectal cancer most commonly refers to adenocarcinoma, and it's usually located in the colon, but it can be found in the rectum as well. The presentation of colorectal cancer is not always clear, so early detection depends on screening. Staging is based on the TNM classification, meaning that tumor size, lymph node invasion, and the presence of metastasis are taken into account when making a treatment plan. When assessing a patient with signs and symptoms suggestive of colorectal cancer, you should first perform an ABCDE assessment to determine if your patient is stable or unstable. If the patient is unstable, start acute management and stabilize the airway, breathing, and circulation. Next, obtain IV access and initiate IV fluids for resuscitation. Finally, be sure to monitor their vital signs, including pulse oximetry, blood pressure, and heart rate. Once these important steps are done, you should determine what caused their instability. Tumors located on the descending colon are generally infiltrating masses, meaning they tend to be ring-shaped and involve the whole circumference of the colonic wall. This causes luminal narrowing, referred to as napkin ring constriction or apple core lesions, because of their appearance on imaging. What's important is that these lesions can lead to an obstruction, which can result in bowel necrosis and perforation. These patients typically have a history of abdominal pain, nausea, and vomiting, and will also have changes in bowel habits, as well as small caliber or narrow stools described as pencil thin. On a physical exam, you might find abdominal distension and signs of peritonitis, like rebound pain and guarding. Finally, labs might show leukocytosis. Based on these findings, you should suspect obstruction or perforation caused by the tumor. Okay, now that we have a diagnosis in mind, let's talk about confirming your suspicion. Your next step is to order an upright abdominal X-ray. You might see large bowel dilatation, which indicates obstruction, and pneumoperitoneum, which means that perforation has occurred. If this is the case, call the surgical team for an emergent laparotomy with resection and send it to pathology, which will provide the final diagnosis. Okay, before discussing pathology results, let's go back to H&P to talk about another way colorectal cancer might cause instability. As they grow, some tumors become ulcerated and have fragile blood vessels. If these vessels burst, they may cause acute bleeding. These patients typically present with rectal bleeding and abdominal pain and may have a history of changes in bowel habits. Additionally, on digital rectal exam, you might see gross blood, and low rectal masses can sometimes be palpated. Finally, labs might show anemia. Based on these findings, you should suspect acute GI bleed caused by a colorectal tumor. At this point, you should immediately address the acute bleed and stabilize the patient. The next logical step is to confirm your diagnosis. To do this, order a colonoscopy with a biopsy. Colonoscopy might reveal overlaying erosion or ulceration, friable mass, synchronous lesions, and active bleeding. If you see these signs, that would mean that the patient has a tumor that caused bleeding. The next step is to get a biopsy to assess the pathology results and determine if the mass is malignant or benign. Okay, let's take a look at the pathology results for both patients with perforation and those with active bleeding. Biopsy showing malignancy leads to a diagnosis of colorectal cancer. However, if there's no malignancy, consider an alternative diagnosis. All right, now that unstable patients are diagnosed, let's talk about stable patients. The first step here is to obtain a focused history and physical, as well as labs like CBC. Now, patients might present with or without obvious symptoms of colon cancer. First up, symptomatic patients typically report changes in bowel habits, rectal bleeding, and weight loss. On a physical exam, you might find a palpable abdominal mass, abdominal distension, or tenderness. On a digital rectal exam, you might see gross blood or palpate low rectal masses. Finally, labs might show signs of anemia. On the other hand, asymptomatic patients might come for several reasons. First, they might have a positive screening fecal occult blood test or fecal immunochemical test. Then they might come in because of a positive screening colonoscopy. Finally, they might have iron deficiency anemia requiring further workup. In any case, a physical exam is typically unremarkable, while labs might also show signs of anemia. Here's a high-yield fact. Some colorectal cancers arise from genetic mutations that can be associated with cancer syndromes. Therefore, be sure to assess for a family history of syndromes like familial adenomatous polyposis, Peutz-Jeghers syndrome, juvenile polyposis syndrome, Gardner syndrome, Turco syndrome, and Lynch syndrome. Okay, with both symptomatic and asymptomatic patients, you should get a colonoscopy with biopsy to find the cause of their symptoms or positive screening tests. Colonoscopy is the most accurate diagnostic test since it allows to localize and biopsy lesions throughout the large bowel, detect synchronous neoplasms, and remove polyps. If a full colonoscopy can't be performed because of obstruction, they may need surgical intervention to resect the obstructing mass, and the surgeon can do a colonoscopy in the operating room if needed. Logically, if there are no masses or signs of colorectal cancer on colonoscopy, or if the biopsy results are negative, consider an alternative diagnosis. Now, the vast majority of colorectal cancers are endoluminal masses that arise from the mucosa and protrude into the lumen. They may be exophytic or polypoid in nature and may be friable, necrotic, or ulcerated with associated bleeding. Additionally, the biopsy is positive for malignancy. Once the diagnosis of colon cancer is made, you can move on to T&M staging with the CT of the chest, abdomen, and pelvis. Cancer staging is based on the T&M system, which stands for tumor size and extent, spread to lymph nodes, and metastasis, or spread to distant parts of the body. The treatment depends on the T&M stage. In general, early-stage cancers can be resected with surgery, while advanced-stage cancers may require different combinations of chemotherapy, radiation, and surgery when possible. Next to T&M staging, you should obtain carcinoembryonic antigen, or CEA, to get a baseline, which will help you follow if the treatment is working or not down the line, as well as if there's a recurrence. Okay, let's see how the staging influences the treatment. The main thing to determine is whether or not there are distant metastases. If there are no distant metastases, surgical resection is the treatment of choice. Before getting the surgery, check if the tumor is small and localized, meaning it's limited to the inner surface of the bowel, involving only the mucosa and submucosa layers, or locally advanced, meaning the tumor is spreading to nearby organs or lymph nodes. Small, localized tumors can go straight to surgical resection. In addition to surgery, it's important to send the resected mass for pathologic confirmation of clear margins and evaluation of the surrounding lymph nodes. If the margins are not clear, or there are cancer cells in the lymph nodes, the patient should be started on adjuvant chemotherapy after resection to take care of any remaining cancer cells. On the other hand, locally advanced tumors first require neoadjuvant therapy. This means that they will be treated with chemotherapy or chemoradiation to try and shrink the tumor and destroy any cancer cells in the lymph nodes. After neoadjuvant therapy, they can get surgical resection, and if needed after that, adjuvant chemotherapy. Okay, let's go back to staging and talk about patients with distant metastases. If there are distant metastases, some cases might still be considered resectable. This includes patients with limited metastases to the liver or lungs. In this case, the patient can go directly to surgical resection of the primary tumor and metastases. Unfortunately, most cases are considered unresectable, so they should be started on chemotherapy. Once the full course of chemotherapy is complete, you can obtain a repeat CT or MRI to assess if the tumor has responded to it. This is termed restaging. If the areas of metastases shrunk enough that they would have been considered resectable originally, and the patient is a surgical candidate from a performance status standpoint, the next step is surgical resection of the tumor and any metastatic disease. However, if they don't respond to treatment, you can switch to second-line chemotherapy regimens or immunotherapy. In addition, start supportive care and consider palliative care for the patient. Here's a clinical pearl. Even if there's unresectable metastatic disease, if the patient is at high risk for obstruction or bleeding, palliative surgery can be considered even prior to chemotherapy. Now let's go back to the colonoscopy. If the tumor is found in the rectum, you can confirm the diagnosis of rectal cancer. On colonoscopy, the mass looks the same as colon cancer, so it's endoluminal, exophytic, and polypoid, with possible bleeding and necrosis, as well as positive biopsy for malignancy. As before, the next step involves T&M staging with CT of the chest, abdomen, and pelvis. Additionally, an MRI of the pelvis should be obtained for rectal cancer in order to locally stage the depth of transmural invasion, assess the presence or absence of invasion into adjacent structures, and note the presence of any perirectal nodal involvement. In patients that can't have an MRI, such as those with a pacemaker, transrectal ultrasound can be used for staging depth of invasion and nodes. Finally, order CEA to get a baseline value. Let's first go over treatment for patients with no distant metastases. Rectal tumors that are small and localized can be resected through endoscopic transanal excision, local excision, or surgical resection. On the other hand, locally advanced tumors require neoadjuvant therapy before anything else. Once the course of treatment is complete, you should assess its effect with proctoscopy and possibly another MRI to restage the tumor. Now, if there's a positive response, the tumor does not significantly increase in size, and there is no evidence of new metastatic disease, call the surgical team for possible resection. After surgery, if margins are not clear or there are cancer cells in the lymph nodes, the patient should be started on adjuvant chemotherapy. Lastly, let's go over patients with distant metastases. Again, some cases might still be considered resectable, including patients with limited metastases to the liver or lungs, so they can get surgical resection of the primary tumor and metastases. On the other hand, unresectable cases should be started on chemotherapy. Once the full course of chemotherapy is complete, you can assess the response by restaging the tumor. If there's a positive response, meaning the areas of metastases shrunk enough, the next step is surgical resection. However, if there's minimal or no response to treatment, consider switching to second-line chemotherapy regimens or immunotherapy, as well as supportive and palliative care. All right, as a quick recap, colorectal cancer most commonly refers to adenocarcinoma. The presentation of colorectal cancer is not always clear, so early detection depends on screening. Unstable cases may occur due to obstruction or perforation, which should be assessed with an abdominal x-ray followed by emergent laparotomy and resection for excisional biopsy, or due to acute GI bleed, which should be addressed and then evaluated with colonoscopy and biopsy. Once the complication of colorectal cancer is managed, biopsy results should be assessed to confirm the diagnosis. When it comes to stable patients, they can go straight to colonoscopy and biopsy to make a diagnosis. Colorectal cancer should be staged with CT of the chest, abdomen, and pelvis, and treated according to the T&M stage. In general, small, localized tumors can be resected with surgery, while locally advanced tumors typically need neoadjuvant therapy before surgical resection. After surgery, if margins are not clear, or there are cancer cells in the lymph nodes, start adjuvant chemotherapy. Lastly, patients with distant metastasis may require different combinations of chemotherapy, radiation, and surgery when possible, as well as supportive and palliative care.
Colorectal carcinoma, also known as colon cancer, is when malignant or cancerous cells arise in the large intestines, which includes the colon and rectum. It's the most common type of cancer of the gastrointestinal tract, and a major cause of death and disease around the world. The large intestine is found in the abdominal cavity, which can be thought of as having two spaces, the intraperitoneal space and the retroperitoneal space. The intraperitoneal space contains the first part of the duodenum, all of the small intestines, the transverse colon, sigmoid colon, and the rectum. The retroperitoneal space contains the distal duodenum, ascending colon, descending colon, and anal canal. So the large intestines essentially weave back and forth between the intraperitoneal and retroperitoneal spaces. Now, the walls of the gastrointestinal tract are composed of 4 layers. The outermost layer is called the serosa for the intraperitoneal parts, and the adventitia for the retroperitoneal parts. Next is the muscular layer, which contracts to move food through the bowel. After that is the submucosa, which consists of a dense layer of tissue that contains blood vessels, lymphatics, and nerves. And finally, there's the inner layer of the intestine, called the mucosa, which surrounds the lumen of the gastrointestinal tract, and comes in direct contact with digested food. The mucosa has invaginations called intestinal glands, or colonic crypts, and it's lined with large cells that are specialized in absorption. Most colorectal carcinomas are adenocarcinomas, meaning that they arise from the cells lining the intestinal glands. Most cases of colorectal tumors happen because of sporadic mutations, but a small number are caused by known genetic mutations that run in a person's family. An example of this is the adenomatous polyposis coli gene, or APC gene, which is a tumor suppressor gene. Normally, the APC protein identifies when a cell is accumulating a lot of mutations and forces it to undergo apoptosis, or programmed cell death. But when the APC gene is mutated, the mutated bowel cells don't die, and instead some start dividing uncontrollably, giving rise to polyps. Over time, these polyps might accumulate more mutations in other tumor suppressor genes, like the KRAS gene or the P53 gene. And ultimately, it might become a malignant tumor, meaning that the cells might be able to invade neighboring tissues. Another well-known example are genetic mutations in DNA repair genes, which help fix up mutations in cellular DNA. When they're out of action, though, cells accumulate mutations and over time can develop into polyps, and eventually adenocarcinomas. So, broadly speaking, adenocarcinomas are the malignant evolution of polyps, and polyps arise when cells start dividing faster than usual. There are many different types of polyps, and some are more prone to becoming malignant. Those are called premalignant or neoplastic polyps. And these premalignant polyps can be classified into adenomatous and serrated, according to how they look under the microscope. Typically, adenomatous polyps have an APC mutation, and the cells look like normal colonic mucosa cells. whereas serrated polyps have defects in DNA repair genes and have a sawtooth appearance. When tumors become cancerous, they can be categorized into stages. Stage 0 is carcinoma in situ, meaning that the tumor has not grown beyond the mucosa. Stage 1 is when the tumor has grown beyond the mucosa, but has not spread to lymph nodes or distant organs. Stage 2 is when the tumor has invaded the whole colonic or rectal wall, and may have reached nearby organs or tissues, but still has not spread to lymph nodes or distant organs. Stage 3 is when the tumor has spread to lymph nodes, but still hasn't spread to distant organs. Finally, stage 4 is metastatic, meaning that the tumor has spread to distant organs. The most common site of metastasis for colon cancer is the liver, and for rectal cancer it's the lungs. There are some non-modifiable risk factors for colorectal cancer, like being an elderly male and having inflammatory bowel disease. But there are also some modifiable risk factors as well, like smoking cigarettes, eating a lot of red meat, not eating a lot of fiber, and being obese. Colorectal cancers are also associated with specific disorders like familial adenomatous polyposis, as well as hereditary non-polyposis colorectal cancer. Initially, colorectal carcinoma is often asymptomatic, but as the disease progresses, symptoms can develop depending on the tumor's location. Tumors in the ascending or right colon generally grow outward, beyond the surface of the mucosa, and that can cause vague abdominal pain and weight loss. Typically, these tumors don't cause bowel obstruction, which means that they can grow quite large before causing symptoms, and that also means that there's often a late diagnosis. These tumors can ulcerate and bleed, and over time the bleeding can lead to iron deficiency anemia. Tumors located on the descending or left colon are generally infiltrating masses, meaning that they tend to be ring-shaped masses that involve the whole circumference of the colonic wall. This causes lumen narrowing, referred to as napkin ring constriction, so symptoms of bowel obstruction typically happen early on. Bowel obstruction can cause colicky abdominal pain and blood-streaked stools, called hematochezia. Diagnosis of colorectal cancer typically requires colonoscopy, which is when a camera is inserted retrograde into the colon and rectum to take pictures of abnormal-looking polyps and get a biopsy. In addition, fecal occult blood testing is often done to look for evidence of gastrointestinal bleeding. Typically, in colorectal cancer, there's an elevation in the tumor marker CEA, which is a glycoprotein involved in cell adhesion. This, however, is not a very specific finding. A barium enema can be useful as well, and that's where a liquid is injected into the rectum through a small tube, and an X-ray is taken to look for abnormalities in the large intestines. On a barium enema, a classic sign of colorectal cancer is the apple core sign, which shows the constriction of the lumen, most often in the descending colon. To identify colorectal cancer early, routine colonoscopy and fecal occult blood tests can be done to look for neoplastic polyps or early carcinomas so that they can be removed at an early stage. This is particularly important for individuals with relatives that have colorectal cancer, and for those with disorders like familial adenomatous polyposis and hereditary non-polyposis colorectal cancer. Treatment for colorectal cancer depends on the stage of the cancer. Early cancers that are confined to the wall of the colon are often surgically resected, and those that have spread to nearby lymph nodes are often treated with chemotherapy. Unfortunately, metastatic cancers are typically incurable, but sometimes chemotherapy or surgery can be used to ease symptoms. Alright, as a quick recap. Colorectal carcinoma is a very common and deadly cancer that affects the large intestines. The majority of cases are sporadic and do not have a clear cause, but modifiable risk factors include smoking cigarettes, eating a lot of red meat, not eating a lot of fiber, and being obese. Symptoms can vary based on the tumor's size and location. Tumors of the right colon generally don't cause bowel obstruction, and instead can cause occult bleeding, which can lead to iron deficiency anemia. Tumors of the left colon, on the other hand, are generally ring-shaped masses, which can cause bowel obstruction, with constipation as well as abdominal pain.
Hey guys! guys, thanks so much for watching this video on colorectal carcinomas. Hopefully it was helpful for you, especially when differentiating between the tumors on the right and left side of the colon. If you guys were interested in this video and want to see some more, you can always head on over to osmosis.org and check out the other videos we have, flashcards, and other questions too. People who were involved in making this video were Vince, who did the illustration, Tanner, who did the voiceover, yours truly, who did the editing, Antonella, who wrote the script, and Rishi and Yifan, who edited the script. Thanks so much for watching, and I'll catch you next time. Bye!
With familial adenomatous polyposis, or just FAP, familial refers to the fact that the disease runs in the family. And adenomatous polyposis refers to the fact that people affected develop multiple polyps that arise from the glands in the large intestine, which includes the colon and the rectum. Now, the walls of the gastrointestinal tract are composed of 4 layers. The outermost layer is called the serosa. Then there's the muscular layer, which contracts in a synchronized way to move food through the bowel. Then there's the submucosa, which consists of a dense layer of tissue through which blood vessels, lymphatics, and nerves run and branch into the mucosa and muscular layer. Finally, the inner lining of the intestine is called the mucosa, and it surrounds the lumen of the gastrointestinal tract, and comes into direct contact with digested food. The mucosa is organized as invaginations, called the intestinal glands or colonic crypts, lined with large cells that are specialized in absorption. Familial adenomatous polyposis is caused by an autosomal dominant mutation in the adenomatous polyposis coli gene, or APC gene on chromosome 5q, which is a tumor suppressor gene. Tumor suppressor genes stop cells from dividing uncontrollably. But if the gene is mutated in the cells without a functioning APC gene, then the intestinal gland cells are more likely to accumulate mutations and start dividing faster than usual, ultimately giving rise to polyps, which are benign outgrowths of intestinal gland tissue. Even though for any single polyp, the chance that it evolves into cancer is generally pretty low, polyps might accumulate additional mutations in other genes, like the p53 gene, which is another tumor suppressor, or KRAS gene, which is a proto-oncogene. And with enough mutations, a cell might become completely unregulated, and might start invading nearby tissue and become malignant. Polyps can be classified by their gross appearance. Some are flat, which means they don't protrude into the lumen and are flat up against the mucosa. Others are pedunculated, which means that they do protrude into the lumen and remain attached to the wall by a stalk, just like a mushroom. And some are sessile, which means that they also protrude into the lumen, but they have their base firmly attached to the mucosa. People with familial adenomatous polyposis develop a specific kind of polyp, called adenomatous polyps, or simply adenomas. And they're usually pedunculated or sessile. Under the microscope, the cells look like normal colonic mucosa cells. Now, there are 3 types of adenomas based on histology: tubular, with little hollow tubes in it, villous, with tiny tree-like branches, and tubulovillous, which look like a mix of the two with hollow tubes and tree-like branches. Tubular adenomas are the most common type, and have less malignant potential than villous adenomas, while tubulovillous adenomas have intermediate malignant potential. In familial adenomatous polyposis, polyps usually start to develop during puberty, and by the age of 30, a person might have hundreds to thousands of them, mostly in the descending colon and rectum. Because they have so many polyps, there's a pretty good chance that some of them will accumulate additional mutations and become malignant. By the age of 40, most individuals will develop colorectal cancer, and by the age of 50, all of them will have colorectal cancer. Familial adenomatous polyposis might be associated with extraintestinal manifestations like jaw cysts, sebaceous cysts, or cysts of the skin, and osteomas, which are benign bone tumors. In particular, the combination of polyposis, osteomas, and sebaceous cysts is known as Gardner syndrome. Some individuals develop attenuated familial adenomatous polyposis, or AFAP, which is like a milder version of familial adenomatous polyposis. People with attenuated familial adenomatous polyposis typically end up with fewer than 100 polyps, and these are typically in the ascending colon. Also, the time course for when individuals develop polyps in cancer is less aggressive compared to familial adenomatous polyposis. Most people with familial adenomatous polyposis don't initially have symptoms. Over time, though, if a polyp gets big enough to obstruct the intestine, it can cause abdominal pain and constipation. Also, some polyps can ulcerate and cause gastrointestinal bleeding, which can lead to iron deficiency anemia in the long run. Diagnosis is usually done with colonoscopy, which is when a camera is inserted into the rectum and colon. And if there's a polyp, then a small biopsy is usually taken. Fecal occult blood testing can also be done to look for gastrointestinal bleeding. Ultimately, genetic testing has to be done to confirm the diagnosis of familial adenomatous polyposis. Individuals need to be monitored regularly for signs of colorectal cancer. The only treatment option is prophylactic colectomy, which means surgically removing the part of the colon that has adenomas before they evolve into carcinomas. Oftentimes, the entire colon has to be removed. Alright, as a quick recap. Familial adenomatous polyposis is an autosomal dominant condition caused by a mutation of the APC gene. People affected develop a lot of adenomatous polyps along the large intestine, which ultimately evolve into colorectal carcinoma. For this reason, they have regular colonoscopic monitoring, and sometimes have a prophylactic colectomy.
In juvenile polyposis syndrome, young children develop multiple polyps throughout the gastrointestinal tract, especially in the large intestine. And unfortunately, some of these polyps can develop into colon cancer at some point in their life. The large intestine is found in the abdominal cavity, which can be thought of as having two spaces, the intraperitoneal space and the retroperitoneal space. The intraperitoneal space contains the first part of the duodenum, all of the small intestines, the transverse colon, sigmoid colon, and the rectum. The retroperitoneal space contains the distal duodenum, ascending colon, descending colon, and anal canal. So, the large intestines essentially weave back and forth between the intraperitoneal and retroperitoneal spaces. Now, the walls of the gastrointestinal tract are composed of 4 layers. The outermost part is the serosa for the intraperitoneal parts and the adventitia for the retroperitoneal parts. Next is the muscular layer, which contracts to move food throughout the bowel. After that is the submucosa, which consists of a dense layer of tissue that contains blood vessels, lymphatics, and nerves. And finally, there's the inner lining of the intestine called the mucosa, which surrounds the lumen of the gastrointestinal tract and comes into direct contact with digested food. The mucosa has invaginations called intestinal glands or colonic crypts, and it's lined with large cells that are specialized in absorption. In juvenile polyposis syndrome, there's an autosomal dominant mutation in the SMAD4 gene, which encodes a protein that's part of a pathway that induces apoptosis, or programmed cell death. Blech. Without a functioning SMAD4 gene, the gastrointestinal cells that mutate are more likely to escape having to undergo apoptosis, and instead they simply divide faster than usual, ultimately giving rise to polyps, which are benign outgrowths that arise along the gastrointestinal tract, mostly in the colon. Some polyps then go on to accumulate additional mutations in other tumor suppressor genes, like the p53 gene, and at that point, they might evolve into cancer. The chance for any single polyp to develop into cancer is generally pretty low, but people with juvenile polyposis syndrome have so many polyps that they have a higher risk of cancer because the chance that a single one might turn into a cancer is significant. In fact, many individuals with juvenile polyposis syndrome develop cancer by age 45. Usually it's colorectal cancer, but the SMAD4 gene is expressed in other tissues, and they sometimes develop cancers of the small intestine, stomach, and pancreas as well. Polyps can be classified by their gross appearance. Some are flat, which means that they don't protrude into the lumen and are flat up against the mucosa. Some are pedunculated, which means that they do protrude into the lumen and remain attached to the wall by a stalk, just like a mushroom. And some are sessile, which means that they also protrude into the lumen, but have their base firmly attached to the mucosa. People with juvenile polyposis syndrome develop hamartomatous polyps, sometimes just called hamartomas, and these are either sessile or pedunculated. Some individuals with juvenile polyposis syndrome also have congenital malformations, like macrocephaly, which is an abnormally large head, or hypotonia, which is when there's low muscle tone and strength. Individuals with juvenile polyposis syndrome often don't have any symptoms. However, if a polyp becomes big enough to obstruct the intestine, it can cause abdominal pain and constipation. Some polyps can also ulcerate and cause gastrointestinal bleeding, which can lead to iron deficiency anemia in the long run. Diagnosis of juvenile polyposis syndrome typically requires colonoscopy, which is when a camera is inserted retrograde into the colon and rectum and takes pictures of abnormal-looking polyps, and a biopsy. The presence of hamartomas is key in making the diagnosis. In addition, fecal occult blood testing is often done to look for evidence of gastrointestinal bleeding. Ultimately, genetic testing has to be done to look for a mutation in the SMAD4 gene. It's important for individuals with juvenile polyposis syndrome to have frequent endoscopies to screen for colon cancer. Some individuals also undergo prophylactic surgery, which means removing the part of the intestine that has the hamartomas before they evolve into carcinomas. In addition, these individuals also need to be monitored regularly for signs of cancer in other organs like the small intestines, stomach, and pancreas. Alright, as a quick recap. Juvenile polyposis syndrome is an autosomal dominant condition caused by mutation of the SMAD4 gene. Generally, affected children start developing multiple hamartomas throughout the gastrointestinal tract, and are at high risk of developing colon cancer at some point in their lives. For this reason, people with juvenile polyposis syndrome need regular endoscopic monitoring, and sometimes they have prophylactic surgery.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Peutz-Jeghers syndrome, named after Dr. Jan Peutz, who first described it, as well as Dr. Harold Joseph Jeghers, who later reported on it, is a rare autosomal dominant condition in which individuals develop polyps throughout their gastrointestinal tract, as well as dark spots called melanotic macules in their mouth, lips, genitalia, palms, and soles. The large intestine is found in the abdominal cavity, which can be thought of as having two spaces, the intraperitoneal space and the retroperitoneal space. The intraperitoneal space contains the first part of the duodenum, as well as all of the small intestines, the transverse colon, sigmoid colon, and the rectum. The retroperitoneal space contains the distal duodenum, ascending colon, descending colon, and anal canal. So the large intestines essentially weave back and forth between the intraperitoneal and the retroperitoneal spaces. Now, the walls of the gastrointestinal tract are composed of 4 layers. The outermost layer is called the serosa for the intraperitoneal parts, and the adventitia for the retroperitoneal parts. Next is the muscular layer, which contracts to move food through the bowel. After that is the submucosa, which consists of a dense layer of tissue that contains blood vessels, lymphatics, and nerves. And finally, there's the inner lining of the intestine called the mucosa, which surrounds the lumen of the gastrointestinal tract and comes into direct contact with digested food. The mucosa has invaginations called intestinal glands or colonic crypts, and it's lined with large cells that are specialized in absorption. Peutz-Jeghers syndrome is caused by a mutation of the STK11 gene, which is a tumor suppressor gene that codes for a protein called STK11. So, without a functioning STK11 gene, the gastrointestinal cells are more likely to accumulate mutations and start dividing faster than normal, ultimately giving rise to polyps. These polyps are benign outgrowths that arise along the gastrointestinal tract, mostly in the small intestine, but also in the stomach and the large intestine as well. Some polyps then go on to accumulate additional mutations in other tumor suppressor genes, like the KRAS gene and P53 gene, and at that point they might evolve into cancer. The chance for any single polyp to develop into cancer is generally pretty low, but for people with many polyps, like those suffering from juvenile polyposis syndrome, the risk for cancer becomes significant. The STK11 gene is expressed in a number of tissues, so individuals with Peutz-Jeghers syndrome have an increased risk of developing extraintestinal cancers without polyps, like pancreatic, breast, lung, ovarian, uterine, and testicular cancer. Polyps can be classified by their gross appearance. Some are flat, which means that they don't protrude into the lumen from the mucosa. Some are pedunculated, which means that they do protrude into the lumen and remain attached to the mucosa by a stalk, kind of like a mushroom. And some are sessile, which means that they also protrude into the lumen, but there's no stalk and the entire tumor is attached to the mucosa. People with juvenile polyposis syndrome develop hamartomatous polyps, sometimes just called hamartomas. And these are either sessile or pedunculated. People with Peutz-Jeghers syndrome also have flat, dark, mucocutaneous spots called melanotic macules, which appear during childhood and often fade as the person gets older. These macules look a bit like freckles, but arise in different areas, like the mouth, lips, genitalia, palms, and soles. Individuals with Peutz-Jeghers syndrome often don't have any symptoms. If a polyp becomes big enough to obstruct the intestine, though, it can cause abdominal pain and constipation. Some polyps can also ulcerate and cause gastrointestinal bleeding, which can lead to iron deficiency anemia in the long run. Diagnosis of Peutz-Jeghers syndrome is usually suspected in individuals with melanotic macules, and typically requires colonoscopy, which is when a camera is inserted retrograde into the colon and rectum to take pictures of abnormal-looking polyps as well as get a biopsy. The presence of hamartomas is key in making a diagnosis. In addition, fecal occult blood testing is often done to look for evidence of gastrointestinal bleeding. Ultimately, genetic testing has to be done to look for a mutation in the STK11 gene. If cancer is suspected, tumor marker screening in the blood might be done, especially CEA for colon cancer, CA19-9 for pancreatic cancer, and CA125 for ovarian cancer. It's super important for individuals with Peutz-Jeghers syndrome to have frequent endoscopies to screen for colon cancer. Some individuals also undergo prophylactic surgery, which means removing the part of the intestine that has hamartomas before they evolve into carcinomas. Some individuals also get prophylactic surgery for breasts and gonads, but that can affect childbearing. Alright, as a quick recap. Peutz-Jeghers syndrome is an autosomal dominant syndrome caused by mutation of the STK11 gene. It's characterized by multiple hamartomas throughout the gastrointestinal tract, along with melanotic macules in the skin and mucosa, and a high risk for developing malignancy in various organs, including cancers of the gastrointestinal tract, pancreas, breasts, lungs, ovaries, uterus, and testicles. For this reason, people with Peutz-Jeghers syndrome need regular monitoring through endoscopy and imaging techniques, and sometimes have prophylactic surgery. With gastroschisis, gastro refers to the gastrointestinal tract, and schisis refers to separation. So in gastroschisis, the anterior abdominal wall fails to close and remains open or separated throughout fetal development. And this results in a newborn's abdominal organs, often the intestines, protruding out and being exposed to the outside environment. Now, during the 4th week of fetal development, the embryo starts to change shape from a flat, 3-layer disc to something closer to a cylinder, called embryonic folding. Looking at the embryo in the horizontal plane, the 2 lateral folds eventually come together and close off at the midline, except for one tiny spot where the umbilical cord connects the fetus to the placenta. That opening later becomes the umbilicus, also known as the belly button. This folding allows for the formation of the gut within the abdominal cavity. With gastroschisis, those lateral folds don't close all the way, essentially leaving an opening in the abdominal wall. The hole almost always extends through the rectus muscle to the right of the umbilicus, although it's not really known why it tends to be on the right side. Whatever the reason is, this opening allows the developing organs to protrude through into the amniotic sac. Exposing the abdominal organs to amniotic fluid can sometimes cause the intestines to get irritated and inflamed, which can lead to malabsorption issues. Following delivery in gastroschisis, the bowels are exposed and they're not covered by a peritoneal layer. In contrast to this, there's a related condition called an omphalocele, which is where the abdominal contents protrude into the umbilical cord, meaning that in this case they're sealed by the peritoneal layer of the umbilical cord and are not exposed to the amniotic fluid. Although the cause of gastroschisis isn't known, it's thought to potentially be caused by reduced blood supply to the abdominal wall during fetal development, and it's likely that both genetic and environmental factors play a role. Some factors that seem to increase the risk of having a baby with gastroschisis include young maternal age, as well as consuming alcohol and tobacco during the pregnancy. Diagnosis before birth might be done via ultrasound or blood test, in which case an increased maternal serum alpha-fetoprotein is associated with abdominal wall defects. Treatment of gastroschisis involves surgery following birth, in which the intestines and organs need to be placed back inside the body and the defect repaired. If the defect is large and involves multiple organs, then they might have to be slowly moved back into the abdominal cavity. Newborns might also need additional treatments, like intravenous nutrients and antibiotics to manage infections. Alright, as a quick recap, gastroschisis is a condition in which the abdominal wall fails to close, leaving a hole typically to the right of the umbilicus, which results in the abdominal organs protruding out. In contrast to omphalocele, these are not covered by a peritoneal layer and are exposed to the amniotic fluid. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Hirschsprung disease is also known as congenital aganglionic megacolon. So Hirschsprung's is a disease that's present since birth, in which a ganglion, or a cluster of nerves, is missing, which ultimately leads to a blocked colon, causing it to enlarge. Alright, so the intestines move waste through the bowels via peristalsis, which is this series of coordinated wave-like muscle contractions that help move feces in one direction. And this is essentially automatic, happening without you even having to think about it. The type of muscle that causes these contractions is smooth muscle, as opposed to skeletal muscle or cardiac muscle. In the gut, there's a layer of smooth muscle just under the submucosa, which sits under the mucosa, which is the innermost layer of the gut nearest to the lumen. On the other side of the smooth muscle layer is the serosa. Now, if we look closer at the smooth muscle layer, it's actually composed of the circular muscle layer arranged in circular rings which contract and constrict the gut behind the feces, which keeps it from moving backward, while the longitudinal muscle layer, arranged along the length of the gut, relaxes, which lengthens and therefore pulls things forward. Also, though, within these layers are two plexuses, or networks of nerves, which are made up of ganglia, which are clusters of individual nerves that help coordinate muscle contraction and relaxation. So first there's the myenteric plexus, also known as Auerbach's plexus, which when activated primarily causes smooth muscle relaxation. The myenteric plexus connects with the second plexus, the submucous plexus, or also known as Meissner's plexus, which is buried in the submucosa and is responsible for helping to control blood flow and epithelial cell absorption and secretion. These groups of nerves are clearly super important for normal bowel function. For people with Hirschsprung's disease, both these plexuses are gone. They're completely absent in some parts of the gut. Why is that? Well, during fetal development, there are these cells called neural crest cells, which are basically a group of fetal cells that migrate away and differentiate into a variety of different cell types. In this case, some of them become neuroblasts, and eventually the nerve fibers of the plexuses in the gut. Starting from the mouth, the neuroblasts start migrating toward the anus. Around week 8 of development, the neuroblasts get to the proximal colon of the gut, and then they pass through the distal colon, and around week 12, they have finally reached the rectum. A disruption of this neuroblast journey in this time window means that the nerve fibers don't develop in the rectum and parts of the colon. Two specific genes that are thought to be important for migration and development of these nerve fibers are RET and EDNRB. So mutations in either of these could lead to an absence of these plexuses. Also, mutations in the RET gene have been linked to Down syndrome, which might help explain why Down syndrome is associated with Hirschsprung disease. Okay, so without these nerves, peristalsis in the gut is seriously impaired, because those muscles can't really relax anymore, and so they stay in their default contracted position, which essentially blocks the movement of feces. Babies that are born with Hirschsprung therefore fail to pass the meconium, their first stool, a process that usually happens within the first 2 days after birth. The rectum and the distal sigmoid colon, which are the areas closest to the anus, are usually affected. So feces builds up just before the obstruction, which causes serious constipation as well as colon dilation, or megacolon, which is at risk of rupture. For diagnosis, an abdominal x-ray with contrast dye might show an enormous megacolon full of stool that can't be easily pushed out. But a definitive diagnosis is by rectal suction biopsy of the narrowed area in the colon, where both the mucosa and the submucosa are extracted, as opposed to a normal biopsy where just the mucosa is taken. Remember that those plexuses are in the muscle layer or the submucosal layer, so a normal biopsy with just the mucosa wouldn't cut it. You need a sample of submucosa to see if the submucosal plexus is there or not, right? Treatment is typically surgical resection of the area that's lacking the nerve fibers, and then the healthy end is connected to the anus. Alright, so as a recap, Hirschsprung disease is a congenital condition where the nerve plexuses don't develop quite right in the colon, which leads to dysfunctional peristalsis and a plugged up colon. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. With intestinal atresia, atresia refers to a passageway that's closed or gone completely. So intestinal atresia is when a malformation during fetal development results in an absent portion of the small or large intestine. If instead the passageway was just narrowed, then it's referred to as intestinal stenosis. Oftentimes these are both just lumped together as intestinal atresia and stenosis. The specific type of intestinal atresia is named depending on what section of the intestines is affected. Duodenal atresia or stenosis is where the first section, the duodenum, is affected. The underlying cause of duodenal atresia isn't known, although it's commonly associated with trisomy 21, also known as Down syndrome, suggesting that it's likely due to genetic defects affecting normal development. Although it isn't known why intestinal atresia develops, it is fairly well known how it develops. Normally, early on in development, the gut's a hollow tube. But by around 6 weeks gestation, the epithelium of the duodenum proliferates and ends up plugging up the lumen, making it a completely solid stick of tissue. After that, the cells in the middle undergo apoptosis, or programmed cell death, and by 9 weeks gestation, the tube's hollow again, called recanalization. This entire process is called vacuolation. In duodenal atresia, this vacuolation process fails, and the duodenum doesn't recanalize properly, resulting in atresia or stenosis of the duodenum. Non-duodenal intestinal atresias or stenoses, like those affecting the jejunum or ileum, or even affecting the large intestine like the colon, are generally not a result of recanalization, and instead are more likely to result from ischemic injury, meaning lack of blood flow to the developing gut. Now, the jejunum, ileum, and large intestine rely on blood supply from the superior mesenteric artery, while only part of the duodenum does. So, for example, if we look at the jejunum, if those vessels supplying it with blood are occluded, then decreased perfusion leads to ischemic necrosis, which leads to segmental reabsorption and narrowing or complete destruction of the affected area. This classically leads to an apple peel configuration, due to it being spiral-shaped. Now, there are also some important clinical signs of duodenal atresia. First, usually the developing fetus swallows and digests some amniotic fluid. But since a segment of the duodenum's narrowed or absent, the fluid has nowhere to go. And this leads to distension in both the stomach and the duodenum, which causes a double bubble appearance on X-ray as a result of the inflated stomach and duodenum being separated by the muscular pyloric valve. This distension can also be detected on a prenatal ultrasound. Also, though, since the fetus swallows less amniotic fluid, that means more fluid sticks around in the amniotic sac, which is called polyhydramnios. Finally, the newborn might have bilious vomiting in the first few days of life, since bile is secreted into the duodenum, but it can't be excreted, and therefore it gets regurgitated back up with breast milk or formula, which also has no place to go. Treatment of intestinal atresia and stenosis involves gastric decompression, which is removing fluids from the stomach with a nasogastric tube, as well as making sure the newborn receives fluids intravenously. The definitive treatment of intestinal atresia and stenosis, though, is surgical removal and repair of the affected segment, which in the case of duodenal atresia is called a duodeno-duodenostomy, since you're attaching duodenum to duodenum. Typically, prognosis following surgery is very good. Alright, as a quick recap. Intestinal atresia and stenosis is where some portion of the intestine, which could be the small intestine or large intestine, is absent or narrowed. Duodenal atresia and stenosis is typically a result of a failure of recanalization, whereas non-duodenal atresias and stenoses are thought to be caused by ischemic injury. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Intussusception is a condition that happens when part of the intestine folds into another section of the intestines, resulting in obstruction. This is commonly referred to as telescoping, because it's similar to how one part of a collapsible telescope retracts into another part. Intussusception is the most common cause of intestinal obstruction in infants and young children, with about 2/3 of them happening among infants under 1 year of age, though adults can occasionally have intussusception too. Now, intussusception usually happens in the ileocecal region of the intestines, which is where the ileum of the small intestine and the cecum of the large intestine meet, and almost all intussusceptions happen when the ileum folds, or telescopes, into the cecum. In adults, telescoping is usually caused by an abnormal growth in the intestine, like a polyp or a tumor, which serves as a lead point or a leading edge. What happens is that the normal wave-like contractions of the intestine, called peristalsis, grabs the leading edge and pulls it into part of the bowel ahead of it. In babies, the leading edge is most often caused by lymphoid hyperplasia, or the enlargement of the lymphoid tissue. There are a ton of tiny lymph nodes sprinkled through the intestines called Peyer's patches, and they're particularly common in the ileum. When a child gets some sort of viral infection in the gastrointestinal tract, usually caused by rotavirus or norovirus, the Peyer's patches enlarge to help fight off the infection, and sometimes become a lead point that drags the ileum into the cecum, causing intussusception. Intussusception can also be caused by a Meckel's diverticulum, which is an abnormal outpouching of gastrointestinal tissue that sticks out of the ileum and into the peritoneal cavity. Occasionally, the diverticulum can invert and stick back into the intestine, allowing it to serve as a lead point that again drags the ileum into the cecum. Although these are well-known mechanisms for intussusception, the majority of cases are considered idiopathic, meaning that they happen without a clear cause. Risk factors include having one previously, or having a sibling with intussusception, as well as having intestinal malrotation, which is a condition where the intestine doesn't rotate correctly during fetal development. Now, when an intussusception develops, the first sign is intermittent abdominal pain that worsens with peristalsis, sometimes causing a child to guard their abdomen. For example, they might swat away the hands of a caretaker, or draw their knees up toward their chest. Other classic findings include vomiting and the presence of a hard, sausage-like mass in the abdomen. There's also a lot of pressure on the walls of the trapped section of the bowel, which squeezes shut the tiny blood vessels running in the walls, causing ischemia, or lack of blood flow, and eventually infarction, death of the tissues. Ischemic and infarcted tissue results in the sloughing off of intestinal mucosal tissue, blood, and mucus into the gut. This can result in red, currant jelly stool, which is a food-inspired visual for the berry jelly consistency of the stool. Fever isn't usually a symptom of intussusception, but in serious cases, like with infarction, the intestines can tear and release bacteria into the body cavity, causing sepsis and fever. Intussusception can also prevent food or fluid from passing through the intestines, causing an obstruction. This can lead to a large mass in the intestines, which can potentially cause the intestine to become twisted, a condition called volvulus. In children, intussusception can sometimes be felt by finger while doing a digital rectal examination, but a definite diagnosis often requires imaging techniques. An ultrasound, X-ray, or computerized tomography, or CT scan, can reveal a classic bullseye, which represents the telescoped intestine shown on end, as well as signs of intestinal obstruction. Intussusception can develop suddenly, and because of the possibility of intestinal ischemia, rapid treatment's necessary. A barium or air enema can be used to unfold the intussusception, especially in children. If it doesn't work or if there's a complication, then surgery might be necessary. During surgery, the portion of the telescoped intestine is freed, any obstruction is cleared, and any tissue that died is removed. Alright, as a quick recap. Intussusception happens when part of the intestine slides into an adjacent part of the intestine, a process called telescoping. Intussusception can lead to intestinal obstruction and can also cut off the blood supply to that part of the intestines, resulting in bowel ischemia. Rapid treatment's important and can be done with a barium or an air enema, as well as surgery if needed. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. With an omphalocele, omphalo refers to the navel, also known as the belly button, or more formally the umbilicus, which is the attachment site of the umbilical cord. And cele relates to hernia or swelling. Omphalocele, therefore, is when some of the bowels herniate out into the umbilical cord. During the 4th week of fetal development, the embryo starts to change shape from a flat, 3-layer disc to something more shaped like a cylinder, a process called embryonic folding. In the horizontal plane, the 2 lateral folds eventually come together and close off at the midline, except for at the umbilicus, where the umbilical cord connects the fetus to the placenta. This folding allows for the formation of the gut within the abdominal cavity. During around the 6th week of development, the liver and intestines grow really quickly, and because the abdominal cavity is still pretty small, there's limited space, which causes the midgut to herniate through the umbilical ring into the umbilical cord. And this happens normally. At about week 10, though, the abdominal cavity typically has grown enough to allow the midgut to come back from the umbilical cord. With omphalocele, the midgut, along with potentially other organs from the abdominal cavity, fail to return back to the abdominal cavity, and therefore stay in the umbilical cord all the way through fetal development and even after birth. Now, since the intestines and potentially other organs aren't meant to be in the umbilical cord, there can be complications like the abdominal cavity not growing to its normal size, as well as pinched blood vessels and loss of blood flow to an organ. So with an omphalocele, after birth the abdominal organs protrude out of the body, but are contained within the umbilical cord, meaning the organs are sealed by a peritoneal layer. In contrast, a related defect called gastroschisis involves the abdominal contents herniating out of the abdominal cavity as well, but it happens through a separate hole in the abdomen, so in this case the intestines aren't covered by a layer of peritoneum. Although the cause of omphalocele is ultimately unknown, it's likely a result of both genetic and environmental factors. Some cases of omphalocele are due to underlying genetic disorders, like trisomy 13, trisomy 18, trisomy 21, also known as Down syndrome, and Beckwith-Wiedemann syndrome. Also, certain factors have been found to increase the risk of a woman having a baby with omphalocele, like consumption of alcohol and tobacco during the pregnancy, use of certain medications like SSRIs, as well as obesity. Diagnosis can be done before birth, or prenatally, through detailed fetal ultrasound or lab tests, screening for increased maternal serum alpha-fetoprotein levels. If not detected prenatally, omphaloceles are obvious right at birth. Treatment of omphalocele involves surgery following birth, in which the intestines and organs need to be placed back in the abdominal cavity and the defect repaired. If the omphalocele is large, then the organs might have to be slowly moved back into the abdominal cavity over a period of time. Alright, as a quick recap, omphalocele is when the intestines, and potentially other organs, fail to return to the abdominal cavity from the umbilical cord, allowing them to protrude outside the belly but inside the umbilical cord. In contrast to gastroschisis, the abdominal contents are covered by a layer of peritoneum. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
A hernia is when an organ protrudes or bulges out through the body wall that normally contains it. So, an abdominal wall hernia is when an organ protrudes through the abdominal wall, which is made up of a few layers. The deepest layer is the visceral peritoneum, which covers many of the abdominal organs and lines the peritoneal space. That layer wraps around to form the parietal peritoneum. Then, moving outwards, there's the extraperitoneal fat, the transversalis fascia, the muscle layer with the internal and external oblique and transversus abdominis aponeurosis, and a layer of fascia, which has different names in different regions. Anything that increases the pressure of the abdominal cavity may result in a sac that forms in the abdominal wall through which organs may protrude. The organ that's usually involved in a hernia is the gastrointestinal tract, but it can also involve other organs like the omentum, the bladder, and even the ovary. Abdominal hernias vary in size and location. Small hernias can be asymptomatic, or they can cause pain and create a small bulge that can worsen with increased abdominal pressure from coughing or straining. Over time, hernias can grow and lead to bowel obstruction, causing severe pain, nausea, vomiting, or constipation. Larger hernias can put pressure on the overlying skin, causing erythema and ulceration. Generally speaking, there are 4 types of abdominal wall hernias: groin, ventral, pelvic, and flank hernias. The most common type are groin hernias, and they occur at the lower margin of the abdomen where the thigh meets the hip. Groin hernias are classified into inguinal and femoral hernias, and inguinal hernias are further classified into direct inguinal and indirect inguinal hernias. Direct inguinal hernias protrude medial to the inferior epigastric vessels within Hesselbach's triangle, which is formed by the inguinal ligament inferiorly, the inferior epigastric vessels laterally, and the rectus abdominis muscle medially. Whereas indirect inguinal hernias go through the inguinal ring and protrude lateral to the epigastric vessels. Femoral hernias are inferior to the inguinal ligament and protrude through the femoral ring. Risk factors for groin hernias include a prior hernia, old age, chronically increased intra-abdominal pressure due to chronic cough, constipation, or strenuous exercise, abdominal wall injury, and smoking. Most of the time, a groin hernia causes a dull sense of groin discomfort with strain or lifting, which is relieved once the pressure is removed. Femoral hernias in particular can be an emergency if the bowel tissue gets trapped or incarcerated and the blood vessels get strangulated, leading to bowel ischemia. Next, there's ventral hernias, which occur in the anterior abdominal wall, and there are a few types. First, there are epigastric hernias, which are defects in the abdominal midline between the umbilicus and the xiphoid process. They're due to a weakened linea alba, and most individuals have a small, slightly uncomfortable lump between the umbilicus and the xiphoid. Second, there are umbilical hernias, also called periumbilical hernia. This is a ventral hernia near the umbilicus, and it's often associated with pregnancy. In males, umbilical hernias can often get incarcerated, whereas in females, the hernias are often easy to reduce. Third, there are Spigelian hernias. These occur through a defect in the Spigelian aponeurosis, which is the aponeurosis of the transverse abdominal muscle bound by the linea semilunaris laterally and the lateral edge of the rectus muscle medially. The typical location is in the Spigelian hernia belt, a transverse 6 cm wide zone around the level of the arcuate line, which is the caudalmost extent of the posterior rectus sheath. Individuals usually have tenderness and swelling in the mid to lower abdomen, just lateral to the rectus muscle. Fourth, there are incisional hernias which develop where a prior surgical incision was made and the fascia never fully healed. Since most abdominal incisions are made in the anterior abdominal wall, most incisional hernias are ventral hernias. Risk factors for poor healing include smoking, diabetes, old age, obesity, malnutrition, immunosuppressive therapy, and connective tissue disorders. Incisional hernias typically develop in the early postoperative period, but can sometimes occur even years after surgery. Pelvic hernias protrude through one of the pelvic foramina, so obturator and sciatic hernias, or the pelvic floor, so perineal hernias. Obturator hernias are rare, and they occur when there's protrusion of the abdominal organs through the obturator foramen, which is on the anterolateral aspect of the pelvic wall where the obturator nerve, artery, and vein traverse. Weakness of the obturator membrane can cause enlargement of the obturator canal with a defect that is usually anterior and medial to the obturator neurovascular bundle. Preperitoneal fat and lymphatic tissue in the obturator canal normally form a cushion around the neurovascular bundle that prevents herniation. Thus, obturator hernia usually occurs in the setting of profound weight loss. An obturator hernia can cause obturator neuralgia, which is groin pain that radiates medially to the knee due to compression of the obturator nerve. An obturator hernia can also cause a proximal thigh mass to form between the pectineus and adductor longus muscles, or ecchymosis of the thigh if bowel necrosis has occurred. Next are sciatic hernias, which occur when abdominal contents protrude through the greater or lesser sciatic foramen. The risk for a sciatic hernia increases in individuals that have had pelvic surgery. These unusual hernias can cause a buttock mass, abdominal pain, or sciatica symptoms. Finally, perineal hernias are the protrusion of organs into the perineum through a defect in the pelvic floor. Perineal hernias typically occur in older multiparous females or occurs incisional hernias in individuals with extensive pelvic operations. Perineal hernias cause a unilateral bulge in the area of the labia, perineal regions, or gluteal regions. Finally, there are flank or lumbar hernias, which are when there's a protrusion of organs through fascial defects in the posterolateral abdominal wall. Lumbar hernias arise in one of two possible triangular defects in the lumbar region. The superior lumbar triangle, also known as the Grinfeld triangle, is bordered by the 12th rib superiorly, internal oblique laterally, and quadratus lumborum medially. The floor is the transversalis fascia and the aponeurosis of the transverse abdominis muscle. The roof is the external oblique and latissimus dorsi muscles. The inferior triangle is also known as the petite triangle because it's a small triangle located between the posterior border of the external oblique muscle laterally, the lateral border of the latissimus dorsi muscle medially, and the iliac crest inferiorly. The floor is composed of the lumbodorsal fascia, continuous with the aponeurosis of the internal oblique and transversus abdominis muscles. Lumbar hernias can form due to trauma or surgery. The most common presentation of a lumbar hernia is a palpable posterolateral mass that increases in size with coughing and strenuous activity. The mass is usually reducible and disappears when the individual lies down. Lumbar hernias can cause vague back pain, bowel obstruction, urinary obstruction, or develop into a pelvic mass. For diagnosis, the hernia and the edges of the defect may be identified through palpation while a person is standing and lying down. Reducible hernias can be pushed back into the abdomen by putting manual pressure to it. Irreducible or incarcerated hernias are trapped within the hernia sac such that they cannot be reduced. Over time, an irreducible hernia can cause blood and lymphatic fluid to get trapped, leading to swelling of the trapped tissue. As edema accumulates, the impairment becomes more and more severe until the contents of the hernia sac can become ischemic and eventually necrotic, which is referred to as a strangulated hernia. Reducible hernias are also called uncomplicated hernias, while both irreducible and strangulated hernias are considered complicated hernias. Sometimes, very small hernias, hernias in obese patients, and hernias in certain locations like pelvic or lumbar hernias require imaging studies like an abdominopelvic CT scan to get diagnosed. The definitive treatment for hernias is surgical repair. There are two different types of surgical hernia repair: herniorrhaphy and hernioplasty. Herniorrhaphy involves making a long incision directly over the hernia to access it. The herniated tissues are then pushed back to their original location. The hernia sac of the abdominal wall is removed, and the edges of the healthy muscle tissue are pushed together and stitched. Hernioplasty is a type of hernia repair surgery where a flat sterile mesh patch is placed over the weakened muscle opening and then stitched into the surrounding tissues, which keeps the mesh in place as reinforcement for the weakened muscle tissues. Hernioplasty is better known as mesh or tension-free hernia repair. Mesh repair is performed in most cases since it has a lower recurrence rate, while non-mesh repair techniques are primarily used when mesh placement is contraindicated, such as when there is active infection or necrosis of the herniated tissue, or when the use of a mesh is cost-prohibitive. Reducible hernias that are asymptomatic can be managed with watchful waiting while monitoring for complications like bowel obstruction or strangulation. Symptomatic hernias can be managed with elective surgical repair. Individuals with an acutely incarcerated or strangulated hernia typically require urgent or emergency surgery depending on the situation. Alright, as a quick recap. Abdominal wall hernias are classified by location into 4 kinds: groin, ventral, pelvic, and flank hernias. Small hernias can be asymptomatic or cause pain, where large hernias typically cause a bulge in the abdominal wall. Over time, hernias can lead to bowel obstruction and can put pressure on overlying skin, causing erythema or ulceration. For diagnosis, the hernia should be felt with the individual standing and lying down to see if it can be reduced and if there's evidence of incarceration or strangulation. Small hernias, hernias in obese patients, and certain anatomical locations like pelvic or lumbar hernias require abdominopelvic CT scan. The definitive treatment of hernias is surgical repair with herniorrhaphy or hernioplasty. In herniorrhaphy, the herniated tissues are pushed back to their original location, and the edges of the healthy muscle tissue are pushed together and stitched. In herniaplasty, a flat sterile mesh patch is placed over the weakened muscle opening and then stitched as reinforcement. Symptomatic hernias can be managed with elective surgical repair. Individuals with an acutely incarcerated or strangulated hernia typically require urgent or emergency surgery, depending on the situation.
Abdominal hernias, also called external hernias, are when an abdominal organ or part of an abdominal organ protrudes through the abdominal wall, usually at a site of weakness. They can be classified into midline hernias and groin hernias. Most frequent types of midline hernias are the epigastric and umbilical hernias, while groin hernias can further be classified into inguinal and femoral hernias. There's also incisional hernias, which is when contents herniate through an incisional scar from a previous abdominal surgery. Now, the abdominal wall is made up of a few layers. The deepest layer is the visceral peritoneum, which covers many of the abdominal organs and lines the peritoneal space. That layer wraps around to form the parietal peritoneum. Then, moving externally, there is the extraperitoneal fat, the transversalis fascia, the muscle layer with the internal and external oblique and transversus abdominis aponeurosis, and a layer of fascia which has different names in different regions. Okay, so anything that increases the pressure of the abdominal cavity may result in a sac that forms in the abdominal wall through which organs might protrude. When organs protrude through the midline, that results in a midline hernia. Midline hernias include the epigastric hernia, which is when abdominal organs herniate through the linea alba, or the part of the midline between the xiphoid process and the umbilicus. With umbilical hernias, on the other hand, the organ protrudes through the umbilicus. And then there's groin hernias, which can be classified into inguinal hernias, the more common type, and femoral hernias. With inguinal hernias, the contents of the abdominal cavity, usually fat or part of the small intestine, protrude through the inguinal canal. The inguinal canal lies between the muscles of the interior abdominal wall. The canal is bound superiorly by the internal oblique and transversus abdominis muscles, anteriorly by the external and internal oblique aponeurosis, inferiorly by the inguinal ligament, and posteriorly by the transversalis fascia and conjoint tendon. Finally, the inguinal canal also has two openings, an internal one called the deep inguinal ring, which is an orifice of the transversalis muscle fascia located lateral to the inferior epigastric vessels, and an external one called the superficial inguinal ring, which is an opening in the external oblique muscle aponeurosis. Now, remember that the inguinal canal forms during embryological development. The process begins when a projection of the peritoneum called the processus vaginalis herniates through the abdominal body wall to allow the gonads, testes in males and ovaries in females, to descend from the abdomen where they formed to their final location in the scrotum or pelvis, respectively. When the gonads have descended completely, the processus vaginalis is obliterated, closing off the tunnel. But even though both males and females have inguinal canals, since the testes have a longer journey ahead, this makes the inguinal canals larger and more prominent in males, creating a physiological site of weakness in the abdominal wall. This makes inguinal hernias far more common in genetically male individuals, so we're going to be referring to this population moving forward. Now, inguinal hernias can be classified as indirect or direct. Indirect inguinal hernias occur when the processus vaginalis fails to close after the testes have passed through it, so this is considered a congenital hernia. Due to the congenital aspect associated with it, indirect inguinal hernia typically occurs in infants and children, but it can also be discovered in adulthood. When the processus vaginalis remains open, intra-abdominal organs, like the intestines, can herniate through the inguinal canal. Specifically, with indirect inguinal hernias, the organs herniate lateral to the inferior epigastric vessels through the internal and external rings of the inguinal canal and end up in the scrotum. On the other hand, direct inguinal hernias are acquired hernias that result from the weakening of the transversalis fascia. And since the abdominal walls weaken with age, direct hernias tend to occur in the middle-aged and elderly population. Most commonly, The transversalis fascia weakens in the posterior wall of the inguinal canal within a region called Hasselbalch triangle, an area defined medially by the lateral border of the rectus abdominis, superolaterally by the inferior epigastric vessels, and inferiorly by the inguinal ligament. A hernia through the Hasselbalch triangle may occur as a result of an increased abdominal pressure, such as when doing some heavy lifting or coughing that leads to continuous overstretching of the musculoaponeurotic tissue. Eventually, with continued pressure, an organ such as the small intestine may bulge directly through the parietal peritoneum, medial to the inferior epigastric vessels, and lateral to the rectus abdominis muscles, going through the external inguinal ring only. Now, femoral hernias, on the other hand, are a relatively uncommon type of hernia. They occur just below the inguinal ligament when abdominal contents pass through the femoral canal. The canal lies medial to the femoral vein and lateral to the lacunar or Himbernot ligament. Inside the femoral canal, there are lymphatic vessels that drain the deep inguinal lymph nodes, as well as a deep lymph node known as the lacunar node. Now, normally the content of the hernia is confined within a hernial sac, which is a pouch of peritoneum that covers the herniating organ. In uncomplicated hernias, the content can be reduced back into the abdomen by pressing on the hernial sac. However, sometimes the contents can't be pushed back inside the abdomen, and it's called incarceration, since the contents are locked out of the abdomen. This results in decreased venous and lymphatic flow and, as a consequence, edema and swelling of the incarcerated tissue. Eventually, the tissue can swell so much that the arterial blood flow to the hernial sac contents is cut off. This is called strangulation, and it leads to ischemia and tissue necrosis. Now, for symptoms, small hernias can be asymptomatic, but larger hernias appear with pain and a visible, palpable bulge. Incarceration may also interrupt passage of contents through the intestines, causing symptoms of bowel obstruction like nausea, vomiting, and fever. With strangulation, there may also be redness because blood is trapped in the hernial sac. Diagnosis is usually established based on physical exam findings. Sometimes, like in individuals with obesity, imaging studies like an ultrasound can be helpful. The ultrasound helps visualize the hernial orifice and possibly the hernial contents. A CT or MRI scan may also be done to rule out other possible diagnoses. The definitive treatment of all hernias, regardless of origin or type, is surgical repair. Okay, quick recap. Abdominal hernias, also called external hernias, are when an abdominal organ or part of an abdominal organ protrudes through the abdominal wall, usually at a site of weakness. Groin hernias are the most common type of abdominal hernias, and inguinal hernias are the most common subtype of groin hernias. Clinically, hernias usually appear as a visible bulge, and depending on the complications, symptoms like fever or tenderness might be present. The diagnosis is commonly based on medical history and physical exam. Surgery is usually the treatment option for most hernias.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Inflammatory bowel diseases are mainly broken down into two autoimmune conditions, ulcerative colitis and Crohn's disease, both of which cause chronic inflammation in the gastrointestinal tract. Ulcerative colitis mostly appears in individuals aged from 20 to 30 years old. The chronic inflammation only involves the mucosal layer of the colon or the rectum, and inflammation usually starts in the rectum and goes retrograde through the colon. Ulcerative colitis can involve only the rectum, in which case it's called ulcerative proctitis. It can also involve the rectum and the sigmoid colon, called ulcerative proctosigmoiditis, or it can involve the rectum, sigmoid colon, and the colon up to the splenic flexure, called distal ulcerative colitis. In some cases, it can also pass the splenic flexure, but spare the cecum, called extensive colitis. And finally, it can involve the entire colon through the cecum, called pancolitis. The onset of the disease is gradual, and symptoms are progressive over a few weeks. These might be systemic symptoms like fatigue, fever, unintentional weight loss, as well as dyspnea and palpitations due to iron deficiency anemia caused by blood loss. Gastrointestinal symptoms include bloody diarrhea, colicky abdominal pain, and tenesmus. Extraintestinal manifestations can sometimes happen, and they include arthritis, uveitis and episcleritis, and skin lesions, like pyoderma gangrenosum and erythema nodosum, as well as primary sclerosing cholangitis and venous or arterial thromboembolism. Acute complications of ulcerative colitis include severe gastrointestinal bleeding and fulminant colitis, which is continuous bleeding and over 10 stools per day. Another complication is toxic megacolon, which is where the nerves and muscles are damaged and the colon becomes atonic and dilated. In severe cases, it can lead to perforation and peritonitis, which causes fever and severe abdominal pain. Finally, long-term complications of ulcerative colitis include an increased risk for colorectal cancer, as well as strictures from repeated bouts of inflammation that are usually located in the rectosigmoid colon and can sometimes lead to bowel obstruction. Now let's switch gears and go over Crohn's disease, which also causes chronic inflammation. But in this case, it's transmural, meaning that it involves the full thickness of the gastrointestinal wall and can happen anywhere in the gastrointestinal tract, from mouth to perianal area. Systemic symptoms of Crohn's disease include fatigue, fever, and unintentional weight loss. Gastrointestinal symptoms include crampy abdominal pain, as well as watery diarrhea and sometimes malabsorption symptoms like steatorrhea. The transmural inflammation can allow fistulas to form, which are communications between two epithelial organs. They can be enteroenteric, meaning from one part of the intestines to another and can feel like a small mass, or can be enterovesical, where they go from the intestines to another organ like the bladder, where they can cause pneumaturia, which is the passing of gas in the urine. They can also be enterocutaneous fistulas, which is where the intestines connect to skin surfaces. Sometimes a phlegmon can form, which is where there's a localized area of inflammation in the intestinal wall that can get infected and become an abscess. Sometimes individuals get perirectal abscesses, fissures, and even cutaneous fistulas around the rectum. There can be oral involvement, like aphthous ulcers or gingivitis, as well as esophageal symptoms like adenophagia and dysphagia. There can also be gallstones that lead to biliary colic. Extraintestinal symptoms are similar to those of ulcerative colitis. Those include arthritis, uveitis and episcleritis, and skin lesions like pyoderma gangrenosum and erythema nodosum, as well as primary sclerosing cholangitis and venous or arterial thromboembolism. Now, on top of all those, Crohn's disease specifically can cause kidney stones as well. For diagnosing inflammatory bowel disease, both ulcerative colitis and Crohn's disease, lab work and colonoscopy with biopsy are needed. Typical lab work includes a CBC that shows anemia, and if there is anemia, then iron studies, vitamin B12, and folate levels are checked to assess for deficiencies. Other common labs are an elevated ESR and CRP, a low albumin, and typically there are electrolyte abnormalities from diarrhea and dehydration. Typically, electrolytes are sent if there's chronic diarrhea, an AST and ALT to look for evidence of hepatitis, and creatinine and urea nitrogen are sent to assess the kidneys. Fecal calprotectin levels are typically elevated as well, because it's a protein released in large amounts by neutrophils in the digestive tract during inflammation. Now, it's also important to exclude infectious causes. A routine workup includes stool cultures for Salmonella, Shigella, Yersinia, Campylobacter, and E. coli, microscopy for ova and parasites, and antigen testing for Giardia lamblia. Pathogens associated with specific risk factors include Entamoeba histolytica, which is associated with travel to endemic countries, and Clostridium difficile, which is associated with recent antibiotic use. When ulcerative colitis is specifically suspected, testing for sexually transmitted diseases like Neisseria gonorrhoeae, Chlamydia trachomatis, herpes simplex virus, and Treponema pallidum might also be done, especially in individuals with severe rectal symptoms, like tenesmus and fecal incontinence. The next step is usually imaging, which isn't needed for the diagnosis, but it can show some abnormal findings for both ulcerative colitis and Crohn's disease. One specific imaging test is a double contrast enema. That's where X-rays are taken of the colon and rectum using barium and air as contrast. In moderate and severe ulcerative colitis, there can be mucosal thickening, and in severe cases, it can show collar button ulcers, which are deep mucosal ulcerations that also reach the submucosal layer. The circumferential inflammation can destroy the hastrus, leading to a smooth section of colon, which is called the lead pipe sign. In severely ill individuals, a barium enema shouldn't be done, because it can precipitate toxic megacolon. In Crohn's disease, aphthous ulcers might be seen, and these are shallow ulcerations of the mucosa. And strictures might also be seen, and these allow a tiny stream of contrast material to pass through, and that's called a string sign. To evaluate small intestinal disease in Crohn's disease, there are a few different imaging techniques that can be done. One option is a wireless capsule endoscopy, and this is where an individual ingests a tiny pill that contains an even tinier video camera, which can record images as it moves through the small intestine. Another option is the upper gastrointestinal series, with small bowel follow-through, or SBFT, meaning that radiologic images are taken while a barium solution is ingested. This can help identify narrowing of the lumen, with nodularity and ulcerations and a string sign if the narrowing is advanced. Fistulas and a cobblestone appearance might also be seen. Ultimately, the diagnosis of both ulcerative colitis and Crohn's disease relies on a colonoscopy with biopsy. In ulcerative colitis, there's typically circumferential inflammation or ulceration that's continuous throughout an entire section of the rectum or colon. In addition, the mucosa is often so damaged that it's friable to the touch and can spontaneously bleed. On histology, the damage is limited to the mucosa and submucosa. In addition, there can be crypt abscesses due to the aggregation of lymphocytes and inflammatory process that eventually results in crypt atrophy. A bit like lymphocytes having a party in a crypt that gets a bit wild and then burns out over time. In Crohn's disease, there's usually lesions that look like linear patches of damaged tissue, with normal GI mucosa in between, and these are called skip lesions. These damaged areas get thicker, giving it a cobblestone appearance. Usually, Crohn's disease doesn't involve the rectum, so the mucosa there might be normal. On histology, the damage is transmural, occurring in all of the layers of the gastrointestinal wall, the mucosa, submucosa, the muscularis propria, and serosa. And there are inflammatory cells and non-caseous sarcoid granulomas might be seen, as well as plasmacytosis and crypt abscesses. Treatment of ulcerative colitis depends on disease severity, how much of the colon is involved, and the frequency of disease relapse or flares. Disease severity in ulcerative colitis is based on symptoms. In mild ulcerative colitis, there are 4 or fewer stools per day with or without blood, with mild crampy abdominal pain and occasional tenesmus. In moderate ulcerative colitis, there are 5 bloody stools per day, abdominal pain, mild anemia, and sometimes a low-grade fever. In severe ulcerative colitis, there are 6 or more bloody stools per day, with severe abdominal pain, fever, tachycardia, anemia, an elevated ESR, and weight loss. The initial approach for mild and moderate ulcerative proctitis or proctosigmoiditis is treatment with the anti-inflammatory drug 5-aminosalicylic acid, or 5-ASA, also called mesalazine. This can be administered topically as a suppository or enema, and it can induce disease remission most of the time. If applying it locally isn't comfortable, then 5-ASA can be given orally, although it's generally not as effective as topical 5-ASA. If the individual doesn't respond to topical 5-ASA within 6 weeks, then 5-ASA should be given both orally and topically, or a steroid agent like beclomethasone can be added on. At that point, a clinical response or remission usually happens within 8 weeks. Now, individuals with proctosigmoiditis and individuals with proctitis that have more than 1 relapse a year should continue maintenance therapy with either topical or oral 5-ASA, whichever established remission for the individual. The initial approach for mild and moderate distal colitis, extensive colitis, and pancolitis is a combination of oral 5-ASA plus either topical 5-ASA or topical steroids, like suppositories and hydrocortisone. If there's no response within 2 to 4 weeks, then budesonide multimatrix can be added to the treatment. Budesonide multimatrix is an oral glucocorticoid that gets released within the colon at a controlled rate. If individuals don't respond to budesonide multimatrix, then oral prednisone is recommended. Maintenance therapy is recommended in all individuals with distal and extensive ulcerative colitis as well as pancolitis, and it's done using oral 5-ASA along with intermittent topical 5-ASA or topical steroids. Now, with severe ulcerative colitis, the initial approach consists of oral glucocorticoids, high-dose oral 5-ASA, along with either topical 5-ASA or topical steroids, like hydrocortisone. If these individuals have evidence of an infection, like a high fever or leukocytosis with neutrophilia, then intravenous antibiotics like ciprofloxacin or metronidazole should also be given to empirically treat for an infection. Individuals that don't respond to initial therapy should be given intravenous fluids, if needed, as well as intravenous steroids like methylprednisolone. Individuals who do respond should continue on maintenance therapy with oral 5-ASA, topical 5-ASA, and oral glucocorticoids. For topical 5-ASA and oral glucocorticoids, the doses are gradually lowered over a few months. Finally, individuals who develop an acute complication like fulminant ulcerative colitis are treated with intravenous fluids, along with broad-spectrum antibiotics like ciprofloxacin and metronidazole, and intravenous glucocorticoids. If the individual doesn't improve after 3 days, then intravenous cyclosporine or infliximab might be tried. And if there's no improvement within a week, then the individual might need to undergo a colectomy, which is curative for ulcerative colitis. Treatment of Crohn's disease depends on the severity and anatomic location of the disease. Disease severity in Crohn's disease is based on the Crohn's Disease Activity Index, or CDAI, or the Harvey-Bradshaw Index, or HBI, which is a simplified version of the CDAI. CDAI includes the stool pattern, general daily well-being over 7 days, complications, presence of an abdominal mass, anemia, and weight changes. The CDAI score divides Crohn's disease into 4 major categories: asymptomatic or in remission, mild, moderate, and severe disease. In addition, individuals can be either low risk or moderate risk for complications. Low risk individuals are usually diagnosed above age 30, have no symptoms, have no prior intestinal resection, and have no perianal involvement. In contrast, moderate high risk individuals are usually diagnosed below age 30, have extraintestinal symptoms, prior intestinal resections, and perianal involvement. There are 2 approaches to the treatment of Crohn's disease. The first is step-up therapy, where less potent medications are initiated and are changed if they're ineffective. The second is step-down therapy, where more potent medications are initiated and gradually decreased. In individuals with mild Crohn's disease that are low risk, step-up therapy is preferred and is initiated with oral budesonide for 12 weeks if there's ileal and colonic involvement. Oral prednisone or oral 5-ASA are alternatives if the individual doesn't respond to budesonide. If there's diffuse colitis or left colon involvement, oral prednisone is initiated, or if there's only mild left colitis, then oral sulfasalazine can be used, which is a modified sulfonamide related to 5-ASA. If remission was obtained with a glucocorticoid agent, the maintenance therapy is continued with the glucocorticoid, and the dose is slowly lowered and eventually discontinued over a few weeks. If the remission was obtained with 5-ASA or sulfasalazine, then the same agents are used for maintenance therapy. In individuals with moderate to severe Crohn's disease that are moderate high risk, step-down therapy is preferred and it's initiated with a biologic agent like infliximab, along with an immunomodulator like azathioprine. In individuals above 60 years old, infliximab monotherapy can be used. Finally, in individuals with severe disease, glucocorticoids like oral prednisone or budesonide might be used. After remission, maintenance therapy with a biologic agent like infliximab is used and it can be combined with an immunomodulator like azathioprine. Alright, as a quick recap. Ulcerative colitis involves only the rectum and the colon, and acute complications include bleeding, fulminant colitis, and toxic megacolon, while chronic complications include strictures and colorectal cancer. Crohn's disease can involve any part of the gastrointestinal tract and causes fistulas as well as renal stones. The routine workup for inflammatory bowel diseases consists of a CBC, ESR, CRP, albumin, electrolytes, ALT, AST, creatinine, urea nitrogen, fecal calprotectin, stool microscopy and stool cultures, along with testing for C. diff toxin. In ulcerative colitis, the colonoscopy shows continuous inflammation only in the mucosa and submucosa of the rectum and colon. In Crohn's disease, the colonoscopy shows focal ulcerations that alternate with normal mucosa, giving a cobblestone appearance. Treatment of ulcerative colitis depends on the severity and extent of the disease, and medications include 5-ASA, budesonide multimatrix, and oral prednisone. In severe cases, infliximab and cyclosporine might be used, and if there's no improvement, colectomy is recommended. Treatment for Crohn's disease depends on the severity and location of the lesions, and includes budesonide or oral prednisone for low-risk individuals, and infliximab plus azathioprine for moderate high-risk individuals.
Alex is a 21-year-old college student who has a 2-month history of frequent episodes of abdominal pain and bloody diarrhea. Chris is also a 21-year-old college student with painful ulcers in the mouth, intermittent abdominal pain, and non-bloody diarrhea that's been going on for years. In addition, Chris has a history of recurrent kidney stones. After careful examination, colonoscopy is ordered in both cases. In Alex's case, there's circumferential inflammation that's continuous throughout an entire section of the rectum and colon. On the other hand, in Chris's case, there are linear patches of damaged colon, with normal mucosa in between, and the rectum is not involved. Alex and Chris both have inflammatory bowel disease, or IBD, which is characterized by chronic gastrointestinal tract inflammation due to autoimmune reactions, as well as systemic symptoms like fatigue, fever, and unintentional weight loss. IBD typically has its onset before the age of 30. The exact cause is unknown, but there's definitely a genetic component because it runs in families. Now, there are 2 types of IBD, Crohn's disease and ulcerative colitis. Okay, now let's look at each specific disease, starting with Crohn's disease, which is mostly caused by an abnormal Th1 cellular response, and a known risk factor is smoking. In Crohn's disease, the inflammation can pop up anywhere in the GI tract, from the mouth to the anus, but the rectum is often spared. It tends to be most severe at the terminal ileum. Gastrointestinal symptoms include crampy abdominal pain, watery diarrhea that may or may not be bloody, and sometimes malabsorption symptoms like malnutrition, stellarorrhea, or B12 deficiency. A very frequent finding to keep in mind are aphthous ulcers in the mouth. Some individuals may also present esophageal involvement with odonophagia and dysphagia. Extraintestinal symptoms include arthritis, uveitis, episcleritis, and skin lesions like pyoderma gangrenosum and erythema nodosum. In addition, a high-yield fact is that Crohn's disease leads to a higher risk of kidney stones and gallstones. That's because damage to the terminal ileum decreases absorption of fats and bile salts in the intestine. The fats bind to calcium, which prevents the calcium from binding to oxalates. Free oxalates are absorbed in the intestine and eventually lead to calcium oxalate stones in the kidneys. On the other hand, the bile salts normally bind to cholesterol to make it water-soluble. If there's a decreased absorption of bile salts, cholesterol can collect and form stones in the gallbladder. Over time, Crohn's disease may lead to complications like strictures, which can cause bowel obstruction. Another complication are fistulas, which are communications between 2 epithelial organs, like from one part of the intestines to another, or from the intestines to another organ like the bladder or the skin surface. Sometimes a phlegmon can form, which is where there's a localized area of inflammation in the intestinal wall that can get infected and become an abscess. Sometimes individuals get perianal abscesses, fissures, and fistulas. Finally, individuals with Crohn's disease may be at increased risk for colorectal cancer. Okay, let's switch gears to ulcerative colitis, which is mostly caused by an abnormal Th2 cellular response. Now, strangely enough, smoking has a protective effect in ulcerative colitis. The inflammation usually starts in the rectum and goes retrograde through the colon, but doesn't extend to the rest of the GI tract. Gastrointestinal symptoms include colicky abdominal pain, bloody diarrhea due to the inflammation that makes the GI mucosa frail, and tenesmus due to rectal involvement. Extraintestinal symptoms can include iron deficiency anemia due to blood loss, as well as arthritis, uveitis, and episcleritis, primary sclerosing cholangitis, and skin lesions like pyoderma gangrenosum and erythema nodosum. Finally, complications of ulcerative colitis include severe gastrointestinal bleeding and fulminant colitis, which is continuous bleeding and over 10 stools per day. Another dangerous complication is toxic megacolon, which is where the nerves and muscles are damaged and the colon becomes atonic and dilated. In severe cases, it can lead to perforation with peritonitis, which causes fevers and severe abdominal pain. Finally, it's important to know that ulcerative colitis increases the risk for colorectal cancer, even more than Crohn's disease. Alright, so for diagnosis of IBDs, an endoscopy or colonoscopy with biopsy is needed. And you need to know the findings for your exams. So, Crohn's disease lesions on endoscopy or colonoscopy look like linear patches of damaged tissue with normal GI mucosa in between, and these are called skip lesions. These damaged areas give the bowel a cobblestone appearance. In some individuals, the mesenteric fat may wrap around the bowel, causing it to thicken, and this is called the creeping fat sign. On the other hand, in ulcerative colitis, there's circumferential inflammation that's continuous throughout an entire section of the rectum or colon. In addition, there can be areas with superficial or deep ulceration. Another important thing to note with ulcerative colitis is that the mucosa may be so friable to the touch that it can bleed during a colonoscopy. Now, if we look at a biopsy, in Crohn's disease, the damage of the GI wall is transmural, meaning that it involves the full thickness, and this may lead to fissures. There can be transmural lymphoid aggregates, where the white blood cells invade down to the deep mucosa and can organize themselves into non-caseating granulomas. The inflamed areas can also swell or scar, forming narrow areas called strictures, which can lead to obstructions. On a barium enema, strictures only allow a tiny stream of contrast material to pass through, and on a radiograph, that's called a string sign. On the other hand, in ulcerative colitis, the damage is limited to the mucosa and submucosa, and there might be crypt abscesses. Crypt abscesses are formed by white blood cells that dwell in the crypts of Lieberkühn, an invagination of the intestinal epithelium into the lamina propria. In ulcerative colitis, the circumferential inflammation can destroy the haustras, leading to a smooth section of colon, which is called lead pipe sign. An important difference with Crohn's disease is that the ulcerative colitis doesn't present granulomas. Once the diagnosis has been made, the choice of treatment depends on the IBD type and severity. Treatment often involves a step-up approach, where less potent anti-inflammatory medications are initiated, and if they fail, they're changed to more potent medications. So, usually for Crohn's disease, treatment is started with corticosteroids. If these fail, then the alternative is giving 5-aminosalicylate acid, or 5-ASA. Another alternative are antibiotics like ciprofloxacin and metronidazole. Antibiotics are thought to help control symptoms by reducing bacteria levels in the intestine, as well as by curbing the immune response, since some antibiotics have anti-inflammatory effects as well. Finally, more severe cases might get a biologic agent, like infliximab, to suppress the immune system, and it can be combined with an immunomodulator like azathioprine. Now, for ulcerative colitis, usually the initial approach is with 5-ASA. More severe cases might be prescribed immunosuppressant medications, like corticosteroids. If those fail, biologic treatments such as infliximab can be used. Beyond that, another treatment option involves surgery and removal of the affected tissue. But one really important distinction is that in Crohn's disease, surgery doesn't cure the disease, since inflammation can occur anywhere along the GI tract. On the other hand, ulcerative colitis only affects the large intestine, so surgery can actually cure the disease. But you have to weigh the benefits of curing the disease against the loss of a section or the entire large intestine. Alright, as a quick recap, Crohn's disease can involve any part of the GI tract and causes fistulas as well as kidney stones. On the other hand, ulcerative colitis involves only the rectum and the colon, and acute complications include bleeding, fulminant colitis, and toxic megacolon, while chronic complications include strictures and colorectal cancer. Diagnosis relies on a colonoscopy with biopsy. In ulcerative colitis, the colonoscopy shows continuous inflammation only in the mucosa and submucosa of the rectum and colon. In Crohn's disease, the colonoscopy shows transmural skip lesions that alternate with normal mucosa, giving a cobblestone appearance. Treatment involves anti-inflammatory medications and depends on IBD type and severity. Going back over our cases, in Alex's case, the fact that his diarrhea is bloody suggests that he has ulcerative colitis. And in Chris's case, his non-bloody diarrhea and recurrent kidney stones suggest he has Crohn's disease. Colonoscopy results support this, as Alex has continuous involvement of the rectum and colon, while Chris shows skip lesions that spare the rectum. A biopsy can be done to confirm the diagnosis.
Crohn's disease, actually now more frequently referred to as Crohn disease, is an inflammatory bowel disease that, causes inflammation in the bowel. Unlike its cousin, ulcerative colitis, which only affects the large intestine, Crohn disease causes inflammation and tissue destruction anywhere along the gastrointestinal tract, from the mouth to the anus. Although ulcerative colitis is classified and treated as an autoimmune disease, Crohn's disease isn't technically classified as an autoimmune disease, but rather an immune-related disorder. What does that mean exactly? Well, with autoimmune diseases, we think that your own cells and proteins trigger the immune system to start attacking itself. In Crohn's disease, the immune system is thought to be triggered by some foreign pathogen in the gastrointestinal tract. Several pathogens have been implicated, like Mycobacterium paratuberculosis, as well as Pseudomonas and Listeria species. So the immune system's reacting to foreign pathogens. Isn't that what it's supposed to be doing? Well, yes and no. Yes, because it's targeting a foreign invader. No, because the inflammatory response is large and uncontrolled, and leads to a destruction of the cells in the gastrointestinal tract. So what's thought to happen is that one of these pathogens activates the immune system by antigen presentation, meaning one of the gastrointestinal cells is like, here, I think this is an infectious molecule. And that's fine, because it is. At that point, T helper cells, or Th1 cells, swoop in and release cytokines, which are cell-signaling molecules, like interferon gamma and tumor necrosis factor alpha, which further stimulate the inflammatory response. The cytokines attract inflammatory cells like macrophages, which start releasing even more inflammatory substances like proteases, platelet activating factor, and free radicals, all which contribute to inflammation. Although not definitively understood, it's thought that for patients with Crohn's disease, one of the steps in this process is dysfunctional and leads to an unregulated and out-of-control inflammatory response. Unregulated inflammation means lots of proteases, platelet activating factor, and free radicals floating around the gastrointestinal tissue, which ultimately causes destruction of healthy tissue. This dysfunctional immune response is thought to be a product of genetics, and in fact, patients with family members that have Crohn's disease are way more likely to develop it themselves. A number of genes have been identified and are thought to contribute to developing the disease. One of these is a frame shift mutation in the NOD2 gene, now called CARD15. Usually, for gene expression, nucleotides are read in groups of 3. But when you add or subtract 1 or 2 nucleotides, it essentially shifts all the remaining nucleotides, which usually ends up in totally different amino acids being coded, and probably a dysfunctional protein. Okay, so the intestinal wall, like this one, has lots of ridges and grooves, and also can be separated into the mucosal layer, the submucosal layer, the muscle layer, and the serosa. Typically, pathogens aren't supposed to just be able to pop right through the wall. But it's thought that perhaps maybe some defect in the epithelial barrier in Crohn's disease more easily lets these pathogens through. Whatever the case, once they're through, the immune system is activated through antigen presentation, which ultimately leads to the apparent unregulated inflammation we just described. As cells become more inflamed and are destroyed, the immune system invades down into the deep mucosa and organizes themselves into granulomas. Now this guy over here is a granuloma, and these are big masses of immune cells that are trying to encapsulate whatever they think is foreign. Eventually, from inflammatory and cellular damage, ulcers form, which are almost like these craters in the intestinal wall. Unlike what we see in other inflammatory bowel diseases, like ulcerative colitis, which extends through the mucosa and submucosa, the damage and inflammation in Crohn's disease extends beyond the submucosal layer and through the entire depth of the intestinal wall. Sometimes we refer to this as being transmural, from mucosa to serosa. Also, another distinction from ulcerative colitis is that these areas of inflammation are scattered, as opposed to being continuous, and have areas of healthy tissue interspersed between inflamed areas. This gives it a classic cobblestone appearance. A final difference, as mentioned already, is that Crohn's disease can affect any area of the GI tract. Most commonly it affects the ileum and the colon, second most commonly just the ileum, and third most commonly just the colon. But again, those are just the most commonly seen, and it can really affect any part of the GI tract, from the mouth to the anus. As more gastrointestinal tissue is damaged, patients might experience pain in the affected areas, most commonly in the right lower quadrant, which is associated with the ileum. Also, diarrhea and blood in the stool are common symptoms. The blood is from damaged intestinal wall tissue, and if the cells in the large intestine are damaged, they lose their ability to reabsorb water, and more water is then excreted, leading to diarrhea. Along the same lines, if the small intestine is the one taking the brunt of the damage, patients may have malabsorption issues, since the small intestines are super important for absorbing nutrients. Treatment for Crohn's disease usually involves anti-inflammatory medications and antibiotics. Antibiotics are thought to help control symptoms by reducing bacteria levels in your intestine, which is sometimes called bacterial overgrowth, and also by curbing the immune response, since some antibiotics have anti-inflammatory effects as well. If patients have severe symptoms, they may be given immunosuppressants like corticosteroids. Beyond that, surgery and removal of the affected tissue is possible, but one really important distinction from ulcerative colitis is that removal doesn't cure the disease, since the inflammation can occur anywhere along the GI tract. Inflammatory bowel disease can cause inflammation in the small and large intestine. In other words, inflammation of the bowel. Colitis refers specifically to inflammation in the colon, or the large intestine. Ulcerative colitis is a type of inflammatory bowel disease that tends to form ulcers along the inner surface or lumen of the large intestine, including both the colon and the rectum. These ulcers are spots in the mucosa where the tissue has eroded away and left behind open sores or breaks in the membrane. Sometimes there's a flare, which means that new damage has happened, and then there are periods of remission when the tissue starts to heal up. Ulcerative colitis is actually the most common type of inflammatory bowel disease. Not that there are that many, but this one causes inflammation and ulcers in the mucosa and submucosa of the large intestine only, which is an important point that sets it apart from Crohn's disease, another inflammatory bowel disease. Now, although certain environmental factors like diet and stress were once thought to be the culprit behind these ulcers forming in the gut, now it's thought that these are more secondary, meaning they seem to make symptoms worse, but ulcerative colitis is now ultimately thought to be autoimmune in origin. In fact, cytotoxic T cells from the immune system are often found in the epithelium lining the colon. So the thought is that inflammation and ulceration in the large intestine is caused by T cells destroying the cells lining the walls of the large intestine, leaving behind these eroded areas or ulcers. It's unclear what exactly these T cells are meant to be targeting, though. Some patients have P. ANCAs in their blood, or paranuclear antineutrophilic cytoplasmic antibodies, which are a kind of antibodies that target antigens in the body's own neutrophils. Although not completely understood, some theories suggest this might be partly due to an immune reaction to gut bacteria that have some structural similarity to our own cells, allowing antibodies to those gut bacteria, or P. ANCAs, to cross-react with neutrophils. Patients also seem to have a higher proportion of gut bacteria that produce sulfides, and often high sulfide production is correlated with periods of active inflammation as opposed to remission. Ultimately, though, these are mostly correlations and theories, and we've yet to nail down the precise mechanism behind mucosal destruction. The cause is ultimately some combination of environmental stimuli, perhaps the sulfide-producing bacteria, mixed with a genetic predisposition, because patients with a family history of ulcerative colitis are more likely to develop the disease themselves. It also seems to be more common in young women from the teens to 30s, with more prevalence among Caucasians and Eastern European Jews. With ulcerative colitis, the pattern for ulceration seems to be circumferential and continuous, meaning that the inflammation goes around the whole lumen and starts in the rectum and continues along the large intestine without any apparent breaks of normal or unaffected tissue, like it's working its way from one end to the other. As more damage is done to the tissue, patients experience pain in the left lower quadrant, which corresponds to the rectum, and more severe and frequent bouts of diarrhea, sometimes with blood in the stool as well. As the mucosa and epithelium are destroyed, blood and serum might be released into the lumen, which contributes to the blood seen in the stools. But also, what's one of the main jobs of the large intestine? Absorbing water. So as these cells are destroyed, the large intestine can't perform this function as efficiently, and ends up letting too much water through, contributing to diarrhea. Diagnosis of ulcerative colitis typically requires colonoscopy, which is when a long tube with a camera at the end is inserted retrograde through the anus, and into the rectum and colon to see the ulcers, and take a biopsy. In addition, radiological imaging might be done with the help of a CT scan, MRI, a barium enema, which is where a liquid is injected into the rectum through a small tube, and an X-ray, which are taken to look for abnormalities in the large intestines. Treatment for ulcerative colitis depends on the severity of the symptoms. Often anti-inflammatory medications like sulfasalazine or mesalamine are given. In more severe cases, drugs that suppress the immune system like corticosteroids, azathioprine, or cyclosporine might be prescribed. If those fail, biological treatments like infliximab, which is a TNF inhibitor, adalimumab, and golimumab can be used. Finally, if these treatment options fail, sometimes patients will have a colectomy, which is a surgical removal of the colon. Since the disease only affects the large intestine, removal of the colon generally cures the disease, but you have to weigh the benefits of curing the disease against the total loss of the large intestine. Alright, as a quick recap. Ulcerative colitis is the most common type of inflammatory bowel disease, where ulcers form along the inner surface or lumen of the large intestine, which includes both the colon and the rectum. Ulcerative colitis is diagnosed with the help of colonoscopy and barium enema, and treatment involves anti-inflammatory medications, immunosuppressants, or colectomy to remove diseased parts of the colon in severe cases. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Hypoxia, or lack of oxygen in cells and tissue, can happen in a number of ways, and ischemia is one of them. Ischo means restraint or suppression, and emia refers to the blood. So ischemia must mean some kind of suppression or reduction of blood flow to an organ or tissue. And blood carries oxygen, right? So when there's a reduction in blood flow to cells, That also means there's a reduction of oxygen to those cells, and this is due to the lowered blood flow in the blood vessels. This lowered flow could be from something blocking the blood from the inside, or it could be something compressing the blood vessel from the outside. An example of something blocking the vessel from the inside is a thrombus, also known as a blood clot. These are solid clumps of platelets and fibrin that obstruct blood flow. Ischemia resulting from something outside the blood vessel is traumatic injury, which can cause inflammation and swelling that physically applies external pressure to the blood vessel, compresses it, and restricts blood flow. Alright, so let's say that this is your artery, and it's like the one-way highway leading all these red blood cells into the city, which is like a major organ in the middle here. So maybe this is Organopolis. These red blood cells are super pumped for their day, where they can drive around the capillaries, like the smaller city streets, and supply the city with fresh oxygen and pick up waste. And this Organopolis is made up of thousands of cells, like homes, that use up the oxygen and create waste that needs to be picked up. The deoxygenated blood cells drain out through different small streets, which are the veins, and go back towards the heart. So one way this organ city could become ischemic is if there's some obstruction to arterial flow into the tissue. Now only a few red blood cells can get in at a time. You might imagine that Organopolis sees a lot less blood and a lot less oxygen, and becomes ischemic. A super important and well-known example of this arterial ischemia is atherosclerosis, where plaque builds up in the arteries going to your heart tissue, which blocks arterial flow, reduces the amount of blood and oxygen that makes it to your heart tissue, and causes ischemic heart disease. Since you can have a blockage of red blood cells coming in, you can also have a blockage of red blood cells going out, leading to a decrease in blood drainage on the venous side. So in this case, you've got a major obstruction in the venous highway leaving the city. So say that these are like the veins draining blood out of Organopolis. All these workers are getting into Organopolis, but they can't leave because there's this blockage heading out, and traffic gets majorly backed up, causing flow to slow down throughout the whole city. This again leads to less oxygen to the tissues and ischemia. Thinking about an organ, it might get so congested that pressure can rise, causing fluid to get forced out of the blood vessels and into the tissues, generating edema. This whole example is very similar to Budd-Chiari syndrome, where the hepatic veins that drain blood out of the liver are blocked by a thrombosis, or a clot. And now blood can't flow through the liver, and the liver tissue becomes ischemic and can lead to liver edema and hepatomegaly, or enlargement of the liver. If the oxygen supply is low enough for long enough, it can cause cell death, and if enough cells die in a region of tissue, we would call that tissue necrosis and infarction. In some cases, there are areas of tissue that are getting close to infarction as cells begin to die off, but they're still able to get saved if they receive blood. This high-risk area that's teetering on the brink of death is called the ischemic penumbra. In some cases, there are two arteries serving a single area of tissue. And this goes against how we often think about tissue as being served by a single capillary bed from a single artery. But when you think about it in 3 dimensions, there can be a lot of overlap, right? If there are these secondary or collateral arteries going to the area, then there might be enough blood flow to keep the penumbra alive for a while. Over the course of weeks to months, these secondary arteries can even grow in size to bring more blood to that area, a bit like disaster relief. This process is called collateralization. So if blood flow to an organ is blocked all of a sudden, a super important concept to keep in mind is called time to reperfusion. This refers to the importance of reestablishing perfusion to the affected organ before the cells die and the ischemia becomes irreversible. Remember that perfusion and blood flow are slightly different. Blood flow is the volume of blood flowing per unit time, like liters per minute. Perfusion is like a measurement of how much blood is flowing to a chunk of tissue per time. So it might be given in liters per minute per gram of tissue. So as an example, if you compared the total blood flow to the kidneys with the total blood flow to the liver, it'd be higher to the liver because the liver is a lot larger. But if you took a 10-gram cube of liver tissue and compared it to a 10-gram cube of kidney tissue, the kidney actually has higher perfusion, since it has more blood vessels packed into its cube. Now, back to reperfusion. If perfusion to the area is reestablished quickly enough, then it's possible that the ischemia is reversible because the cells were dying, but they're not dead. If too much time has passed and the cells have actually died, then the ischemia is irreversible since you can't bring back dead cells. One example of irreversible ischemic damage is something like a heart attack or a myocardial infarction, where an artery supplying a specific part of the heart with blood becomes blocked, causing death of that part. Depending on the area that's affected, this could cause serious heart dysfunction. Like if enough of the heart's ventricle was damaged, it might not be able to pump blood as well anymore.
Ischemic colitis, or IC for short, is the most common form of intestinal ischemia. It is typically caused by reduced intestinal blood flow, usually due to small vessel occlusion or hypoperfusion of the colon. Hypoperfusion usually follows the blood supply pattern and is most common in the watershed areas, so the splenic flexure and rectosigmoid junction. This occurs because the arteries supplying the watershed areas are the most distal branches, so when blood flow to the intestine decreases, they're the most likely to suffer from insufficient blood supply. Reduced intestinal perfusion causes injury to the colon mucosa. However, prolonged hypoperfusion can result in transmural ischemia, which can further lead to complications, such as fulminant gangrene, perforation, and peritonitis. Now, when assessing a patient with suspected IC, start with an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, you should prioritize acute management to stabilize their airway, breathing, and circulation. This means that you might need to intubate the patient, establish IV access, or administer fluids before continuing with your assessment. Once the patient is stable, determine the cause of their instability and proceed with a focused history and physical examination. History usually reveals severe abdominal pain, tenesmus, and bloody diarrhea, while a physical exam might reveal signs of shock, such as hypotension and tachycardia. Sometimes you may also find signs of peritonitis, like rebound pain, rigidity, or guarding. If you see these signs, start supportive care, which means continuing IV fluids and administering empiric, broad-spectrum antibiotics. But here's the thing. These findings are not specific to ischemic colitis only, so you should order abdominal imaging, such as X-ray or CT, to look for bowel dilation and signs of complications, such as perforation or peritonitis. Important findings to look for include pneumatosis coli, or the presence of gas within the bowel wall, as well as portal gas, which refers to gas in the portal vein or its branches, and pneumoperitoneum, or free gas in the peritoneal cavity. In this case, call the surgical team for emergent consultation and laparotomy. All right. Let's go back all the way to the ABCDE assessment and take a look at how to approach a stable individual with suspected ischemic colitis. Start by obtaining a focused history and physical examination, as well as labs such as CBC and lactate. Now, history typically reveals crampy abdominal pain that developed rapidly, usually in the left lower quadrant, as well as tenesmus. Additionally, the patient might report mild rectal bleeding or bloody diarrhea, which usually develops within 24 hours of the abdominal pain. Here's a high-yield fact. When taking history, be on the lookout for risk factors for colonic ischemia. First, there are factors like hypertension or diabetes mellitus that damage small blood vessels and decrease blood flow to the colon. Another risk factor is atrial fibrillation, which can lead to thromboembolic complications involving the small vessels like those of the colon. Finally, an important risk factor is aortic surgery, during which the aorta and its branches might be temporarily clamped, which can cause hypoperfusion of the colon. Let's move on to the physical exam. On palpation, patients with IC will usually present with tenderness and mild distension. Sometimes there is also guarding. Finally, labs might reveal elevated white blood cells and lactate. Okay, if you suspect IC based on history, physical examination, and labs, you should proceed with supportive management. This includes fluid resuscitation, bowel rest, hemodynamic monitoring, and administration of empiric broad-spectrum antibiotics. Once you start supportive care, order a CT scan with IV and oral contrast. Be on the lookout for any signs of end-stage bowel ischemia and necrosis, which will show up as pneumatosis coli, which can lead to air in the mesenteric vessels, as well as air in the portal venous system, or signs of perforation like free air in the abdomen. If you see any of these, call the surgical team for consultation and emergent laparotomy. On the other hand, if you didn't see any signs of necrosis on CT, you can't rule out IC just yet. IC without necrosis usually presents with bowel wall thickening and submucosal edema, which appears as thumbprinting on radiograph or CT imaging. Additional CT findings include a target sign caused by the hyperemic mucosal and serosal layer of the colon wall, which appear hyperdense on CT, and the edematous submucosal layer, which appears hypodense on CT with or without associated paracolonic stranding. These findings are usually found in the watershed areas. Finally, sometimes there might not be any CT findings that suggest ischemic colitis. Alright, now that we covered all the signs of ischemic colitis on imaging, let's move on to the colonoscopy. In patients who don't have signs of necrosis on CT, you should order a colonoscopy with biopsies to confirm the diagnosis of ischemic colitis and rule out other causes of colon inflammation, such as inflammatory bowel disease or pseudomembranous colitis. Signs of IC on colonoscopy include fragile mucosa, segmental erythema, erosions, and petechial hemorrhage with pale mucosa in between. The biopsy is usually not specific to ischemic colitis, but it helps rule out other conditions. So, if you see any of these signs, you can confirm the diagnosis of IC. On the flip side, if there are no findings suggestive of ischemic colitis on colonoscopy with biopsy, or results point to something else, you should consider an alternative diagnosis. Now that we've diagnosed IC, let's move on to treatment. Treatment for IC usually involves continuing supportive care, which may include avoiding hypotension or giving high-dose vasopressors, as well as observing them until their CBC and lactate go back to normal. Usually, patients improve after 2 to 3 days. However, if they don't improve or even develop signs of worsening or complicated disease, you should call the surgical team for emergent consultation and possible laparotomy. Alright, as a quick recap, patients with ischemic colitis can present as unstable or stable. If the patient is unstable, stabilize them and perform an abdominal X-ray or CT to look for signs of complications, such as colon dilation, pneumatosis, portal gas, and pneumoperitoneum. Patients with complicated ischemic colitis require emergent surgical consultation and laparotomy. On the other hand, stable patients require supportive care with fluid resuscitation, bowel rest, and broad-spectrum antibiotics. Next, they should be assessed using CT with IV and PO contrast. CT usually shows signs of colon inflammation, like thickening and edema of bowel walls, thumbprinting, or a target sign. Then, patients with these signs should be further evaluated using colonoscopy with biopsies. Colonoscopy findings typically include fragile mucosa, erythema, erosions, and petechial bleeding with pale mucosa in between. When it comes to treatment, IC is usually treated with supportive care. If the patient doesn't improve in 2 to 3 days or worsens, the surgical team should be called for an emergent laparotomy.
Small bowel refers to the small intestine, and infarction is when ischemia, which is an inadequate blood supply, causes necrosis or tissue death. So a small bowel infarction happens when there's a reduced blood supply to the small intestine, and this causes parts of the intestinal wall to necrose or die, which can be life-threatening. Now, the small intestine is made of several layers. The innermost layer is the mucosal layer, and it's composed of a few of its own layers. The first layer is the epithelial lining, and it faces the lumen. Next is the lamina propria, which is rich with blood and lymph vessels. And finally, there's the muscularis mucosae, which has smooth muscle. Deep to this mucosal layer is the submucosal layer, which has connective tissue with proteins like collagen and elastin, as well as glands and additional blood vessels. The submucosal layer also has the Meissner plexus, which is part of the enteric nervous system. Below the submucosal layer is the muscularis propria, which is basically two layers of smooth muscle with the myenteric plexus, another part of the enteric nervous system, sandwiched between them. These muscles are particularly important in helping to move food through the bowel. Finally, there's the serosal layer, which is the outermost layer of the small intestines that faces the abdominal cavity. The superior mesenteric artery is the main supplier of blood to the small intestine. Branches of the artery spread through the mesentery, called mesenteric arteries, and penetrate the serosal layer and travel to the submucosa where they branch further into arterioles. Because the small intestine has a high demand for oxygen and nutrients to sustain digestion, it's highly susceptible to tissue injury from ischemia. To reduce the risk of that happening, the mesenteric arteries branch and reconnect at points, forming collateral circulation. That's protected because if blood flow is reduced in one pathway, then the tissue can still receive blood through another pathway. Once the small intestines have gotten oxygenated blood, that blood leaves through the superior mesenteric vein. Small bowel infarction happens when there's a significant decrease in blood flow to the small intestine. This reduction in blood flow decreases blood pressure and can cause an insufficient blood flow throughout the collateral circulation, which initiates ischemic injury in a wide region of tissue. At the cellular level, ischemic injury can lead to the production of reactive oxygen species, which can damage DNA, RNA, and proteins in the cell, leading to cell death. If blood flow returns to the ischemic tissue, it's called reperfusion. Unfortunately, though, that process can cause further injury, called reperfusion injury. In reperfusion injury, the influx of oxygen into an already damaged cell can be overwhelming and can cause even more oxidative stress, which worsens the cell damage. As damaged cells release reactive oxygen species, it triggers an inflammatory response which attracts immune cells, like neutrophils. The immune cells remove dead and damaged cells and release cytokines, like tumor necrosis factor alpha. The cytokines cause blood vessels to become more permeable to fluid and more immune cells, resulting in bowel edema or swelling of the small intestinal wall. Small bowel ischemia and infarction becomes more severe as the damage extends from just the mucosal layer, called a mucosal infarct, to all layers, known as a transmural infarction. Early on, bowel ischemia can make the bowels simply not work, resulting in an ileus, where food lingers and doesn't get pushed along. Severe damage to the small intestines can also cause a break in the epithelial lining of the small intestines, allowing bacteria in the lumen to get into the blood vessels in the wall. Alternatively, bacteria can completely cross the small intestinal wall and get into the peritoneal space, and from there get into the lymphatics or blood vessels. Ultimately, if bacteria get into the bloodstream, then it can lead to a massive inflammatory response called sepsis. In sepsis, blood vessels throughout the body can get leaky, and if enough fluid moves from the blood vessels into the interstitial space, it can lead to septic shock, which is where organs throughout the body get insufficient blood, and this can lead to organ failure and death. Small bowel ischemia and infarction can happen due to occlusive and non-occlusive causes. Occlusive causes are physical blockages that prevent blood flow through the vasculature, and they usually cause transmural infarcts. This can happen when a thrombus, or a blood clot, forms in the superior mesenteric artery or vein and causes thrombosis, or occlusion of the vasculature. It can also happen when a thromboembolism, which is a piece of a blood clot that's broken off, travels through the blood and becomes lodged in the superior mesenteric artery. Another type of occlusive cause is when something like a tumor, hernias, volvulus, or a twisting of the bowel, or intussusception, which is telescoping of the bowel, physically compresses the vasculature and occludes blood flow. Non-occlusive causes of small bowel ischemia and infarction are related to systemic decreases in blood flow, and they usually cause mucosal infarcts. This can happen in the setting of hypovolemia, due to severe hemorrhage or dehydration, or low cardiac output conditions like after a myocardial infarction. A classic symptom of small bowel ischemia is severe abdominal pain, even though the abdomen itself might be soft and easy to press into. Small bowel infarction usually happens about 12 hours later and commonly causes vomiting and sometimes even bloody diarrhea. Over time, the abdomen can get distended and bowel sounds can go away as the bowel stops moving. In severe cases, when there's sepsis, a person can develop a fever, low blood pressure, and a fast heart rate and breathing rate to help compensate. If fluid accumulates in the abdomen, it can cause signs of peritoneal inflammation, like rebound tenderness and guarding. Early diagnosis of small bowel ischemia and infarction is crucial. An abdominal CT scan can show bowel dilation, bowel wall thickening from edema and inflammation, as well as intestinal pneumatosis, which refers to air in the bowel wall. CT angiography can help visualize blood flow through the small intestines. Typically, lab studies are also done, and these show a high white blood cell count and metabolic acidosis. Treatment of small bowel ischemia and infarction is generally aimed at giving enough fluids, managing pain, and giving antibiotics if needed. Definitive treatment, though, requires reestablishing blood flow through surgery or by using a thrombolytic enzyme if a clot is suspected. Sometimes surgical resection of infarcted tissue might be needed as well. Alright, as a quick recap. Small bowel ischemia and infarction can happen when blood vessels are occluded from something like a blood clot or a nearby tumor, a hernia, a volvulus, or intussusception. It can also happen due to a non-occlusive event, like low blood pressure throughout the body. In either situation, the wall of the small intestines can be severely damaged and inflamed. The result can be anything from an ileus to bacterial peritonitis. Rapid diagnosis by CT scan and treatment to reestablish blood flow are essential to survival. Ultimately, if bacteria get into the bloodstream, then it can lead to a massive inflammatory response called sepsis. In sepsis, blood vessels throughout the body can get leaky.
With malabsorption, nutrients are no longer effectively absorbed in the small intestines. Nutrients can either be macronutrients, such as fats, proteins, and carbs, or micronutrients, like vitamins and minerals. Malabsorption can either be global, meaning that the absorption of all nutrients is affected, or it can be partial, meaning that only specific nutrients cannot be absorbed. Malabsorption presents differently based on which nutrients are being malabsorbed, the severity of the disease, and the underlying cause. Global malabsorption can present with chronic or recurrent diarrhea with pale, greasy, voluminous, and terrible smelling stools and unintentional weight loss. In contrast, partial malabsorption causes symptoms specific to the nutrient involved. With fat malabsorption, symptoms include steatorrhea, meaning fatty stools. To confirm that it's really steatorrhea, a fecal fat test can be done to check for fat. If it's negative and fat malabsorption is still suspected, then a 72-hour stool collection should be done because that's the gold standard for diagnosing fat malabsorption. To do that, an individual has to have a diet that includes 70 to 120 grams of dietary fat per day, which is the equivalent of eating about 300 grams of cheese per day. Stool is collected for 72 hours, and if there's more than 6 grams of fat per day, then it's considered fat malabsorption. Typically, if there is steatorrhea, the stool fat exceeds 20 grams per day. If fat malabsorption is present, then the fat-soluble vitamins A, D, E, and K might also not be getting absorbed. Vitamin A deficiency causes symptoms like night blindness and thickened skin due to hyperkeratosis. Vitamin D deficiency causes symptoms like paresthesias and fractures due to osteomalacia. Vitamin E deficiency can cause symptoms like muscle weakness. And finally, vitamin K deficiency causes symptoms like easy bruising, excessive bleeding from wounds, gastrointestinal bleeds, or hematuria. With protein malabsorption, edema and muscle atrophy may be present, and on the lab tests, there may be hypoalbuminemia and a low total protein level in the blood. With carbohydrate malabsorption, symptoms include watery diarrhea, flatulence, and bloating. To identify carbohydrate malabsorption, the D-xylose test can be done. That's where an individual fasts overnight and then eats 25 grams of D-xylose, which is a monosaccharide that's normally absorbed by the small intestines. The serum D-xylose is checked after an hour, and if it's below 20 milligrams per deciliter, that suggests malabsorption. In addition, urine is collected over the next 5 hours as fasting continues, and if urine excretion of D-xylose is below 4.5 grams, that also suggests malabsorption. False positive results can occur, especially in older individuals with a decreased glomerular filtration rate. Now, malabsorption can also lead to anemia, either because of reduced iron absorption in the small intestine, leading to iron deficiency anemia, or reduced vitamin B12 or folate absorption in the small intestine, leading to megaloblastic anemia. Usually, if the mean corpuscular volume, or MCV, is less than 80 femtoliters, then it's microcytic, and this usually happens with iron deficiency anemia. With iron deficiency anemia, serum iron and ferritin are decreased, and total iron binding capacity, or TIBC, is increased. If the MCV is above 100 femtoliters, then a blood smear is necessary to see if the macrocytic anemia is megaloblastic. If so, vitamin B12 or folate deficiency is the most likely cause, and can be confirmed by obtaining vitamin B12 and folate levels. Now, global malabsorption is caused by diseases that cause damage to the small intestine mucosa, reducing the surface area available for absorption. A common cause of this is celiac disease, sometimes called celiac sprue, which is an autoimmune condition triggered by the gluten found in foods like wheat bread. Individuals can develop symptoms of global malabsorption like chronic or recurrent diarrhea, with steatorrhea, unintentional weight loss, abdominal distension, and bloating. In addition, celiac disease can cause iron deficiency anemia and vitamin B12 and folate deficiency. Celiac disease is also associated with dermatitis herpetiformis, which is a chronic skin condition, along with short stature, delayed puberty, and reduced fertility. The diagnosis of celiac disease starts with checking for immunoglobulin A antitissue transglutaminase antibody, or TTGA-IgA. If TTGA-IgA is positive, then an upper endoscopy with biopsy is done to look for evidence of damage, villus atrophy, and crypt hyperplasia in the duodenal mucosa. If the TTGA-IgA is negative, then total serum IgA levels are obtained. If they're low, then TTGA-IgG and deaminated gliadin peptide, or DGP, are checked. If either one of those is positive, then an upper endoscopy with biopsy is done. Finally, many individuals who suspect having celiac disease can keep a food journal and can try to eliminate gluten from their diet to see if that improves symptoms. Okay, so some individuals and groups are managed slightly differently. For example, those with a first-degree relative with celiac disease get an upper endoscopy with biopsy and have TTGA-IgA levels checked. If both are normal, then celiac disease is unlikely. If either are positive, then total serum IgA levels, TTGA-IgG, and DGP are obtained. In addition, Human leukocyte antigen testing, or HLA testing, is often performed when there seems to be a genetic predisposition, because HLA-DQ2 and HLA-DQ8 are both known to be linked with celiac disease. Another group that gets managed slightly differently are children suspected of having celiac disease. Typically, these children have classic symptoms of celiac disease, but may also have a failure to thrive or pubertal delay. In symptomatic children, a TTGA-IgA is checked, and if it's positive, then an upper endoscopy with biopsy is performed to see if histology is consistent with celiac disease. If there are signs of celiac disease, then the individual is placed on a gluten-free diet to see if symptoms improve. If histology is not consistent with celiac disease, or if symptoms don't improve after a gluten-free diet, then HLA testing is done. However, if the TTGA-IgA is negative, but symptoms suggest celiac disease, then additional tests like total serum IgA levels, anti-endomysium antibody or EMA, and DGP can be done. And if any of these suggest celiac disease, then an upper endoscopy with biopsy is performed. In addition, children with other conditions like autoimmune thyroiditis, type 1 diabetes mellitus, and Down syndrome are at high risk for developing celiac disease. In these children, a TTGA-IgA level is checked. If it's normal, then the workup only continues if symptoms begin. If the TTGA-IgA is slightly elevated, but less than 3 times the upper limit of normal, then the EMA is tested for. If the EMA is negative, then the workup only continues if symptoms begin. Now, if the TTGA-IgA level is above 3 times the upper limit of normal, or if the EMA is positive, then an upper endoscopy with biopsy is performed. If histology suggests celiac disease, then the individual is placed on a gluten-free diet, and if there is no clinical improvement, then HLA testing should be done to see if HLA-DQ2 or DQ8 are present. However, if there is clinical improvement, then celiac disease is confirmed. The main treatment of celiac disease is eliminating the trigger, gluten, from the diet. Because gluten is included in a variety of foods, it requires careful attention to ingredients when buying processed foods. Typically, a gluten-free diet improves symptoms within 2 weeks, and after 6 weeks, the individual should have repeat lab testing, including a complete blood count, folate, vitamin B12, and iron studies, and TTGA-IgA. There should also be a repeat upper endoscopy with biopsy 6 months after being on a gluten-free diet to make sure that there are signs of healing. Another cause of global malabsorption is tropical sprue, and it occurs mostly in a tropical region that includes Haiti, the Dominican Republic, Puerto Rico, and Cuba. The disease may be caused by a pathogen that hasn't yet been identified. The individual typically has global malabsorption symptoms like chronic or recurrent diarrhea with steatorrhea, unintentional weight loss, abdominal distension and bloating, as well as vitamin B12 and folate deficiency. It's a diagnosis of exclusion that requires ruling out infectious and inflammatory causes of diarrhea. That includes doing stool testing for ova and parasites to look for Entamoeba histolytica or Giardia lamblia. Serologic testing starts with TTGA-IgA to identify celiac disease. If the workup is negative for other causes, then an upper endoscopy with biopsy is done to look for evidence of damage, villus atrophy, and crypt hyperplasia in the duodenal mucosa, the same sort of findings as in celiac disease. A key difference is that in tropical sprue, the damage is typically less severe. Tropical sprue is treated with 250 milligrams of tetracycline taken 4 times a day, along with 5 milligrams of folate taken daily for 3 to 6 months. Unfortunately, even with this treatment, relapses sometimes occur. Next up is exocrine pancreatic insufficiency. Here, there's a lack of pancreatic digestive enzymes due to various underlying diseases, and this also causes global malabsorption. Mild exocrine pancreatic insufficiency can be asymptomatic, but moderate or severe exocrine pancreatic insufficiency typically causes global malabsorption symptoms as well as lipid-soluble vitamin deficiencies. The workup for exocrine pancreatic insufficiency includes the fecal elastase 1 test, which is an enzyme produced by the pancreas and can be detected in the stool. If the fecal elastase 1 level is lower than 200 micrograms per gram, it's considered abnormal. Another test is taking the serum trypsinogen level, which is another enzyme produced by the pancreas and activated in the small intestine. And if this is less than 20 nanograms per milliliter, then advanced exocrine pancreatic insufficiency is present. Pancreatic function can be further tested a number of different ways. One way is to stimulate pancreatic secretion by giving an individual the hormone secretin, which stimulates bicarbonate secretion in the pancreas, and then seeing how much bicarbonate is in the duodenal fluid. Duodenal fluid can be collected using an oroduodenal tube that goes through the mouth and into the duodenum, or endoscopically and under sedation. If the bicarbonate in the duodenal fluid is less than 80 milliequivalents per liter, then exocrine pancreatic insufficiency is confirmed, and at that point an extensive workup is done to identify the cause. Some causes include chronic pancreatitis, cystic fibrosis, and pancreatic duct obstruction. In general, however, the treatment of exocrine pancreatic insufficiency is to give an individual capsules that contain mixtures of pancreatic enzymes. Finally, a rare cause of global malabsorption is Whipple's disease, which is called by Trophorema whippleyi. Trophorema whippleyi is a gram-positive bacillus that lives in the environment and spreads through fecal-oral contamination. Although most individuals with the pathogen don't develop any diseases, some develop symptoms. Typically, Whipple's disease causes global malabsorption symptoms and migratory arthralgias of the large joints, but it can also cause dementia and endocarditis. Whipple's disease is rare, and more common conditions like inflammatory bowel disease, connective tissue disease, and infectious diseases should be considered first. But if Whipple's disease is suspected and there are gastrointestinal symptoms, then an upper endoscopy with biopsy should be done. The biopsy can test for T. whippleyi using a periodic acid shift or PAS stain, PCR, or immunohistochemistry to identify the bacilli within the macrophages. Alternatively, if an individual has joint or neurological symptoms, then testing can be done on synovial fluid or cerebrospinal fluid. Treatment for Whipple's disease typically includes an initial phase with intravenous antibiotics that penetrate the blood-brain barrier, such as penicillin or ceftriaxone, followed by a maintenance phase with trimethoprim sulfamethoxazole, which lasts for about a year. An alternative regimen of doxycycline plus hydroxychloroquine can be used, along with trimethoprim sulfamethoxazole, if the individual presents neurological symptoms. Now, some conditions only cause partial malabsorption. For example, lactose intolerance specifically affects absorption of lactose, a type of carbohydrate. In lactose intolerance, there's decreased activity of the enzyme lactase, so lactose cannot get absorbed into the intestines. Individuals develop diarrhea, abdominal pain, flatulence, and bloating after ingestion of milk or other dairy products. Milk and ice cream have the highest concentration of lactose, but the high fat content in ice cream decreases gastric emptying, and this allows some lactose-intolerant individuals to eat ice cream without symptoms. Yay! To diagnose lactose intolerance, a lactose breath hydrogen test is used. In that test, an individual ingests 50 grams of oral lactose and symptoms are initially assessed and a baseline is established on a scale, where 0 means no symptoms and 5 means severe symptoms. During the test, symptoms are identified and scaled as they appear. Additionally, breath hydrogen is checked at the beginning of the test by asking the individual to blow up balloon-like bags to establish the baseline hydrogen, and then again at 30-minute intervals for 3 hours. Normally, very little hydrogen is detected in the breath, but with lactose intolerance, hydrogen is produced when there's undigested lactose in the intestines. If there's an increase of symptoms of 2 over the baseline, or if there's a rise in hydrogen concentration of 20 parts per million over the baseline, then a person is diagnosed with lactose intolerance. Treatment of lactose intolerance consists of reducing or eliminating lactose from the diet, and making sure that a person is getting adequate alternative sources of calcium and vitamin D. Calcium-rich foods include oranges, walnuts, and almonds, and vitamin D-rich foods include mushrooms, fortified foods like cereals, and fish. In addition, replacement lactase enzyme can be given orally along with lactose-containing food. Alright, as a quick recap, fat malabsorption causes steatorrhea, and the gold standard is a 72-hour stool collection, which is positive if there's more than 6 grams of fat per day. Protein malabsorption causes edema and muscle atrophy, and results in hypoalbuminemia and hypoproteinemia. Carbohydrate malabsorption causes watery stools and can be identified with D-xylose serum levels below 20 milligrams per deciliter. There can also be iron, vitamin B12, or folate deficiency, all of which cause anemia. Global malabsorption can be caused by celiac disease, which typically causes an elevated TTGA-IgA level, and on an upper endoscopy, there's evidence of damage, villus atrophy, and crypt hyperplasia in the duodenal mucosa. Sometimes, additional testing like total serum IgA levels, TTGA-IgG, and DGP are done, along with HLA testing to look for HLA-DQ2 and HLA-DQ8. Treatment of celiac disease consists of eliminating gluten from the diet. With tropical sprue, the presentation and biopsy results are similar to celiac disease, but a key difference is that in tropical sprue, the damage is typically less severe. The treatment is tetracycline and folate taken for 3 to 6 months. With exocrine pancreatic insufficiency, fecal elastase 1 is typically below 200 micrograms per gram, and treatment consists of giving exogenous pancreatic enzymes. Whipple's disease is caused by T. whippleii, and it causes malabsorption symptoms along with joint and neurologic symptoms. Diagnosis is based on testing for T. whippleii from an upper endoscopy biopsy, and one treatment regimen includes intravenous penicillin or ceftriaxone, followed by prolonged therapy with TMP-SMX. Partial malabsorption can be caused by lactose intolerance, which can be diagnosed by having an individual ingest 50 grams of oral lactose and then having symptoms or having a rise of hydrogen of 20 parts per million above the baseline. Treatment consists of dietary lactose restriction or elimination.
It's becoming more and more common to see things like gluten-free pizza or gluten-free buns and other gluten-free items at restaurants, grocery stores, or other food-based businesses. This is partly because there's this increasing recognition, awareness, and diagnosis of a disease called celiac disease, in the past called celiac sprue. As many as 1 in 100 people have celiac disease, although many remain undiagnosed. Now, celiac disease is currently understood as an immune system-mediated disorder where the gluten in food triggers the body's immune cells to attack the cells in the small intestine, as well as produce autoantibodies against tissue transglutaminase, also found in the small intestine, as well as other tissues like the heart or the liver. Gluten's found in common wheats and grains, including wheat, rye, and barley. If we take a look at wheat, you've got your individual wheat kernels, and then inside each kernel there's the endosperm, which has a bunch of nutrients for the seed's embryo, mostly protein and starch, and some vitamins. The type of protein here is gluten, the main culprit in celiac disease. Well, really the main culprit behind celiac disease is gliadin, an umbrella term given to a group of gluten peptides that share a 33 amino acid sequence which triggers an immune response. So, if somebody with celiac disease eats a wheat-based pizza, it's broken down in the stomach into gluten peptides and a whole lot of other stuff. That other stuff is no challenge for digestion. Gluten peptides, like the gliadin in wheat, however, are high in proline and glutamine, 2 amino acids which make it a tough little bugger to digest. So, when the undigested gluten proteins like gliadin get to the small intestine, they meet the intestinal mucosa, which is lined with a layer of intestinal epithelial cells. Gluten proteins can then get across the gut epithelial cells, either between them or through the cell, from the apical to the basolateral membrane, and get to the lamina propria, which is a thin layer that lines the gut wall. Once there, an enzyme called tissue transglutaminase, or TTG, cuts off an amide group from the protein. Deamidated gluten proteins are then eaten up by macrophages and served up on its MHC class II molecules. Remember, macrophages are in the gut and are always doing a bit of gut sampling, where they grab proteins, which a lot of times are from foods that we've eaten, and show them to the immune cells. MHC stands for Major Histocompatibility Complex and is that name of the serving platter for the stuff that is served up. It's a normal way to make sure there are no pathogenic bacteria lurking in the gut. Now, there are a ton of different types of MHC class II serving platters, and these serving platters are encoded by genes called human leukocyte antigen genes, or HLA genes. These genes determine what things the MHC class II molecules serve up. So, for example, HLA-DR encodes for an MHC that serves up something different than the one HLA-DQ encodes for. Researchers have noticed that patients with celiac disease typically have specific HLA genes, specifically HLA-DQ2 and HLA-DQ8, which code for MHC serving platters that allow deamidated gliadin to bind tightly. And when deamidated gliadin is tightly bound to these specific MHC serving platters, that's when the immune system kicks in. The macrophage throws it up top and is like, hey, guys, what do you think about this molecule? And T helper cells, also known as CD4 plus T cells from the immune system that recognize the gliadin, zoom over and are like, yep, I'll take it from here. And they release inflammatory cytokines like interferon gamma and tumor necrosis factor, which are molecules that initiate inflammation, directly damaging and destroying epithelial cells in the villi of the small intestine in the process. Not only that, though, the helper T cell stimulates B cells to start pumping out IgA antibodies against gliadin and the tissue transglutaminase enzyme. Of these, anti-tissue transglutaminase antibodies play a role in some of the non-digestive complications of celiac disease. Anti-gliadin antibodies, on the other hand, don't cause any damage. They are, however, helpful in making a diagnosis. Finally, the helper T cells also recruit killer CD8 plus T cells, which is when things get nasty. Killer T cells are drawn to and destroy cells undergoing inflammation. So, in short, as patients eat gluten, the immune system is stimulated and epithelial cells are destroyed. It's possible that the destruction of these cells lets more gliadin across the epithelium since they're not bunched together as tightly as they were before. Now, this whole fiasco mainly happens in the duodenum, probably because it's the first part of the small intestine and so the first to be exposed to gluten. The jejunum and ileum are also involved, but the duodenum is where most of the damage goes down. So, a biopsy of the duodenum shows pretty clearly the extent of the damage. Healthy duodenum should look like this, where you have these really tall villi and these crypts that don't go down too far. With celiac disease, these villi can be destroyed and flattened out, called villus atrophy, and the crypts can get longer. These changes are called crypt hyperplasia, possibly from infiltration of immune cells or from the remodeling process that begins to take place during chronic inflammation. You'll also be able to see this infiltration of immune cells, or lymphocytes, in the epithelium. An endoscopic biopsy of this tissue is generally recommended for diagnosis and monitoring of celiac disease. Children with celiac disease often present with symptoms like abdominal distension or bloating, as well as failure to thrive and diarrhea. Adults typically have chronic diarrhea and bloating as well, but the symptoms vary wildly. Also, patients can frequently have dermatitis herpetiformis as a complication, which actually has nothing to do with the herpes virus. It's actually a bumpy skin rash that pops up from circulating IgA antibodies in the blood, where they mistakenly bind to the transglutaminase in the dermal papillae of the epidermis. Once they've bound, neutrophils swing by and start up an inflammatory reaction that's noticed on the skin as this rash. Tests for the antibodies in the blood can be used clinically to help screen for celiac disease. IgA blood tests for anti-tissue transglutaminase antibodies can be done, and these bear two names, depending on the lab technique used to determine them, so both TTG and endomesial TTG antibodies look for the same thing. They can be effective ways to determine whether someone has celiac disease, especially in more severe cases, although for more common, mild forms of celiac, these tests are less effective. Tests for IgA or even IgG antibodies against deamidated gliadin may also be used. The older anti-gliadin antibodies are not very accurate and in general should not be used. For reasons that aren't well understood, people with celiac disease have a somewhat higher risk of being IgA deficient, meaning they aren't able to produce any IgA antibodies in general, so in this case they'd need to have an IgG screening test done. Now, the main bad guy in this whole story that provokes the immune system and causes this whole mess is gluten. So, symptoms and issues typically resolve when patients adopt a gluten-free diet. For some patients that start to adhere to a gluten-free diet, even for many years, there's still an increased risk of refractory disease, like small bowel cancer and T-cell lymphoma, presumably due to inflammation and immune system activation over time. While avoidance of gluten can lead to control of celiac disease, this is a challenging diet, and removal of all gluten from the diet is nearly impossible. It's worth mentioning that there's very little solid scientific evidence to back a removal of gluten from the diet unless you do have celiac disease, although some people do seem to have improved GI symptoms on a gluten-free diet. Whether that's from removing gluten specifically or more broadly an adherence to a diet that's typically much lower in processed foods and carbohydrates remains to be seen. Alright, as a quick recap, celiac disease is an immune-mediated system disorder where the gluten in food triggers the body's immune cells to attack the cells in the small intestine, as well as produce autoantibodies against tissue transglutaminase. Children with celiac disease often present with symptoms like abdominal distension or bloating, as well as failure to thrive and diarrhea. Adults typically have chronic diarrhea and bloating as well, but the symptoms vary wildly. Blood tests like anti-TTG antibodies and anti-deamidated gliadin antibodies can be used, in addition to small intestinal biopsy, to diagnose the disease. Symptoms of celiac disease improve on a gluten-free diet, but there is little evidence that removal of gluten from the diet has any benefit for people without celiac disease.
The most common forms of sugar are glucose, fructose, and galactose. And these are all types of monosaccharides, meaning they're made up of just one sugar molecule. Molecules like this are called carbohydrates because they're made up of carbon, hydrogen, and oxygen, usually with a hydrogen-oxygen ratio of 2:1. If you link two of these guys together, you get a disaccharide because di means two. And this is also a carbohydrate. Now, our body uses these sugar molecules for energy, right? For us humans, glucose is our gasoline, our energy source. We'll take galactose and fructose, but ultimately we need to use glucose. So almost all the fructose and galactose we ingest is converted to glucose. And then we use that glucose for energy. Alright, but usually carbohydrates aren't in the monosaccharide form when we ingest them. And a lot of what we take in are in the disaccharide form. And one notorious disaccharide that tends to cause serious gastrointestinal distress for a lot of people is lactose. Now, lactose is a disaccharide that's made up of a glucose molecule and a galactose molecule. For us to use it as energy, though, we have to first break it down to those two monosaccharides. In the milk of most mammals, lactose is generally the major carbohydrate. So when you have a glass of milk and it gets through your stomach, the small intestine, that lactose gets chopped into glucose and galactose by an enzyme that's fittingly called lactase. The gene responsible for the production of the lactase enzyme is expressed exclusively in the enterocytes lining the small intestine, which are cells that help absorb nutrients from the stuff we eat. Once produced, that enzyme makes its way to the cell surface, along the cell's microvilli, these little tentacles that help increase surface area and absorb nutrients. Okay, once lactose gets chopped by lactase, we're good to go, and we absorb the glucose and galactose and all is well. Now, as mammals, we're wired to be able to ingest milk after birth, right? So it makes sense that when we're young, we have a whole bunch of lactase enzyme, since that's pretty much all we drink. After weaning, in most mammal species, expression of the gene responsible for lactase is way downregulated, and so production of lactase also goes way down. The majority of humans actually follow this protocol as well, and downregulate lactase production around 3 to 5 years of age. Interestingly though, the majority of Caucasians, mainly those from Northern European background, continue having elevated lactase activity all the way into adulthood, and so they exhibit lactase persistence. Why Caucasians? Well, this group historically has domesticated cows and other milk providers and consumed lactose-based or milk-based products into adulthood. And by natural selection, it's thought that they've developed increased persistence of lactase production by specific gene mutations that are often autosomal dominant. Similar lactase persistence phenomena has been observed in separated and distinct smaller populations that rely on lactose production as well. Pretty interesting stuff, if you ask me. At any rate, what about those of us that didn't inherit the lactose persistence gene? And every time we even think about milk or dairy products, our bowels give out a small groan. Well, when that lactose gets to the brush border of your small intestine, the vast majority of it doesn't get chopped and absorbed, as much as 75%. And it just keeps on moving down the GI tract and passes into the colon. At this point, the gut flora has an absolute field day, since microbes aren't as picky and they ferment the lactose into a mix of hydrogen gas, carbon dioxide, and methane. These gases contribute to the symptoms of gas and bloating. Along with those gases, though, short-chain fatty acids are produced like acetate, butyrate, and propionate. We don't absorb these short-chain fatty acids, which means that they stay in the lumen of the gut. Both the unabsorbed lactose and products of fermentation raise the osmotic pressure, which attracts water into the bowels. So water flows in, and this influx of water is what leads to diarrhea. Now, in super rare cases, lactase deficiency can be congenital, meaning infants would be deficient from birth. This is an autosomal recessive disorder, and infants that can't break down lactose have trouble with breast milk and develop diarrhea starting from birth. Sometimes even those with lactase persistence can develop temporary lactose intolerance as a result of infection or inflammation of the small intestine. During these acute illnesses of the small intestine, the microvilli of enterocytes can be flattened or damaged, and since these are the dwellings of our lactase enzyme friend, these acute illness states can cause a lack of lactase enzyme and result in temporary lactose intolerance. Once the small bowel heals, though, they'll be able to produce lactase again. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media.
In short bowel syndrome, bowel is another word for the intestines. This is a condition that occurs when either the small intestine and/or the large intestine become physically shorter when a portion is removed by surgery, or functionally shorter when a portion is damaged in a way that makes it non-functional. This can lead to poor absorption of water and vital nutrients from food. Normally, digestion begins when food is chewed and travels into the stomach where it's dissolved by stomach acid, enzymes, and physical churning. Then, it's sent to the first portion of the small intestine, which is called the duodenum. This is where more enzymes are added from the pancreas to digest macronutrients, including proteins, carbohydrates, and fats, while bile is added from the liver and the gallbladder to help absorb fats. It's also where the absorption of some minerals like calcium, iron, and magnesium begins. The next section is called the jejunum, and it has long projections on its surface, giving it a large surface area for absorption. It plays the biggest role in the digestion and absorption of most nutrients, including the breakdown products of macronutrients, zinc, water-soluble vitamins, and fat-soluble vitamins, namely A, D, E, and K. The third section is called the ileum, and it has tight intercellular junctions, allowing it to efficiently absorb fluid and begin concentrating the intestinal contents. Unlike the jejunum, The ileum is also capable of undergoing structural and functional adaptations to compensate for the jejunum if needed. The final portion is called the terminal ileum, and it absorbs vitamin B12 and bile salts, which are recycled. It ends with the ileocecal valve, which prevents intestinal contents from going into the large intestine too quickly, and the backward flow of material. The large intestine functions to absorb water, electrolytes like sodium and potassium, short-chain fatty acids, and bacteria within it produce vitamin K. Since each part of the small intestine has a specialized function, as does the large intestine, the manifestations of short bowel syndrome depend on which portion is no longer functioning normally. Diarrhea can result from intestinal contents moving too quickly, or from food intolerances due to loss of certain enzymes. This can lead to life-threatening dehydration. An inability to absorb certain vitamins and minerals can lead to a large range of signs and symptoms, while malabsorption of macronutrients leads to malnutrition and weight loss. Short bowel syndrome can be present at birth, but typically occurs when part of the small bowel is removed during surgery. Common conditions requiring this include necrotizing enterocolitis in babies and Crohn's disease in adults. Any condition that injures the small intestine and makes part of it non-functional can cause the condition even if the intestinal length is normal. Diagnosis includes the medical history, lab tests looking for nutritional or electrolyte deficiencies or a resulting anemia, imaging such as abdominal X-ray, barium studies or MRI, and endoscopy of the upper and lower intestines. Treatment depends on the symptoms. Mild cases may require dietary adjustments with slowly increasing food and water intake, supplements, and diarrhea medications. Severe cases may include total parenteral nutrition, or TPN, which provides intravenous nutrition and fluids, and an eventual small bowel transplant. Alright, as a quick recap. Short bowel syndrome occurs when either the small intestine and/or the large intestine become physically or functionally shorter. This leads to malabsorption of water and nutrients, and can cause a wide variety of symptoms, depending on the section of bowel involved. Diagnosis depends on the medical history, lab tests, and abdominal imaging, while treatment may include dietary adjustments, diarrhea medications, and TPN.
Tropical sprue is a gastrointestinal disease that results in malabsorption of nutrients in water. Just like other sprue diseases, like celiac sprue, which is more often known as celiac disease, in tropical sprue the villi of the small intestine become flattened, but the exact cause of this isn't known. The biggest clue is that tropical sprue seems to mostly affect individuals living in the tropical regions of the world, like the Caribbean, India, and Southeast Asia. The most widely accepted theory is that an acute intestinal infection, which could be bacterial, viral, or protozoal, initially damages the intestinal lining, and this causes the first bit of inflammation. In response, the intestinal cells secrete enteroglucagon, which is a hormone that decreases intestinal motility. Decreased motility means that food's allowed to linger in the intestines for longer than usual. More food means more resources, so this sets the stage for a change in the normal bacterial flora, which leads to bacterial overgrowth. Bacterial overgrowth refers to the idea that some organisms begin to overpopulate and therefore dominate the bacterial ecosystem of the intestines. In tropical sprue, Klebsiella, E. coli, and Enterobacter end up becoming these dominant bacteria. These guys release toxic byproducts as they ferment the food that lingers in the gut, and these toxins can damage the intestinal lining, leading to more inflammation. Over time, all this chronic inflammation leads to villus atrophy, which is flattening of the villi that line the small intestine. Villi are important because they provide surface area and digestive enzymes necessary for nutrient absorption. Flattening of the villi reduces this surface area, which means less nutrients and water can be absorbed across the intestinal wall, which leads to malabsorption. This 1 means more food is left behind for the bacteria, which leads to more intestinal wall injury and inflammation. And 2, the malabsorption also causes depletion of vitamin B12 and folate over time. Unfortunately, folate's needed to help maintain the integrity of the intestinal mucosa. So as levels fall, it also further contributes to the intestinal wall injury and inflammation. Tropical sprue typically affects adults, and the usual pattern is of a chronic disease with exacerbations or flare-ups from time to time. The most common symptoms are related to intestinal injury and malabsorption, and are diarrhea, abdominal pain, fatigue, weight loss, and dehydration. One complication that can result from malabsorption of vitamins like folate and vitamin B12 is megaloblastic anemia, where the bone marrow produces large, immature red blood cells. The diagnosis of tropical sprue is usually made in individuals who have lived in the tropics and have long-standing gastrointestinal symptoms and malabsorption. Fat malabsorption can be investigated by doing a 72-hour stool collection test while on a prescribed diet. Also, though, carbohydrate malabsorption can be assessed using a D-xylose absorption test. Normally, if it's absorbed in the intestines, it gets into the bloodstream and ultimately gets filtered into the urine. If it's not absorbed, though, less eventually gets excreted in the urine. So these people end up with less D-xylose in their urine. In addition, imaging techniques can also be used to help make a diagnosis. For example, endoscopy can be used to see villus atrophy, and a barium swallow might show intestinal wall thickening, which often happens with chronic inflammation. The ultimate gold standard, though, would be a tissue biopsy of the jejunum to directly visualize the intestinal inflammation in villus atrophy. Treatment for tropical sprue typically involves using antibiotics to reduce the bacterial overgrowth, and nutrition replacement to deal with specific deficiencies like folate and vitamin B12. Sometimes these treatments have to be given for up to a year because of the chronic nature of the problem. Alright, so to recap. Tropical sprue is a gastrointestinal disease that's thought to be the result of bacterial overgrowth, most commonly of Klebsiella, E. coli, and Enterobacter species. These bacteria release toxic substances as they ferment the food in the small intestines, which can lead to chronic inflammation and subsequent flattening of the small intestinal villi, which ultimately results in malabsorption and the related abdominal symptoms. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. Appendicitis is when the appendix gets inflamed, and it's the most common surgical emergency of the abdomen. Normally, the appendix can be found in a retrocecal location, as well as pre-ileal, post-ileal, pelvic, and subcecal. Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube. That something could be a fecalith, a hardened lump of fecal matter, an undigested seed, a benign or malignant tumor, or even intestinal parasites like pinworms. Another cause of obstruction, especially in children and adolescents, is lymphoid follicle growth, also called lymphoid hyperplasia. Lymphoid follicles in the appendix grow in size during adolescence, and they can sometimes obstruct the tube. Exposure to viral infections like adenovirus and measles or having inflammatory bowel disease can also cause these follicles to grow as well. Early on, acute appendicitis presents with periumbilical abdominal pain, as it stimulates the visceral nerve fibers from T8 to T10, causing this vague, central referred pain. In addition, individuals usually present fever, loss of appetite or anorexia, nausea, and vomiting. Sometimes there can be other atypical symptoms like indigestion, flatulence, diarrhea, and malaise. Within 24 to 48 hours, the appendix becomes more swollen and inflamed, and it starts to irritate the parietal peritoneum on the abdominal wall, causing somatic pain that's more severe and localized to the right lower quadrant, as well as causing a fever. This classic migration of pain may not be seen in children under 3 years old. There are some specific signs for appendicitis that can be elicited upon palpation. McBurney's sign is tenderness at McBurney's point, which is located 1/3 of the distance from the anterior superior iliac spine to the belly button. And it's a classic sign of appendicitis. Another sign of appendicitis is Rovsing's sign, which is when palpation of the left lower quadrant causes pain in the right lower quadrant. The obturator sign happens when the inflamed appendix lies in the pelvis and causes irritation of the obturator internus muscle, leading to pain upon internal rotation of the right hip. The iliopsoas sign is when there's pain on extension of the right hip, which is found in retrocecal appendicitis. Now, if obstruction persists, the pressure in the appendix increases even more, and the appendiceal walls become weaker and weaker, up to the point where the appendix might rupture. Perforation of the gastrointestinal tract allows bacteria to escape the appendix and get into the peritoneum. An important and early sign of peritoneal irritation is abdominal guarding, which is when an individual tightens their abdominal muscles during palpation to try and avoid pain. Blumberg's sign, also referred to as rebound tenderness, refers to palpation and quick release, with pain felt upon release of pressure, again a sign of peritoneal irritation. Peritoneal inflammation due to an intra-abdominal process like perforation, also known as secondary peritonitis, can be localized initially, and then progress to becoming generalized. In that case, the same pain patterns will present throughout the abdomen, not just in the right lower quadrant. In addition, there are often associated systemic inflammatory or septic symptoms like fever, tachycardia, and hypotension, and individuals appear generally unwell or are in distress. Diagnosis of appendicitis can be supported by laboratory tests. Typically, in blood tests, the white blood cell count is elevated with a neutrophil predominant, and there's an elevated CRP. Blood tests might also show dehydration or fluid and electrolyte imbalances. A urinalysis should be done to rule out genitourinary conditions as the cause of abdominal pain. Irritation of the bladder or ureter by an inflamed appendix might result in mildly elevated urinary white blood cell count, while a significant elevation suggests there's a urinary tract infection. In addition, to rule out ectopic pregnancy, postmenarcheal pediatric cases should get a urine pregnancy test, and adult females should obtain a serum pregnancy test. Now, the predictive value of each individual clinical and laboratory finding in appendicitis is relatively poor, due to their low sensitivity and specificity, but their value can be cumulative when found together. The Alvarado score is a validated numerical decision tool designed to take advantage of this, and help diagnose appendicitis based on the presence or absence of 3 clinical signs: right lower quadrant pain, fever, and rebound tenderness; 3 symptoms: migratory pain, anorexia, and nausea or vomiting; and 2 lab findings: leukocytosis greater than 10,000 and left shift greater than 75% neutrophils. Right lower quadrant tenderness and leukocytosis are given 2 points, while the rest of the parameters are given 1 single point. In general, a score of 7 or higher indicates a high probability of acute appendicitis, and should be sent for surgery. Now, in children, the Alvarado score has been shown to help in the diagnosis, but was not accurate enough to use alone. The surgical goal of appendicitis is to operate early, before appendiceal rupture and peritonitis develop. In individuals with classic findings or a high Alvarado score, diagnosis of appendicitis is clinical, so they might be taken for immediate surgery without imaging studies, while individuals with atypical presentation may need further testing to rule out conditions like bowel obstruction, ovarian or testicular torsion, and kidney stones. Plain abdominal radiography is not useful in making the diagnosis of appendicitis, and should not be routinely obtained. Ultrasound and CT scan are appropriate first choices. CT scan can also be done as follow-up if the ultrasound is inconclusive. MRI is recommended over CT scan in pregnant women and children who can cooperate, to minimize radiation exposure, but it often can't be done emergently. On ultrasound, there's usually an enlarged appendix with a diameter of more than 6 millimeters, as well as tenderness over the appendix with compression of the ultrasound probe. If there's an abscess, there might be increased echogenicity of the inflamed periappendiceal fat, and in severe cases there might be an appendicolith, which is a calcified deposit within the appendix. CT scan or MRI features of acute appendicitis include an enlarged appendix, an appendiceal wall thickening of more than 3 millimeters, periappendiceal fat stranding, appendiceal wall enhancement, and there may also be evidence of an abscess. The standard treatment for uncomplicated appendicitis is appendectomy, which is surgical removal of the appendix. Both open and laparoscopic approaches might be used. For an acute intact non-perforated appendicitis, an appendectomy should be done within 24 hours of diagnosis. Preoperative management includes intravenous rehydration, analgesia, correction of electrolyte abnormalities, and administration of prophylactic antibiotics. Antibiotics should be administered as soon as the diagnosis of appendicitis is established, and at least 30 minutes before the surgical incision is made. Generally, individuals are given a single intravenous dose of 2 grams of a second-generation cephalosporin, like cefoxitin or cefodotan, or the combination of 2 grams of cefazolin plus 500 milligrams of metronidazole. While individuals allergic to penicillins and cephalosporins might get clindamycin plus ciprofloxacin, levofloxacin, gentamicin, or aztreonam. Appendicitis is considered advanced or complicated when perforation or gangrene is developed. Individuals with unstable perforated appendicitis, meaning it's caused generalized peritonitis or hemodynamic instability, require emergency appendectomy, as well as irrigation and drainage of the peritoneal cavity. After surgery, individuals might be started on a clear liquid diet and advanced as tolerated to a regular diet. It might be discharged once they tolerate a regular diet and are afebrile. Postoperative antibiotics are generally only given to children with advanced appendicitis, and in that situation, IV antibiotics are continued until they can tolerate a regular diet and are afebrile. Children who are still febrile or unable to tolerate a regular diet 7 days after surgery might have an abdominal or pelvic abscess and should have diagnostic imaging studies done. Now, stable individuals with complicated appendicitis who have symptoms localized to the right lower quadrant, meaning there's no generalized peritonitis, can be treated with antibiotics and intravenous fluids, rather than immediate surgery, since a non-operative approach in these cases is associated with fewer complications. These individuals will often have a palpable mass on physical examination, and imaging studies might reveal a phlegmon, an area of local tissue inflammation, or an abscess. If there's a phlegmon, then individuals are kept on IV antibiotics and repeat imaging is often performed to follow the resolution or progression of the phlegmon, and to make sure that it doesn't develop into an abscess. On the other hand, if there's an intra-abdominal or pelvic abscess, then individuals are kept on IV antibiotics, and should have CT or ultrasound-guided percutaneous drainage. Immediate appendectomy is an alternative option if the abscess is not amenable to percutaneous drainage. Now, if individuals who didn't get immediate surgery fail initial antibiotic therapy, they require rescue appendectomy, whereas those who respond to initial antibiotic therapy can be discharged with oral antibiotics to complete a 7 to 10 day course and return for follow-up in 6 weeks. Now, some individuals may elect to undergo immediate elective appendectomy for complicated appendicitis, as this can allow them to go back to normal function faster, but there may be a higher risk of operative complications. A significant number of individuals may also undergo a delayed elective appendectomy after an interval of 6 to 8 weeks following antibiotic therapy, because the non-operative approach has been associated with recurrent disease and increased hospital visits. In conclusion, the most appropriate management strategy should be personalized to the individual. Alright, as a quick recap. Appendicitis initially causes nausea, vomiting, fever, and periumbilical abdominal pain that then migrates to the right lower quadrant. Classic signs include McBurney's sign, Rovsing's sign, the obturator sign, and the iliopsoas sign. If the appendix ruptures, it can cause peritonitis, which can cause abdominal guarding and Blumberg's sign. Typically, there's an elevated white blood cell count with a neutrophil predominance, and an elevated CRP. The Alvarado score can help risk stratify individuals who should undergo imaging or immediate treatment. Ultrasound and CT scans are appropriate first choice for imaging studies, while MRI is recommended over CT scan in pregnant women and children who can cooperate. For acute non-perforated appendicitis, immediate appendectomy should be performed within 24 hours of diagnosis. Preoperative management includes intravenous rehydration, analgesia, correction of electrolyte abnormalities, and prophylactic antibiotics. Stable individuals with perforated appendicitis who have a phlegmon of the right lower quadrant can be given IV antibiotics without immediate surgery. Individuals with an intra-abdominal or pelvic abscess can be given IV antibiotics and have a CT or ultrasound-guided percutaneous drainage. Immediate appendectomy is an alternative option if the abscess is not amenable to percutaneous drainage. Those who fail initial antibiotic therapy require rescue appendectomy, whereas those who respond to initial antibiotic therapy can be discharged with oral antibiotics to complete a 7 to 10 day course. Finally, individuals who wish to have a shorter recovery may elect to have immediate elective appendectomy, and those who respond to antibiotics may benefit from a delayed elective appendectomy after 6 to 8 weeks to avoid a recurrent disease.
Appendicitis refers to inflammation of the appendix, which is usually caused by obstruction of the appendiceal lumen by tumors, fecaliths or hard fecal masses, and lymphoid hyperplasia. When the appendix is obstructed, the pressure inside it increases. This causes local stasis of lymphatic flow, occlusion of small vessels, and bacterial overgrowth, which can eventually lead to ischemia and necrosis of the appendix. Now, appendicitis can be classified as uncomplicated or complicated. In uncomplicated appendicitis, the appendix is only inflamed, while in complicated appendicitis, it may develop perforation, phlegmon, or abscess. If you suspect appendicitis, the first thing you should do is an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, which usually results from sepsis, you should first stabilize their airway, breathing, and circulation. This means that you may need to intubate the patient, establish IV access, or administer fluids before continuing with your assessment. However, if your patient is stable, your next step is to obtain a focused history and physical examination, as well as labs such as a CBC and CRP. Now, history typically reveals abdominal pain, which starts around the umbilicus and migrates to the right lower quadrant. Additionally, the patient might report fever, nausea, vomiting, and anorexia. On physical examination, individuals usually present with tenderness in the affected area, most commonly the right lower quadrant, especially at a region called McBurney Point, located 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Some additional physical exam findings that can help you recognize appendicitis include the Rofsing, psoas, and obturator signs. A Rofsing sign is positive when you palpate your patient's left lower quadrant and your patient feels pain in the right lower quadrant. This indicates peritoneal irritation of the right side of the abdomen. On the other hand, a psoas sign is positive when passive extension of the patient's right hip causes right lower quadrant pain. This indicates an inflammation of an appendix that is retrocecal, or situated behind the cecum. Finally, the obturator sign is positive if internal rotation of the hip with the knee and hip flexed causes pain in the patient's right lower quadrant. This may indicate an appendix located in the pelvis. Lastly, it's extremely important to evaluate for peritoneal signs, such as local or diffuse rebound tenderness, as well as rigidity and guarding. Now, when it comes to labs, you might see leukocytosis with a left shift and an elevated CRP. These lab findings are not specific for acute appendicitis, but may support the diagnosis. Alright, if you suspect acute appendicitis based on the history, physical examination, and lab findings, make sure to initiate acute management. This includes starting IV fluids, as well as administering antiemetics and pain medications as needed. Additionally, you should keep the patient NPO. After initiating the acute management, your next step is to confirm the diagnosis. To do this, order a CT scan of the abdomen and pelvis with IV contrast to assess the appendiceal diameter and wall thickness and whether any fat stranding is present. A high-yield fact to remember is that some institutions prefer starting with an ultrasound because it's quicker, more cost-efficient, and avoids radiation exposure. This is especially important in the pediatric population. If the imaging reveals an appendiceal diameter of less than 6 millimeters, appendiceal wall thickness of less than 3 millimeters, and no fat stranding around the appendix, then appendicitis is unlikely, so you should consider other diagnoses, such as mesenteric adenitis. On the other hand, if the imaging reveals a dilated appendix with a diameter greater than 6 millimeters, thickening of the appendiceal wall greater than 3 millimeters, and fat stranding around the appendix, it confirms the diagnosis of uncomplicated appendicitis. Sometimes imaging reveals appendicitis with either an abscess, phlegmon, or extraluminal air, or a combination of these findings. In all of these cases, think of complicated appendicitis. Additionally, you might even see a small calcified deposition within the appendiceal lumen, which is also referred to as appendicolith. Keep in mind that appendicolith is not a complication, but an important risk factor that can eventually lead to perforation. Here is some high-yield information to keep in mind. When deciding on the appropriate imaging modality for your patient, you should pay attention to two groups: pediatric and pregnant individuals. In these cases, you should try to avoid radiation exposure, so you'd first do an ultrasound of the right lower quadrant. An ultrasound may reveal a non-compressible appendix with an increased reflection of the fat around the appendix. If the ultrasound findings are still unclear, you can order an MRI of the abdomen. Alright, now that imaging is all clear, pun intended, let's talk about treatment. First, let's start with uncomplicated appendicitis, which can be treated either non-surgically or surgically. Typically, the initial treatment is with non-surgical management, which includes IV antibiotics for 1 to 3 days, followed by oral antibiotics for a total of 7 to 10 days. Make sure to choose an antibiotic that covers intestinal flora and anaerobes, so possible options include penicillin with a beta-lactamase inhibitor, or a combination of metronidazole with either a fluoroquinolone or a third-generation cephalosporin. After giving non-surgical management, serial abdominal exams should be performed to check if the antibiotics are working. In fact, the main indication for surgical management in patients with uncomplicated appendicitis is a worsening of serial abdominal exams despite antibiotics, which means it's progressing to complicated appendicitis. Other indications for surgical management include being immunocompromised, having a history of IBD or pregnancy, as well as the presence of appendicolith on imaging. If your patient falls into any of these categories, they require an urgent appendectomy. Now that we are done with uncomplicated appendicitis, what should you do if the CT reveals findings of complicated appendicitis, such as perforation, phlegmon, or abscess? First, let's focus on appendicitis associated with perforation. You should start the patient on IV antibiotics and consult surgery for a potential emergency appendectomy. Next up, if appendicitis is associated with a phlegmon, you can usually treat it non-surgically with IV antibiotics while monitoring your patient's response. If the patient improves, you can discharge them and continue oral antibiotics to complete a total of 7 to 10 days. Also, don't forget to schedule an appendectomy in 6 to 8 weeks. On the other hand, if the patient's symptoms don't improve or even worsen, the patient should get an urgent appendectomy and continue IV antibiotics to complete 7 to 10 days. Finally, if a patient has appendicitis complicated by an abscess, you can treat them with IV antibiotics and abscess drainage, either percutaneously or surgically. If the abscess is small, or less than 3 centimeters, it might be too challenging to reach the abscess percutaneously. So, in that case, the patient should get an urgent appendectomy and IV antibiotics. Once the patient is released from the hospital, you can switch them to oral antibiotics for a total of 7 to 10 days. In contrast, if the abscess is large or greater than 3 centimeters, it's often possible to drain the abscess percutaneously. Now, sometimes the abscess can be located in an area that can't be reached percutaneously. In this case, consider an urgent appendectomy. Regardless of the procedure, make sure to continue antibiotics for a total of 7 to 10 days. Alright, as a quick recap, once you suspect appendicitis based on history and physical findings, obtain a CT scan to confirm the diagnosis. Uncomplicated appendicitis is typically treated with IV antibiotics. However, individuals with risk factors might need an urgent appendectomy. On the other hand, complicated appendicitis can be associated with perforation, phlegmon, or abscess. All patients with complicated appendicitis should receive IV antibiotics. Additionally, individuals that present with perforation require emergent appendectomy, while patients with a phlegmon can respond well to IV antibiotics only. If the patient with phlegmon improves, you can switch them to oral antibiotics and schedule an appendectomy in 6 to 8 weeks. But if they don't improve, they might need an urgent appendectomy. Finally, depending on the size and location, an abscess can be treated with either appendectomy or drainage.
While in the emergency department, Bella, a 22-year-old woman, presents with abdominal pain that started 6 hours ago. The pain was initially located around the umbilical area, but it has migrated to the right lower quadrant in the past few hours. The pain is sharp, like being stabbed with a knife, and it gets worse with movement. A physical examination showed tenderness of the right lower quadrant, with moderate guarding, and a low-grade fever of 100.4 degrees Fahrenheit. Shortly after, Edward, who's 11, presents with generalized abdominal pain, with vomiting and diarrhea. On examination, he appears ill and has a temperature of 104 degrees Fahrenheit. His abdomen is tense, with generalized tenderness and guarding. No bowel sounds are present. Blood tests were ordered in both cases, detecting an increased white blood cell count of 12,000 cells per microliter, with 85% neutrophils. Now both people have appendicitis. Now the appendix is the little close-ended hollow tube that's attached to the cecum of the large intestine. And sometimes it's called the vermiform appendix, where vermiform means worm-shaped. Normally, the appendix can be found in a retrocecal location, as well as pre-ileal, post-ileal, pelvic, and subcecal. Its function is actually unknown, though some theories suggest it might be a safe house for the gut flora, and that it plays a part in the lymphatic and immune system. Okay, so appendicitis usually occurs because something gets stuck and obstructs the appendix. That something could be a fecalith, which is a hardened lump of fecal matter, a piece of undigested material like gum or seeds, or even a clump of intestinal parasites like pinworms. Another cause of obstruction could be lymphoid follicle growth, also called lymphoid hyperplasia. And a high-yield fact is that unlike a fecalith, this is more common in children. Now, because the intestinal lumen is always secreting mucus and fluids from its mucosa, fluid and mucus build up in the obstructed appendix, which increases the pressure inside. This makes it grow in size, and it will physically push on the nearby afferent visceral nerve fibers, causing abdominal pain. Along with that, the flora and the bacteria in the gut, usually E. coli and Bacteroides fragilis, will multiply in the appendix. This triggers the immune system to recruit white blood cells, and pus starts to accumulate, resulting in full-blown inflammation of the appendix. As the pressure keeps growing and the appendix continues to swell up, it will push on and compress nearby small blood vessels, causing ischemia and local necrosis. For your tests, remember that as a consequence, inflammation extends to the serosa of the appendix, where it begins to spread to the parietal peritoneum, irritating it. The growing colony of bacteria can then invade the wall of the appendix, causing more inflammation, and the wall becomes weaker and weaker to the point where the appendix can rupture. This is one of the worst complications of appendicitis, as it allows bacteria to escape into the peritoneum and cause peritonitis. Regarding symptoms, all you need to know is that acute appendicitis typically starts with nausea, vomiting, fever, and periumbilical abdominal pain due to visceral nerve irritation. Within 24 to 48 hours, the appendix becomes more swollen and inflamed, and it irritates the abdominal wall, causing the pain to get more severe and migrate to the right lower quadrant, as well as causing a fever. Also, it's a good idea to memorize some of the classical signs of this disease. First is McBurney's sign, which is tenderness at McBurney's point, which is located 1/3 of the distance from the anterior superior iliac spine to the belly button. Another sign is Rovsing's sign, which is palpation of the left lower quadrant and moving along the path of the large intestine towards the right. This will push the contents in the bowel towards the appendix, further irritating it, causing pain in the right lower quadrant. The obturator sign is when the person flexes the hip and knees to 90 degrees while lying down, and the clinician rotates the hip internally. Since the inflamed appendix lies in the pelvis, it will cause irritation of the obturator internus muscle when this maneuver is performed. Finally, we have the psoas sign, where the person lies on their left side and the clinician extends the right hip. Since the appendix borders the psoas muscle, when it's stretched by hip extension, the friction will lead to pain. An important and early sign of peritoneal irritation is abdominal guarding, which is when an individual tightens their abdominal muscles during palpation to try and lessen the pain. Then, there's Blumberg's sign, also known as rebound tenderness, where a deep palpation and quick release causes pain during the release. Diagnosis of appendicitis can be done with laboratory and imaging tests. For your exam, you need to know that blood tests will show increased white blood cell count with a neutrophil predominance of around 85%. Blood tests may also show dehydration or fluid and electrolyte imbalances. Don't forget that further investigation is needed to rule out other causes of abdominal pain. A urinalysis should be done to rule out genitourinary conditions. Irritation of the bladder or ureter by an inflamed appendix may result in mildly elevated urinary white blood cell count, while a significant elevation suggests there's a urinary tract infection. In addition, remember to rule out an ectopic pregnancy in females of childbearing age. Postmenarchal pediatric cases should get a urine pregnancy test, and adults should obtain a serum pregnancy test. When it comes to imaging, ultrasound is the first choice. It usually shows an enlarged appendix with a diameter of more than 6 millimeters, as well as tenderness over the appendix with compression of the ultrasound probe. If there's an abscess, there may be increased echogenicity of inflamed periappendiceal fat. And in severe cases, there may be an appendicolith, which is a calcified deposit within the appendix. A CT scan is done as a follow-up if the ultrasound is inconclusive. MRI is recommended over CT in pregnant women and children who can cooperate to minimize radiation exposure. Common findings include an enlarged appendix, appendiceal wall thickening of more than 2 millimeters, periappendiceal fat stranding, appendiceal wall enhancement, and there may also be evidence of an abscess. The standard treatment for appendicitis is surgical removal of the appendix, or appendectomy. The goal is to operate early, before appendiceal rupture and peritonitis develop. Now for the future, keep in mind that those with classic findings may be taken for immediate surgery without imaging studies, as delays may result in perforation or rupture of the appendix, while individuals with atypical presentation may need further testing to rule out other causes of abdominal pain. Alright, so let's review. Appendicitis initially causes nausea, vomiting, fever, and periumbilical abdominal pain that then migrates to the right lower quadrant. Classic signs include McBurney sign, Rovsing sign, the obturator sign, and the Psoas sign. If the appendix ruptures, it can cause peritonitis, which can cause abdominal guarding, and Blumberg sign. Diagnosis includes blood tests. Typically, there's an elevated white blood cell count with a neutrophil predominance. Ultrasound is the preferred choice for imaging, while a CT scan is done as a follow-up if the ultrasound is inconclusive. MRI is recommended over a CT scan in pregnant women and children who can cooperate. Treatment usually consists of appendectomy. Alright, back to our cases. Bella came in with fever and abdominal pain located around the umbilical area, which has migrated to the right lower quadrant, a classical presentation of appendicitis. Since there's also moderate guarding, peritonitis is a possibility. Blood tests showed increased white blood cell count with 85% neutrophils, and if an abdominal ultrasound or CT were to be taken, it might show signs of appendix inflammation. Her typical clinical picture, alongside suggestive blood test, is enough to diagnose appendicitis. Edward presented with generalized abdominal pain, vomiting, and diarrhea. On examination, he appeared ill and had a temperature of 104 degrees Fahrenheit and abdominal guarding. Blood tests showed increased white blood cell count with 85% neutrophils. Although his clinical picture is not exactly typical, it is still suggestive of appendicitis, which should be confirmed by either ultrasound or CT.
The appendix is the little one-ended tube that's attached to the cecum of the large intestine. Sometimes it's called the vermiform appendix, where vermiform means worm-shaped, so that should paint a pretty clear picture of what it looks like. And this odd, kind of cute little worm-like structure's function is actually unknown, though some theories suggest that it might be a safe house for gut flora, and some evidence seems to suggest that it plays a part in the lymphatic and immune system. Other, arguably more cynical viewpoints think that it's just a useless vestigial organ from our ancestors. Whatever the case may be, the fact remains that it's pretty talented at getting inflamed and causing abdominal pain, a condition known as appendicitis. As much as 10% of the population develops appendicitis at some point, and it's the most common surgical emergency of the abdomen. Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube, like a fecalith, which is a hardened lump of fecal matter that finds its way into the lumen of the appendix and wedges itself there. It could also be other things, though, like seeds that weren't digested, or even pinworm infections, which are intestinal parasites. Another cause of the obstruction, especially in children and adolescents, is lymphoid follicle growth, also known as lymphoid hyperplasia. Lymphoid follicles are dense collections of lymphocytes that get to their maximum size in the appendix during adolescence. Sometimes this growth, though, can literally obstruct the tube. Also, when exposed to viral infections like adenovirus, measles, or even immunizations, the immune system ramps up and these follicles can grow as well. Whatever the cause of the obstruction is, Now the appendix is plugged up, right? Well, the intestinal lumen, including the appendix, is always secreting mucus and fluids from its mucosa to keep pathogens from entering the bloodstream and also keep the tissue moist. Even when it's plugged, the appendix just keeps secreting as usual. When this happens, fluid and mucus builds up, which increases the pressure in the appendix. And just like when you fill up a water balloon, it gets bigger and physically pushes on the afferent visceral nerve fibers nearby, causing abdominal pain. Along with that, the flora and bacteria in the gut are now trapped, right? And intestinal bacteria that are usually kept in check in the gut, like E. coli and Bacteroides fragilis, are now free to multiply. And this causes the immune system to call up white blood cells, and pus starts to accumulate in the appendix. This activation of the immune system can be seen in the lab as an increase in the serum white blood cell count. Patients might also develop a fever in response to the infection, which in combination with right lower quadrant abdominal pain, at the point roughly where the appendix is, known as the McBurney's point, is a super important sign for identifying appendicitis. Also, along with the fever, other classic symptoms include nausea and vomiting. Now, if that obstruction persists, the pressure in the appendix increases even more. At a certain point, as the pressure keeps going and it continues to swell up, it pushes and compresses the small blood vessels that supply the appendix with blood and oxygen. Without oxygen, the cells in the walls of the appendix become ischemic and eventually die. Since these cells were responsible for secreting mucus and keeping bacteria out, now the growing colony of bacteria can invade the wall of the appendix. As more cells die, the appendiceal wall becomes weaker and weaker, and for a small proportion of patients, it gets weaker to the point where the appendix ruptures. Rupture of an infected appendix allows the bacteria to escape the appendix and get into the peritoneum, and patients often experience peritonitis with rebound tenderness, meaning pain when pressure is taken off, again around the McBurney's point. Patients might also have some abdominal guarding, where the abdominal muscles tense up when pressed to try and avoid pain. The most common complication with a ruptured appendix is pus and fluid getting out and forming an abscess around the appendix, called a paraappendiceal abscess. Sometimes subphrenic abscesses might also form, and these would be tiny abscesses below the diaphragm but above the liver or the spleen. The standard treatment for appendicitis is appendectomy, which is a surgical removal of the appendix along with antibiotics. If patients have abscesses, these are also important to surgically drain. Removing the appendix isn't known to have any negative side effects, and sometimes it's removed if the surgeons are already doing an abdominal surgery for some other reason, just to avoid an appendicitis down the road. Diverticula, or a single diverticulum, is this pouch that forms along the walls of a hollow structure in the body, kind of like a cave. Usually we talk about these caves or pouches in the context of the large intestine, so it would be a colonic diverticula. But it can also happen in the small intestine as well as other hollow structures in the body. The walls of the large intestine are made up of several layers, starting with the inner layer, the mucosa, then the submucosa, then muscle layer, and finally the serosa. Sometimes these little outpouches include all the layers from mucosa to serosa, and these are called true diverticula, and sometimes only the mucosa and submucosa poke through the muscle layer, and these would be called pseudo or false diverticula, where the muscle layer isn't included and the mucosa and submucosa are covered only by serosa. Most of the time, diverticula in the large intestine are false diverticula. It's thought that the formation of colonic diverticula is a result of high pressures that literally push on the walls such that they bubble out and form these pouches. Now remember that the large intestine has this smooth muscle layer, right? And it's able to contract using that muscle layer, just like any other muscle we contract, except that we can't consciously control these because it's smooth muscle rather than skeletal muscle. This smooth muscle contraction accomplishes a couple things, like mixing ingested food and moving digested food toward the end of the line. Whenever it contracts, though, higher pressures are generated inside the lumen, since it's sort of like being squeezed and compressing the air inside. And normally you'd imagine that the higher pressure would be equally felt throughout the lumen, right? Well, it's thought that contractions in patients with diverticula are exaggerated or abnormal in some way, which causes an unequal distribution of pressure, with some specific areas having really high pressures during these contractions. It's not quite clear exactly what leads to these abnormal contractions, but some studies suggest it might have something to do with the smooth muscle itself. Now let's take a step back and think about something called Laplace's law, which says that the pressure on the wall of a cylinder is proportional to the inverse of its diameter. So as diameter decreases, pressure increases. In other words, a really small cylinder is going to feel a lot more pressure on its walls than a really large cylinder. Similarly, since the sigmoid colon is the smallest portion of the colon in diameter, it's subject to relatively high pressures according to Laplace's law, basically the spot in the large intestine where the walls get pushed on the hardest. The sigmoid colon is therefore where most diverticula form. Additionally, diverticula tend to form in the spots where the blood vessels that supply the intestinal walls traverse the muscle layer. This spot is slightly weaker, making it more likely for diverticula to form. As that diverticula forms, that blood vessel responsible for wall weakness becomes separated from the intestinal lumen only by mucosa, and is therefore subject to injury and predisposed to rupture, meaning blood gets into the large intestine, which would then be passed to the stool. And this is known as hematochezia, or rectal bleeding, but this bleeding is usually painless. Other associations with diverticula include things that either increase the stress of the walls of the intestine or decrease the strength of the intestinal walls. Fiber helps stool move more easily through the colon, so diets low in fiber can lead to constipation and make it harder for the colon to move small, hard stool. Having said that, the exact relationship between fiber and having diverticula, with or without symptoms, is not very clear, but dietary fiber is associated with a decreased risk of symptomatic diverticular disease. And on the flip side, a diet high in fatty foods and red meat is associated with an increased risk of symptomatic diverticular disease. There are also genetic causes of diverticula, like Marfan syndrome and Ehlers-Danlos, which are genetic disorders that affect connective tissue. Without strong connective tissue supporting and strengthening the colon wall, diverticula can begin to form. Having diverticula in the colon is called diverticulosis, and most of the time people won't even know that they have diverticulosis because they don't have any symptoms. Sometimes people with diverticulosis have vague stomach pain, and occasionally the diverticula might bleed, but most of the time when there are no symptoms, diverticulosis is discovered through a colonoscopy or CT scan that might be done for another reason entirely. Sometimes, though, the diverticula can become inflamed, and this is known as diverticulitis. Itis meaning inflammation, right? Although inflammation can happen when fecal matter, or fecaliths, become lodged in the diverticula, this is thought to actually be less common, and really inflammation is thought to happen more often due to erosion of the diverticular wall from higher luminal pressures. Erosion and inflammation most commonly causes pain in the left lower quadrant. Diverticulitis is usually not associated with hematochezia, or rectal bleeding, since the blood vessels become scarred from inflammation, and therefore rectal bleeding is more associated with diverticulosis. Sometimes, if the diverticula become distended enough, it might rupture and form a fistula, which is a connection with an adjacent organ or structure. Since it sits pretty close to the bladder, a fistula connecting the large intestine to the bladder might form, called a colovesicular fistula, and this might result in air or stool in the urine, which, as you might imagine, is not a good thing. Treatment for diverticulitis might involve antibiotics to limit bacterial overgrowth, and some might recommend a high-fiber diet after patients have recovered. In more severe cases, though, the affected area of the colon might be surgically removed. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Irritable bowel syndrome, or IBS, describes a pattern of recurrent bouts of abdominal pain and abnormal bowel motility, causing things like constipation or diarrhea, or a mixture of the two. And oftentimes the abdominal pain improves after a bowel movement. Although it sounds similar, IBS is different from inflammatory bowel disease, or IBD, which involves some of the same IBS symptoms, but also includes inflammation, ulcers, or other damage to the bowel, whereas IBS does not involve these, and instead can be thought of as a functional disorder. Right now, the underlying biological mechanisms that produce the symptoms of irritable bowel syndrome aren't well understood, so most research is focused on these key symptoms: abdominal pain and abnormal bowel motility. With regard to abdominal pain, a lot of people with irritable bowel syndrome have visceral hypersensitivity, which means that the sensory nerve endings in the intestinal wall have an abnormally strong response to stimuli, like stretching during and after a meal. This visceral hypersensitivity might explain why people with the disease experience recurrent abdominal pain. With regard to abnormal bowel motility, the underlying mechanism is a little less clear. One clue is that eating foods that have short-chain carbohydrates, like lactose and fructose, often trigger the symptoms. One possible explanation is that unabsorbed short-chain carbohydrates act as solutes that draw water across the gastrointestinal wall and into the lumen. In addition to triggering visceral hypersensitivity, which causes pain, that excess water can also cause the smooth muscles lining the intestines to spasm, and create diarrhea if the excess water is not reabsorbed back into the body. To make matters worse, the unabsorbed short-chain carbohydrates are often metabolized by gastrointestinal bacterial flora, which produce gas that could trigger even more bloating, spasm, or pain. Now, there are also epidemiologic clues as well. For example, in North America, irritable bowel syndrome is most common among middle-aged women, but in other parts of the world it affects both sexes equally. Also, one important risk factor is having a bout of acute gastroenteritis, for example from norovirus or rotavirus. But also another risk factor is being stressed, and both of these seem to be triggers for developing irritable bowel syndrome in many individuals. Since the mechanism behind irritable bowel syndrome is still unclear, most treatments target the symptoms. This includes things like diet modification, like avoiding certain foods like apples, beans, and cauliflower, all of which have short-chain carbohydrates. In addition, to treat constipation, soluble fiber, stool softeners, and osmotic laxatives can help. Whereas for gastrointestinal spasms and pain, antidiarrheals like serotonin antagonists and antimuscarinic medication can help. Finally, managing things like stress and controlling feelings of anxiety and depression can all help symptoms of irritable bowel syndrome. Okay, as a quick recap, patients with irritable bowel syndrome have recurrent abdominal pain with constipation or diarrhea, or a mixture of the two, and the pain's usually relieved after bowel movements. The underlying pathophysiology, though, isn't well understood, but seems to be related to visceral hypersensitivity and abnormal bowel motility. And triggers or risk factors include short-chain carbohydrates, bouts of acute gastroenteritis, and stress. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Anal fissures are longitudinal tears in the anal mucosa under the dentate line. Since this region is innervated by somatic nerves, anal fissures are often quite painful. Now, there are two types of anal fissures: typical or primary fissures caused by local trauma, and atypical or secondary fissures which are associated with some other condition, such as Crohn's disease. All right, the first step when approaching a patient with signs and symptoms suggestive of an anal fissure is to obtain a focused history and physical examination. Patients with typical or primary anal fissures usually report severe anal pain that might be present at rest but worsens during defecation and may persist for several hours. Additionally, they might report anal bleeding or hematochezia. History might reveal local trauma, such as constipation and passing large, hard stools. On physical exam, typical anal fissures usually present as superficial lacerations located in the posterior midline. Less commonly, they can be seen in the anterior midline or in both the anterior and posterior midline. Similarly, individuals with atypical or secondary anal fissures usually report anal bleeding and pain that's present at rest but worsens during defecation. History typically reveals chronic, multiple, recurring, and non-healing fissures. On physical examination, you may see multiple wide, deep fissures that are healing poorly. In contrast to typical fissures, atypical fissures are found in locations other than the midline, often the lateral region. Additionally, a patient might have perianal skin tags, which are remnants from previous bouts of inflammation. In some cases, perianal skin tags can become edematous and painful. All right, now that you've obtained a history and a physical examination, let's move on to the management of typical anal fissure. Individuals with typical anal fissures are initially treated with supportive care, which includes stool softeners, sitz baths, and a fiber-rich diet, with or without topical analgesics. If this initial treatment doesn't help, you should continue supportive care and add topical calcium channel blockers like nifedipine or topical nitrates. These can help relax the smooth muscles of the internal anal sphincter and promote healing. Now, most typical anal fissures will heal with this treatment. However, if the healing is inadequate and they continue to have symptoms, you should consider that this might be an atypical anal fissure and do a colonoscopy or sigmoidoscopy to look for secondary causes. If the cause is identified, treat the underlying cause. If not, consider consulting the surgery team for botulinum toxin A injection, lateral internal sphincterotomy, or anal advancement flap. Okay, let's move on to the management of atypical fissures. Just like with typical anal fissure, start with supportive care. This alone usually won't be enough since the underlying secondary cause is not addressed. So in this case, you should also order a colonoscopy or sigmoidoscopy. Colonoscopy should be done for patients who have risk factors for colon cancer, such as age over 50 and a family history of colon cancer. All others can undergo a sigmoidoscopy. If you find an underlying cause that can be associated with anal fissures, such as Crohn's disease, make sure to treat it. However, if there is no underlying cause, consult the surgical team for possible interventions. This could involve injecting botulinum A toxin into the anal sphincter to help relax the tense, hypertonic anal sphincter muscle and, in turn, improve healing in chronic fissures. On the other hand, a lateral internal sphincterotomy involves cutting internal anal sphincter muscle fibers up to the apex of the fissure or the dentate line. This reduces the pressure created by the internal sphincter, increases blood flow, and promotes healing. Lastly, an anal advancement flap is an alternative to a lateral internal sphincterotomy in patients who are at risk of developing fecal incontinence. During this procedure, a skin flap is created from the skin around the anus and used to cover the fissure. All right, as a quick recap, anal fissures are a common cause of bleeding and severe anal pain. Individuals with typical or primary anal fissures can typically be treated with supportive care, such as stool softeners, sitz baths, a fiber-rich diet, topical analgesics, and possibly topical calcium channel blockers or topical nitrates. If there's no improvement, order a colonoscopy or sigmoidoscopy to identify an underlying cause, such as Crohn's disease. If no cause is identified, you should consult surgery. For atypical or secondary anal fissure, also start with supportive care, but also do a colonoscopy or sigmoidoscopy right away to identify the cause. If the cause is identified, treat the cause. If not, obtain a surgical consultation for a botulinum toxin A injection, lateral internal sphincterotomy, or anal advancement flap.